वर्किंग? ठीक है.
नहीं
But
आया,
Arvind, how we are going to share the result?
आया क्या मेरे को? अच्छा दे दी. एक्सेप्ट तो मेरा हो
ठीक है. अरविंद रिजल्ट दिखाओ. तब तो वहां से करना पड़ेगा.
क्या हो गया पटना रांची का?
वहां से करो, यहाँ पे रखो एक बैकअप, वहां से करो. अरविंद एक दूसरा लैपटॉप लेके उससे स्विच करना, क्या बोलते हैं ये, इससे रिजल्ट के लिए. मैम आया, जस्ट 1 सेकेंड, एक थोड़ा सेटिंग बाकी है, जस्ट टू रिजल्ट. हाँ, लखनऊ ऑन द कैमरा एंड वीडियो यार.
पटना मिल गया है इंटरनेट.
ओके, पटना रांची इशू है. Yeah, ma'am, see that this result. Result only voted by 5 people. Why not everyone? Again, we will start testing to vote everyone, every location. थोड़ा फिर से उनको देते हैं, 3-4 बार टेस्टिंग करेंगे ना तो they know, they will explain to doctor.
QR कोड है.
Accepted vote हो गया ना. अभी फिर से नेक्स्ट क्वेश्चन आएगा तो आएगा, यही एक्सप्लेन करना.
अरे देखो डेस्क पे रखा होगा क्यूआर कोड, हर टेबल पे क्यूआर कोड है.
हाँ, टेबल पे जो QR कोड है उसमें से सिर्फ क्वेश्चन रेज कर सकते हैं. ये जो क्विज नहीं दिख रहा है मुझे, आई एम अनेबल टू सी द क्विज.
सर क्विज अभी बंद किया, अभी नेक्स्ट क्वेश्चन पे जा रहे हैं. अरविंद नेक्स्ट क्वेश्चन कर.
क्यूआर कोड पे स्कैन करने के बाद
नेक्स्ट क्वेश्चन पे जा रहा हूँ. हाँ देखो.
This event underscores our commitment to advancing pediatric medical education in India. This year's summit features an interactive case-based CME program which is being live streamed to 22 locations across India with over 2,000 pediatricians participating. We are honored to host distinguished faculty from India, including the esteemed Dr. Y.K. Amdekar sir. Our speakers include Dr. Vijay Yavale, who is also the chief coordinator of this session, Dr. Rajesh Chokhani, Dr. Bala Subramanian, Dr. Prakash Vaidya, Dr. Jagdish Chinappa, Dr. Upendra Kinjaurekar, and Dr. Sham Kukreja from Copenhagen. Before Dr. Yavali takes over, I invite our faculty and Alchem senior members, Argha sir and Vikas sir, to join us for the Saraswati Vandana and lamp lighting ceremony. Thank you. I'm Dr. Amitrajit Pal, and let's embark on this day of learning and collaboration.
कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परं ब्रह्म दीपज्योतिर्जन दीपज्योतिर्परं ब्रह्म दीपज्योतिर्जनार्दन तुम्हे पापं सन्ध्यादीपनमोऽस्तुते ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुराव्ययम् ओ दीप ब्रह्मरूपस्त्वं ज्योतिषां प्रभुराव्ययम् आरोग्यं देहि पुत्रांश पतिं स्वच्छामि मे सदा तवेरस्तं समारभ्य तावत् सूर्योदयः तवेरस्तं समारभ्य तावत् सूर्योदयः
So now I want to welcome our session moderator and chief coordinator for today's session, Dr. Vijay Yavale. Dr. Vijay Yavale sir has been the IIP president 2014, head of Apollo Children's, Navi Mumbai, director and consultant of Dr. Yavale's multi-specialty hospital for children, Navi Mumbai, and editor-in-chief, Pediatric Infectious Disease, the Journal of IAP ID chapter. Welcome, sir. I will request you to share a few words.
Very good morning, friends. Respected Dr. Amdekar, my friends Rajesh, Jagdish, and Upendra, my friends present here physically, all my fellow colleagues who have connected with us virtually, a very good morning to one and all. And I'm extremely happy to be here once again for the annual Accord session. I really enjoyed doing this session because this is one event where there is absolute freedom of crafting the scientific program, and there is no pressure and there is no interference by the sponsors. And we have a long day to go today. We begin with a case-based interactive session conducted by Dr. Amdekar and Dr. Rajesh Chokhani. They would be talking about diagnosis based on evidence and experience, or evidence or experience, followed by a small talk on What's New in Enteric Fever by Dr. Bala Subramanian is yet to arrive. He'll be joining us very shortly. And then we have a small tea break followed by yet another interactive session on our day-to-day common problem issue of managing a child with respiratory complaints. Then we break for lunch. Post lunch, we have a very short talk on newer paradigms in nutrition.
Good morning, respected doctors.
Very practical.
Now, welcome to the Accord Pediatric Summit
very
2024
practical
presented by LPS.
solution for
Now,
pediatrician.
sir,
and not
let
for
us join us for the
dietitians.
Saraswati Vandana
Yes,
and
overall,
lamp lightning.
Dr. Anil
President,
Kumar Gulati is a
IIP
pediatrician in
2023,
Saket
Dr.
and has an
Upendra
experience of
We'll be talking on that. And then we wind up with yet another interactive session on various dilemma that we face in practice, where I have Dr. Bala Subramanian and Dr. Sham Kukreja, who would be joining us virtually from Denmark. And we would really solicit interaction from all the audience, so that at the end of the day, we really have some carry home tips. Without much ado, now let's get on to the scientific program. We have 22 centers connected with us. We'll be interacting with a few of them as we move along. With these words, I once again thank the sponsors, Alchem Laboratories, and once again welcome you all for this scientific deliberation. Thank you.
So now I'll request presentation of a bouquet and mementos to our esteemed speakers. Thank you. To Dr. Vijay Yewale, sir. So I will now request Dr. Vijay Yewale, sir, to take over
Now, I
the
request
session.
our colleague Gopal Kapoor to honor our senior.
I think.
Sir, please come.
Amin. I think let's start with the first session now. We'll start with the first session.
Okay.
Yeah, with this, let's start with the scientific sessions. I invite Dr. Amdekar and Dr. Rajesh Chukhani to take over and begin the first session.
So the first session for today is diagnosis based on evidence or experience. It's an interactive case-based discussion, and the sessions will be taken by Dr. Y.K. Amreka, sir, who has been practicing for the last 50 years, visiting consultant to SRCC Hospital, Mumbai, has been teaching faculty at Grant Medical College and JJ Group of Hospitals, Institute of Child Health, Mumbai, and past president of Indian Academy of Pediatrics. Dr. Rajesh Chokhani, sir, consultant pediatrician, Hinduja Hospital, Mumbai, president of IIP, Mumbai 2023, examiner, MRC PCH, Royal College, UK and DNB FCPS DCH exams, and faculty for various conferences at the international and national levels. So I'll request our esteemed speakers to take over the session, sir.
Good morning, friends. First request to please occupy the front seats because it's going to be interactive and I don't want to run across the whole hall. So please come right on the front. We are small in number. We can discuss together. Be close. Yeah, thank you very much. I think it's as usual. We would be doing an interactive sessions and please raise your finger. We will get the mic to you and let everybody contribute to thinking. And it's like a steer program. Okay. Today we are doing something little different because I thought today's in an era where everything has to be evidence-based. While that is so correct and that's the way to go forward, there are limitations of that as well. And therefore, we thought that we will discuss cases where you will be really putting up your views on how much evidence you gather, or at some stage you say, let me go by my experience. Okay, I'm sure we all meet such things. And therefore, today's discussion is largely based on evidence or experience. Okay. I am aware that experience has its own limitations, and experience is also defined as an ability to make the same mistake again and again with increasing confidence. So I'm aware of that. I need to be very, very cautious about that kind of a mistake. At the same time, evidence is not easy to get, and absence of evidence is not a lack of evidence. So again, we have a problem. So there is no real divide between evidence and experience. Okay. There are two sides of the same coin. A problem arises when differing values are attached to these components. Some people will say, oh, evidence is a must. Somebody will say, what evidence? Experience is must. We are giving different values to these two, but that is not right. And therefore, evidence in clinical practice is based on tests that offer proof, but tests are of different strengths. And evidence is also of different strengths. Okay. The last and the worst evidence, we call it evidence, is anecdotal experience. So we are fooling ourselves. We'll call it evidence grade 5. Don't call it evidence. It's no evidence. But we will still grade evidence. And I think, as I've already said, that evidence may not mean active disease. My laboratory test is abnormal, but I am fine. Okay. Such things do happen in clinical medicine. And therefore, evidence, yes. And what is experience? It's a clinical judgment that involves decision making, depends upon the appropriate application of knowledge and individual expertise, needs skills, and most important, open mind to avoid bias. Okay. So you can see that we need both. Okay. And after all, the clinical judgment is the key component of evidence-based medicine. Okay. If you have no clinical judgment, what evidence are you collecting? When there is a theft, first you need to think who could be the thief and then start searching. You can't search all over. So basically, again, the clinical judgment is the key, and two are inseparable. That's the only way to deliver best care. Having given this idea, we will apply this to every case scenario. They are not virtual cases, actual cases that we have seen, where we were to debate whether should we go further for evidence or treat the child and get him well. Let's start discussing those cases.
Good morning, everyone. As we all know, this is a voting-based discussion to make it more interactive. So we will first read out the case vignette, then we'll give the options at a certain point, And all of you have a scan code on your table, both in Mumbai and all our friends from various centers out of Mumbai. So please scan that code so that you get the question and the options on your mobile. And then you have to click on the correct option and it will get registered here. And then we will discuss why everyone voted for the different options. And that's a very good way to learn.
The same thing.
There's no need to refresh. The questions will keep coming on the same link when the next case or the next voting is asked for. Okay. So with that, let's start with the first one. So a 2-year-old healthy child presented with fever, cold and cough for 2 days. On examination, the child is not sick and there's no other localization. There are no positive findings. Okay. Now, in this scenario, the options for us are no tests, counsel the parents. Second, CBC, peripheral smear and CRP. Third, a fever panel. Now, there are various types of fever panel. Each lab has its own fever panel. For blood investigations, some include SGPT, NS1. They've also started doing a multiplex fever panel. And the fourth option is multiplex PCR for respiratory infections. So now, if the options are on your mobile, please choose the correct option. And then we will discuss why somebody feels this option is right or that option is right. All our friends outside Mumbai also, please select the correct option and vote. Okay, so I think most of you who are present have already voted. Some are still voting, but the leading choice is no tests, counsel parents. So since this is a question of evidence versus experience, question to those who voted for no tests is, don't you want evidence?
And no test is fine. What counsel? You counsel to say, I don't know. What is counseling? No test, no treatment. Then what counseling? Would somebody say, what counseling?
We counsel saying that this is probably viral and may take its own course. Nothing much to be done unless the child gets any kind of warning symptoms.
Anyone else?
The point is that the child is not sick and a healthy child and a short duration of commonly seen infections. So we can convince or counsel the parents that, as Kulkarni sir said, that this is a common infection with your healthy child, no localization. So just wait and watch.
So the question is, what is the evidence in favor of this being a viral infection or this being
No
a
evidence.
harmless infection?
At least do some tests and make sure there is nothing serious.
If there is any
When you
family-
said this is viral, at this point, what is the evidence that this is a viral infection?
Rajesh here.
The child at present is not sick. Fever, cough, cold are again common symptoms of a viral fever or a viral prodrome or anything, and there is no localization. Child may be playful interfebrile when there is no fever. Well-grown child, no other red flags. So that's in favor of viral fever at present.
Same, sir. So the child they have mentioned that it's a healthy child. So if the child is playful, active, and during the interfebrile period, this is what we counsel the parents, then it's most likely to be a viral infection.
I'm sure all of you agree to that. My question as a parent is, Doctor, are you sure there will be no problem? That's my question.
We have to.
I'm not worried whether it's a viral, bacterial, which antibiotic, no antibiotic. I'm not worried as a parent. I want to know whether my child will end up with something else. That is what the counseling is. Counseling is not what is the diagnosis. Diagnosis is doctor's problem.
Exactly. I was trying to say the same thing, that the counseling is related to the fact that we are not currently looking at anything which is complicated, but these are the red flags that I would like to explain the parent. And if those are present, then I would like to see the patient once again.
Absolutely. So we need to counsel with red flags. And I tell the parents that when there are dark clouds, it's likely to rain heavily, but don't open the umbrella. Okay. Be ready, but don't act. And what may happen? It may suddenly start pouring. Okay. But sir, we may not have time to open the umbrella. No. It's not that bad. You can always do it. So that is important. Yes.
If there is family history of any viral infection in the family, then we can be little sure that it's a simple viral infection, maybe.
Yes. Sure.
A very small minuscule did vote for CBC, peripheral smear and CRP. Can anyone tell us why? Anyone in this hall wants to discuss why?
An IVF baby or something and they're very scared, then they may opt for certain surety with the test.
Madam, every mother is worried, IVF or otherwise. So would you do CBC for everyone?
So the next question is, suppose you did CBC, peripheral smear and CRP. Will you get infallible answers?
No.
You will not.
So counseling will include that at this point of time, any test is unlikely to give me a definite answer. So as she said, please look at whether the fever gets worse, any new symptom arises, whether baby is breathing fast, not feeding well. If so, please run back to me. We will decide. And add on to say that if we pick up such early warning, we will be able to correctly treat. Don't worry. So there's that. This is what most of us will do. Of course, there is nothing like a fever panel, and I don't know why people do SGPT at all. Jagdish, do you do SGPT for fever? I don't know. What is the idea?
No, sir, I don't do. But again, here what I would say is my approach would be a little different. I think we are used to a paternalistic point of talking to parents. That is, you have come with a problem and I'm telling you what is the best option for your child. But that's not what really is the ideal method. The ideal method is to put the facts to the parent, tell them, see, this child is a well healthy child. This child has had an acute illness. In my experience, all this is suggestive of a self-limiting infection. It could be whatever it is. But at the end of the day, both parents and you have to be on the same page. They should accept what you're saying. And they should be on the same page, and both of you are in the best interest of the child. Because the moment you tell them something like, do a blood test, the anxiety level goes up. We don't know what to do with those tests, and the parent doesn't increases his anxiety, thinking that it could be something more serious. So I think the very fact of asking for a test itself produces anxiety in a parent. So the best thing to do here is to say, I've gone down this route many times. I know what this is in all probability. So I think what you do is to just follow these instructions and come back if there's something that goes wrong. I think building trust and taking a shared decision making for the child is extremely important.
Fine. So we have all decided to go by experience and logic. Even when evidence is possible. Okay. We have chosen experience over evidence in routine clinical situation. Let's see what happened thereafter. Same case.
This child developed fast breathing on day 3 and the fever was better. On examination, did not look sick, but there were subcostal retractions, bilateral V's, and SpO2 was 93. Now at this point, the options are chest X-ray, oxygen and nebulized salbutamol and observe, Second option is in addition ABG and multiplex PCR. Third option, in addition broad spectrum antibiotic and antiviral. And fourth option, in addition ICU admission. So now at this point, again, choose whatever option you think you would do. Same is for our online friends. Please choose the option which you think you wish to select, and then let's see. Okay.
We are all too rational, looks like. I hope it's not an rationality to an irrational extent. Okay. We want minimal intervention. In the first slide, we said do nothing. Even when there are problems, you say just oxygen, nebulization, and wait.
Okay. Now we did have again a minuscule who even voted for ICU admission. So
I do an ABG, no? He's in distress.
So I'll request Delhi to come in, and if any delegate at Delhi wishes to discuss anything other than option A, as in if you want to argue for option B, C or D, please come in Delhi.
No, actually, I feel that option A is the most appropriate.
We can't hear. One sec.
As in, now I'm basing my experience on evidence. Likely, it's likely to be, we are heading towards bronchiolitis, as this says. So we will rather observe at this stage and see how the things go further. And at this stage, an X-ray will give us an information about if there anything surprising for us there. And at the same time, oxygen will be enough for seeing that 93% oxygen saturation can be pulled up, and nebulization with or without salbutamol should be enough.
Thank you so much, sir. Thank you very much, Delhi. So fine. So again, we have in this same case, even after this new development happened, we have opted for our general judgment, which is experience more than evidence, whether we are headed for anything bigger in terms of trouble. We move on to the...
Be very sure that he is not looking sick, fever is down. Okay, bilateral wheeze, looks like a hyperreactive airway triggered by the viral infection. We just treat symptomatically and then expect an improvement, right? But these options are really followed. Such patient, this very patient was admitted in ICU, ABG was done, multiplex molecular study was done. At the end, the child got all right within 48 hours with oxygen and nebulization, but parents went home after spending 2 lakhs of rupees. But child was all right. Some people may feel happy that doctor took so much of care, that every test was done and nothing was left to the doctor's brain or experience or evidence. Okay. I was wondering, even a death is now today certified without evidence. When do you get evidence of death? Clinically, you say he is dead, certified. Okay. Even the death is certified by experience, and without evidence, you leave this earth without evidence. Okay. So this was a real case, and therefore, I am very happy all of us have thought about it, right? Everything is possible in medicine, but still experience, the logic, some guesswork, and being truthful to say, even at the end of that, I may be wrong, but I am very watchful and I correct my mistake in time. That is all that the parents want, right? Let's look at another case.
So an 18-month-old child presented with high fever and crying for 3 days. On examination, the growth was normal, vitals were stable otherwise. The baby child was irritable, there was no localization, otoscopy was normal. The options are CBC, CRP, urine analysis, and decision after test results. In addition, hospitalize CSF and manage as per reports. In addition, start IV ceftriaxone. And in addition, acyclovir and artemether. So think, what do you think you would do or you would choose, and vote for that. Yeah. So I think majority again want to do CBC, CRP, urine analysis and decide. So basic first line investigations for a febrile child who's crying or who's irritable. But a few did opt for CSF and hospitalize.
Who will opt for CSF and justify it? Here is a child who is crying. He is a young child. He could have a meningitis. You can't miss it. So who will opt not to do CSF?
Sir, one sec. So Chennai, can you come in now? Does any delegate from Chennai wish to discuss why this child should be hospitalized and CSF should be done? With a justification, clinical analysis and justification.
No, here we have a child, 18-month-old child, high fever, crying and irritable. Since we can think of other infections, one can be viral fever, it can be ear infection or UTI. But since there is a crying child, irritable, we should keep in our mind about meningitis and we should tell them the red flags and need follow-up.
Thank you. A question to you, just to stimulate further discussion. In an 18-month-old child with bacterial meningitis, would you expect something else at the end of 3 days besides high fever and crying?
Meningeal signs I have to see, sir.
Okay. Anyone here in Mumbai?
Vomiting and headache.
Yes, sir. Thank you so much, sir. Thank you. Yeah. We'll take the discussion further.
You would also expect vomiting, and there could be lethargy also, because meningitis you suspect, there could be crying, but more than that, I would expect you would be lethargic, and clinically there could be meningeal signs also. And sometimes if it is meningococcal, then could be some rash or that kind of thing also can appear.
Okay.
Drowsiness between the irritability as well as seizures can be the presenting thing.
You have not told us whether the crying was inconsolable or the child was consolable.
So it's a very prominent crying, irritable all the time, crying all the time.
And I think if this child started with fever, irritability together and has remained the same over 3 days, there is no change, either worse or improvement. Looks like that it is not a fastly progressive disorder. That's what the meningitis would have been. And therefore, the first impression would have been it's a persistent disorder, but not fastly worsening disorder, which puts us to say very unlikely meningitis. CBC will not make us sure whether we should do CSF or not, because anyway, there could be some neutrophilic leukocytosis, and therefore, yes, we will do it because that might push us in favor of one or another. Urine examination, yes, of course. And therefore, majority of you felt, and so also we felt, that we would look for some other diagnosis rather than do a CSF, etc., and watch carefully. Again, counseling becomes important. I think whenever we wait for the evidence to be gathered, a counseling is a must. And I think most of us do not have time to counsel. Okay.
Sir,
We make same mistakes of either doing or not doing, but we make a mistake of not counseling. And I think that is where it is. So let's.
Sir,
let's look at,
Lucknow wants
so
to
what
come in,
is
sir.
the
Lucknow.
probable diagnosis?
Yes, Lucknow, please come in.
Sir, in this case particularly, history of vaccination is very important. In case the vaccination has not been done, I think CSF should be done on priority.
Sure, sir. Point noted. So now, in this child, WBC count was 18,000 with 72% polys, and that was the rest of the differential. And other tests like urine, etc., were inconclusive. CRP was also inconclusive. So now what do we do next? What is your interpretation from whatever evidence we have got?
As there is a high fever and some kind of crying and WBC counts are high with polymorphonuclear leukocytosis, I would suspect could be a bacterial infection. So urine test is important here, rule out UTI. And if at all I suspect a pneumonia, I would do a chest X-ray and rule out a pneumonia also. First, these two tests would be done.
Okay. So just to complete, urine was showing 10 pus cells, nitrites negative and LE negative, and culture has been sent. Now, anything else? So where is this infection? Where is this bacterial infection? Take into account that it's a 18-month-old child who has been treated symptomatically for the first 3 days and who has the only symptom of excessive crying and fever. Otitis we have checked and it's
whatever CRP you want, it's 100. What will you do? So again, CRP not there or there won't change your thing.
This type of a picture with a polymorphonuclear leukocytosis with WBC, it need not tell us that it is a bacterial infection. This can be just a systemic inflammatory response.
Absolutely. In which CRP is also high. So CRP will not tell us anything.
Normal or negative CRP will negative predictive value.
Normal CRP is unlikely in this child. And if it is there, then we will say, no, we will repeat it. We will see what it is. So again, the point is, even a CRP won't differentiate our action.
So, Kamlakar, the practical question is, suppose CRP is normal in this child. Is it strong enough for you to say, okay, I'm not going to treat this child with a bacterial, with an antibiotic? Correct. But in terms of action, means what I'm saying is a negative CRP or a normal CRP good enough to give you the confidence to withhold an antibiotic on its own merit is the question.
No, Rajesh, since you have done the CRP and the CRP is high, I would most closely examine the musculoskeletal system because joint infections can get missed out that way. And a CRP high is a pointer to them.
See, CRP high and low is a relative term.
Yes, sir.
And 70% likely, that means 30% not likely.
No,
Okay.
it's not
So then don't you want an evidence further?
No, it doesn't.
Okay. What we feel is when you say CRP is higher in bacterial infection than in viral, but what is high and what is low is relative.
Talking in this context
Okay.
where CRP was done in any case. Having done that, if you get a high CRP, look very closely at a joint problem.
You should do blood culture. The point we wanted to make here is that, as sir just said, whether you do a CRP or you don't do a CRP, whether it is high or whether it is normal, in this and many such scenarios, your action does not change just because of the CRP. This is the point we wanted to make.
I have a comment to make. While I
No, they have to ask me, no? Ask anybody.
While I agree that CRP as a standalone test has no value, but if you put it together with the clinical background and clinical history examination, a A negative CRP would give me more confidence of waiting and not starting an antibiotic.
So, Vijay, means I have been always I'm trying to understand this issue because I'm the only fool who hasn't done a CRP for last 30 years and still survived. So my question
just to elaborate further, suppose this 18-month-old child who's been having fever, of course, high fever is unlikely in bronchiolitis, but very often an 18-month child with respiratory, hypoxic child would present with excessive crying. And if he has a negative CRP and high count, I would be confident to withhold antibiotic unless I have more evidence. Yes,
with this
we have seen count of 20,000 and 25,000 with normal CRP.
No, we have
clinically viral looking, and we have not started antibiotics.
I think in this scenario, when you have a viral bronchiolitis, that's not an issue. The issue is this child. Okay.
I would like to do a chest X-ray and throat examination first. Examination of throat to rule out tonsillar infection. And
Tonsillar infection, we would have known. Yes,
Sir,
we
I
would have
think-
seen that.
I think we have said that there is no localization. So we assume that a good physical examination has been done and ruled out. But if at the end of this scenario at 18,000 counts, if I'm still inconclusive, the fever, high fever and crying still persists, then I would surely like to do a blood culture. I would also think of starting an antibiotic with such high counts. But before I start IV ceftriaxone, I would surely want to do a CSF at this stage.
I think question is 3 days of persistent fever, inflammation, high count. Do you expect a normal CRP 0?
Sir, while a CRP cannot be used as a basis, as a peg to hang your antibiotic therapy on, a high CRP does alert us.
No, tell us in this child. I give you 40, 60, 80. What will you do?
It could be either way.
Same thing, no? But that's the point I'm making.
But if it is high, it might help us to look for a bacterial problem.
Sure,
greatly
we'll
like a joint swelling.
let's go ahead. Sir, we'll go ahead.
Okay. So look for bacterial means what? Blood culture, no? Fine. But CRP, irrespective what number is, blood culture will be done, right? So that is accepted. The point we are making is we are doing CRP because CRP is there to do. Okay, if I ask you, if I don't do, no, but I will do the same thing. That is what it is.
I think
Okay.
anybody from Patna Center will like to ask any question? Please.
From Guwahati.
Unmute ho gaya. Excuse me. That
Yes, come in. Yes, come in.
yeah, from Patna. I'm Dr.
Patna, come
Jaswal.
in.
Yeah, I'm Dr. Jaswal. I'm one of the attending person. Doctor is asking some questions related to that. Please go ahead.
Good morning, sir.
Good morning.
Sir, this child is 18-month-old and high fever with a crying since beginning. So such a count. I think of a non-infective inflammation like Kawasaki and leukemia. Can it be possible?
Okay. Very good suggestion that if this child has not localized so far and has signs of inflammation, whether it is non-infective inflammation like Kawasaki or leukemia. Now, leukemia is ruled out from those blood counts. I mean, those blood counts don't suggest a leukemia. Everything differential, etc. is normal. Yeah. But Kawasaki definitely stands. Thank you. Guwahati.
So there is one question from Delhi.
One sec. Guwahati has been waiting for a while. We'll take Guwahati. Maybe Delhi we can take in the next case. Guwahati,
yes,
please
sir.
come. Yeah.
Yes, sir. A child is 18-month-old and only sign is that only symptom is crying excessively. So I will think Kawasaki disease obviously. So I will go for CRP. If CRP is high, then I will think of Kawasaki and look for other evidences. I may do one echo as well.
Fine, we'll move further. This was a Kawasaki. Okay. The point is neutrophilic leukocyte results. How did you go by clinical correlation? None of those tests in isolation or even together can make us finally use experience. Okay. And what evidence for Kawasaki? No evidence. Okay. Science has advanced so much. We talk about typical Kawasaki, atypical Kawasaki, incomplete Kawasaki, and we are incomplete in evidence. But still, era is a modern era of evidence medicine, right? So first case, no evidence. Second case, also no evidence, even when complicated, right? Let's look at further.
Move to the next case. 10-year-old healthy child presented with high fever for 2 days. Amoxiclav was started on day 2 itself by the family physician or whoever was treating. Afebrile next day and one more day. High fever recurred on day 5, and now this child has a left thigh swelling and pain. The antibiotic was still on. On examination, there are local signs of inflammation. So it was considered osteomyelitis. WBC count is again 18,000 with 80% polys. But they went on to do a MRI which said suggestive of osteomyelitis. The first set of antibiotics failed, so a second upgrade choice was taken, which also failed. The child remained the same, but otherwise stable on day 15. It's now 15 days with so many days of antibiotics. Options are repeat CBC before further decision. In addition, blood culture. In addition, bone biopsy, including culture, and withdraw antibiotics for 3-4 days and observe.
First time we are looking democratic. Every option is possible. Okay.
Okay. So I think the house is divided with everyone thinking of different possibilities. So let someone who chose option C, in addition, bone biopsy, including culture, please defend why you wish to do that. Anybody from this house?
So here you have a child who has been definitely diagnosed with osteomyelitis on MRI. His febrile, his neutrophilic leukocytosis he has, and is not responded. So, and I would certainly would want to know if possible, one is drain the collection and get some culture report on that pathogen. Okay.
Nashik, do you want to come in at this stage? Does anyone want to discuss any of the options from Nashik?
Am I audible, sir?
Yes, yes.
So definitely we would like to reevaluate this patient because it is persistent problems. We would definitely repeat a CBC and a blood culture. I would also like to get a culture of the fluid if possible, since it is persistent. So definitely we'll have to reevaluate.
Okay.
Sir, may I come in? From Nasik only, Dr. Ramakant.
Hi, hi.
Hi, sir.
Come in.
So here the experience will be over the evidence, because if patient is on day 15 stable, so I just want to know whether, going by my experience, is going to cause harm to this child. If waiting is not going to cause harm, I will like to wait, since child is on day 15 stable, otherwise stable. So whether this MRI is really suggestive of osteomyelitis, what does it mean by osteomyelitis on MRI? Whether there was definite collection, whether there was joint involvement, or it was just like a periosteal reaction. So probably I may be able to have withdrawing the antibiotic, whether it was some inflammatory condition. Otherwise, this child is less likely to have cafe disease, which may mimic osteomyelitis. But I will like to withdraw antibiotics for 3 to 4 days, observe the child, and ensure that there is no harm in waiting.
I think Mostly we all know enough of medicine.
Thank you, Ramakant. Thank you.
But we don't think. Similarly, we see but not observe. Observe this child's first sentence. Child got well and remained febrile for 2 days. Does osteomyelitis remain well for 2 days without treatment or with whatever amoxicillin? And has the child remained same stable? Okay. This is a real case. This child was in a 5-star hospital in Mumbai for a month. And when the father came and said, "Sir, we have a problem," I said, "Do you know the history well?" He said, "Yes." He gave me the history. Osteomyelitis will never get febrile for 2 days. If you pick that up, this was an immune-mediated benign osteomyelitis. But the story was clear. Okay. It's not osteomyelitis. Yes, it is osteomyelitis, inflammation. MRI shows inflammation, biopsy showed inflammation, but inflammation which is non-infective. How do you pick up? Child was all right for 2 days, unless you say that was a viral infection and this was. Why do 2 infections come within a day or 2 of each other? You have to get to tag around the same story. This is another example that in a hurry in our clinic, we don't observe, we only see. And sometimes Rajesh used to tell me that, "Sir, patient sees the doctor, but doctor does not see the patient." Okay. And same thing happens, we listen to the patient. We don't only hear the patients. So when you hear but not listen, when you see but not observe, when you know but you don't think, I think the clinical medicine goes wrong there. And then say, no, clinical medicine is inadequate. We need an evidence. This is a real case. What evidence? Evidence that you did not observe. Evidence that you did not think. These are real cases. Okay. And I must have done mistakes. Even today I do it. But I look back and said, "Oh, I will not do this mistake again. I can do another new mistake." Where is the hurry? So many mistakes we can do. I think that's why we like to share such things with you. It's not that I have not done mistakes. Even today I do mistakes. So I think this is one good example how we don't spend time with listening to the patient or observing the patient.
So would I like to add over here?
Just wait for a minute. Yeah.
Now you ask the parent,
Sorry,
how is his appetite? Sir, when there is no fever, he eats well. But when do you ask this question? When you have in mind that this is not an infection.
No, so
how will you pick up on the first 2-3 days that this is not infection? What it turns out to be is another difference, but this is not an infection is clear in the first 2-3 days. That is what we want to say.
Antipyretics for first 2 days.
Antipyretic, yes, but which antipyretic cures anybody?
Sir, since we are talking about evidence versus experience, in a case like this, which is already complicated up to day 14 or 15, wouldn't it be important to actually do an evidence? I mean, considering that you're saying we should wait and withdraw antibiotics, but to prove that what you are saying is correct, like immune mediated, shouldn't we prove
Correct.
it?
My thought of evidence was stop everything, give naproxen and wait for 4 to 7 days. He starts getting better. Don't you have enough evidence? Okay, evidence is not always this.
No, sir, but if
So
he could have been on antibiotics.
No,
for
one
first
sec.
2
I'll
days,
explain. I'll answer that. So see, we wish everyone to take this message home that when you are not treating the original pathology fully, no amount of antipyretic can keep a child completely afebrile if the original pathology is on. So point is that fever can be suppressed for some hours, but then it's going to come back. So if there's absolute no fever for 2 days, that means either you have partially treated that infection or there is no infection or whatever, but it cannot be just antipyretic effect that for 2 days there is no fever in an infected situation. Okay, so that's one. And the other thing is here that we did have evidence which seemed to point to a bacterial infection, but then it turned out that it's not a bacterial infection. So in most of these cases, when the first place gets involved, this is the story that happens everywhere, the world over, unless someone like Sir will pay an attention to that history and see that this is fishy and this is odd. It's only when the second site starts getting involved that these conditions are often picked up. Till that time, it is going on treated as bacterial osteomyelitis, change of antibiotic, this, that. And after so much treatment, how we say blood culture will not be positive. The same holds true possibly that your chance of biopsy showing you a germ which is still untreated. It's there, but it may not be there. So you are still totally confused.
Sir, may I make a point?
Yes, please.
Sir, here I just wanted to say that it is like a prompt engineering. We are searching for evidence on investigations. Rather, we go back to the case, search for evidence there in history, and then do our investigations to find them, support our evidence. So here
Yeah,
I would like to say that rather than investigating, revisiting, history and examination might have clinched or help us in ordering the investigations.
Correct. So I think what you are emphasizing is the point which we talk of in all chronic cases, that if we have failed 2 sets of antibiotics, it's time to sit back, think, go back, analyze everything, see where we are going wrong, change our diagnosis or whatever. And as Ramakant pointed out, if the child is stable, there may not be any harm in stopping and waiting or whatever, but at least waiting and re-evaluating.
Sir, would you consider tuberculosis in our setting in this case? Would you investigate for tuberculosis?
Not really. Tuberculous osteomyelitis is not an acute osteomyelitis, number one. I mean, forget the febrile period in between. Okay. Second is that persistent neutrophilic leukocytosis going further is again unlikely. Okay. And to that extent, I don't think tuberculous osteomyelitis is the possible diagnosis. See, in medicine, anything is possible. Let's not start with that. William Osler said 120 years ago that medicine is a science of uncertainty, but the art of probability. Okay.
Sir,
What
I am
is
from
possible in
Lucknow.
medicine? Everything. What is probable? Tuberculosis, very unlikely. Okay.
Sir, I am from
Yes,
Lucknow.
sir,
I want
from
to make a
Lucknow,
comment.
Yeah, please. Lucknow, please come in.
Yeah. Yeah, I just want to make a comment. If we go by the approach, what Dr. Amdekar has told us, if we see this case, the child presented with high-grade fever without localization, first of all, if we would not have started antibiotics, probably the fever would have subsided by day 2 or day 3, whatever. And then after it recurs, it often gives us a clue to the etiological diagnosis of the case. So the approach was wrong. That is why we got a little confused. Otherwise, it was very simple to diagnose.
Thank you, sir. Thank you. We move on to the next case. So case 4. Yeah. What are the other? Drug-induced fever. See, drug-induced fever usually is after a long period of drugs. So you are saying you stop the drug on day 15, you are saying. No, we have not stopped the drug. The child was still on drugs. We were asking all of us whether that is an option, that we can stop drugs and reevaluate the child. Okay, they had not stopped.
Drug-induced fever, what are the other causes of drugs can cause fever? That's the question.
So I think there are many situations where undiagnosed fever is being treated with antibiotics for a certain length of time. the child gets better on all fronts, but continues to have fever. Now, at such times, we have to start thinking whether this is a drug-induced fever or whether it is just that IV line related fever and such things. Because the child is fine in all other respects and you've not diagnosed the original infection. So you don't know whether you were treating a pneumonia which has got better or you were treating a typhoid which has got better. So child is better, fever is going on. Okay, case 4. 3-month-old healthy infant on exclusive breastfeeding developed mild fever and cold for a day. Mother also has fever and cold. This baby is 3-month-old. On examination, nothing. Options, paracetamol, SOS and observe. In addition, CBC, peripheral smear, CRP, urine analysis. In addition, mother's rapid detection test for influenza and NS1 and hospitalize, send for tests and IV ceftriaxone. Okay, so majority are for the first option, that is paracetamol.
I think, Jagdish, 3-month-old infant with fever, you wait and watch. Okay, I know guidelines are changing now. Okay, but till recently, 3 months is a risk period. Your comments on that?
Yes, sir. I think the important thing here is that I assume that this child is your regular patient and this child can come for follow-up if it worsens. I assume that that thing is there. Then after that, if that is the case and this child is available for a follow-up in the next day, then I would choose option A and tell them that this is what I would do.
Yeah, I think the latest guidelines have brought down from 3 to 1 month. Okay, earlier we used to say 6 months, 3 months risk period. Here is a mother is also having that. But at least will you look for what is the cause of fever in a mother? Maybe malaria, NS1. Okay, baby has the same.
So it's not required, sir. It's not required because right now I know in my triage that this is a mild infection. So it's not likely to cause any problems. So I wouldn't want to do anything. I think the triage category in a patient is extremely important to decide on investigations.
Practically, it is difficult because by now mother must have received lots of antibiotics because, I mean, this is a practical difficulty. Physicians, due respect to them, I mean, no mother is left without anti-malarial or antibiotic.
Okay. So this one, everyone is agreed that we'll give paracetamol and observe. So once again, you're using your experience and not wanting to look at evidence. Move on to the next case.
Can I come?
A 4-year-old child presented with breathlessness for a month and has also increased in weight by 6 kg over the last 4 months. Any thoughts?
Prednisolone for prolonged period. Received prednisolone for a prolonged period for breathlessness.
Okay, but received prednisolone for what? Breathlessness.
Breathlessness.
But first 3 months only increased weight. Breathless.
If some
Breathlessness is only for last 1 month.
Yeah.
And last 4 months mein he has put on 6 kg. So in the first 3 months, he's just putting on weight without any complaint. So you can say that a new mall has opened next to his house. Acceptable reason. Any other thoughts?
Endocrinal causes. Good morning, sir. From Bangalore.
Edema, hypothyroid. Okay. Okay, Bangalore, do you want to come in?
Any endocrinal
Bangalore
causes?
wants to discuss any thoughts on this case so far? So the
Hypothyroidism, sir.
first question is whether this is what we call as nutritional or exogenous obesity,
So
or do you think something is wrong inside?
there is one
Bangalore.
query from Kolkata.
Okay.
Yeah,
Okay,
just
we'll
a
come
minute.
to you in a minute. Bangalore?
So it could be some endocrinal causes like Cushing
Okay.
syndrome or hypothyroidism.
Okay, good. Would you pass it off as nutritional obesity?
No, I would like to take a nutritional history and then decide, since nutritional causes are more common.
Okay, fine. Thank you, Bangalore.
Thank
Kolkata,
you,
please
sir.
come in.
Nephrotic syndrome is a swelling or edema of the face and other parts are there or not in this oliguria and other.
Yes, sir. They were not there. There was no edema and no oliguria.
Oh, thank you.
Okay. Thank you, sir. Thank you.
So obviously it's a pathological obesity, 6 kilo in short time, and rightly somebody said that could it be an adrenal excessive secretions? Yes. So that part is right. This was the Cushing's. Okay. But this Cushing's is running fever now for a
Yeah. So this was diagnosed as adrenal hyperplasia. Fever developed within a week, continued for a month, and several investigations to define the cause of fever, as well as several kinds of treatment, antibiotic, etc., anti-malarial failed in resolving the fever. So now the options are malignant adrenal tumor, bacterial infection due to circulating steroids, fictitious fever, and
That's right.
none of the above. Okay. So the question here is how to explain this fever. So at least half the house feels that they want to explain the fever also on the malignant adrenal tumor. So Hyderabad, can you come in now? Hyderabad, anybody has any points to make on any of the options? Unmute yourself, Hyderabad. Hyderabad, unmute.
Just secondaries. Because the
Yeah,
breathlessness
now we can hear Hyderabad. Yeah, please start all over again. We couldn't hear you.
most likely it could be a malignant adrenal tumor with secondaries in the chest because of the breathlessness, which is progressive for a month, and obesity added to that.
Okay. Okay. Anybody has any comment on the second option, bacterial infection due to circulating steroids in this scenario? Any comments, any arguments for, against? Okay. Thank you, Hyderabad.
Sir, may I come in? Chokani, sir.
Yes, please.
Ramakant,
Ramakant.
yes, sir. Here, this patient, the fever which has continued for a month without any deterioration or a improvement suggests less likely to be a bacterial infection. Again, here, in addition to experience, the evidence will take over since child has got pathological obesity and complications are occurring. So I will like to harp more on investigations in this child and search for the cause.
Okay. Suhas, you wanted to say something about bacterial infection.
Since we've been extensively investigated, it's unlikely that we would have missed any bacterial infection in those tests. So I would not go in for that, especially with the clinical scenario.
I think obviously this patient taught us many things. First is that if you have a endocrine problem fit in the fever also endocrine? Okay, of course, clinically there is nothing to suggest any other localization, but as a rule, don't bring in two different diseases of a different kinds in the same patient around the same time. That's the first principle. And therefore, the second principle was always ask when the fever does not respond to your treatment, and your treatment is hypothetical. You have no evidence, nor even clinical correlation. Ask one question: what brings down fever? Okay, this is a real case again at Wadia, and our endocrinologist had done all the tests. When I went and asked the mother, what brings down the fever? She said, sir, I have tried every antipyretic, but no antipyretic works. That statement alone gave me a diagnosis. It is a central fever. And you have an endocrine problem, and you have another endocrine site. So I told our endocrinologist, this is a hypothalamic pituitary problem. What it is, I won't know. They said, there is nothing of this kind. I said, you find out. Then they found out some damn syndrome or whatever. That's not important. It taught us two things. Every time make at least an inquiry, what brings down fever? And when fever does not come down, it's either a heat fever or a central fever. And a heat fever is easy to diagnose clinically because the central part and the peripheral part of the skin both are equally hot. Whereas in any high fever, the periphery is cold. So always put one hand over the leg and one over the abdomen, and always ask whether antipyretics work. You will get heat fever sometimes, and you may get occasionally a central fever, but such small questions you will ever remember to ask when you are in trouble. This was a syndromic problem. See, I'm giving you all these cases because I have learned out of my own mistakes. Okay, but it gave us a clear message where we now try to avoid them, right? That's why these cases, not that. You would have done all tests, no doubt. But can we retrospectively avoid all that we did? Answer is yes. Yes.
Okay, let's move on to the next case. So this is case 6A. So we have two similar looking cases, and we'll see how a little bit of thinking makes a little difference. So a 2-year-old presented with fever followed by cold and cough. Fever abated in 2 days, but cough continued. So amoxicillin was started on day 5, but the child was still coughing even after 5 days. And means even after 5 days of amoxicillin, so now 10 days of the illness, and on examination there was nothing found. So now, do we need any more information? Do you want to ask any more questions? Anyone from here wants to ask any more questions?
Anyone from
Type
this
of
room
cough.
can also ask questions directly.
Sorry? Okay. Jagruti, you said type of cough. Anything else?
Any other extra pulmonary symptoms for atypical pneumonia?
Okay, so no extra pulmonary symptoms, no breathlessness.
Lymph nodes?
Cough is throughout the day.
Child sick. Any thick or thin nasal discharge or kind of cough, daytime aggravation or nighttime aggravation? That I would like to know.
No, not sick looking.
Since there is
Sure, Jagdish and Prakash will agree that for every cough today, one question you should never forget is, have you had such cough in the past? Cough is such a common problem that it has been always in the past.
Sir,
But
we'll
if
go through
somebody
the
says no,
options first.
somebody-
Should we go through the options?
Fine.
So now with this initial discussion, the options are CBC, CRP, chest X-ray, in addition macrolide, in addition MAN2 and gastric aspirate for MTB or symptomatic therapy and observe. Okay, so now Ranchi can come in, and anyone from Ranchi wants to discuss these options. And if you are for CBC, CRP, chest X-ray, would you like to tell us your reasons for the same? Ranchi, please unmute. Ranchi, we can't hear you.
Yeah. Is it
Yes.
audible, doctor?
Yeah, now we can hear Ranchi.
Good
Yeah.
morning, everybody. So we would like to have this CBC, CRP, and chest X-ray, and in the background, with the background of such episode of cough and fever in the past. So CBC will tell us about bacterial as well as viral infections. CRP will help in that, and chest X-ray will just exclude any lung involvement in this. Because this patient, we are not getting any signs on examination of this patient. So these investigations will help whether to continue with the antibiotic or not, and to discontinue this. Empirically, antibiotic should not be given in this case.
Okay, thank you so much, madam. Nagpur, can you come in? Nagpur.
Can we come from Bangalore, sir?
Sir, just 1 minute. We'll take you on the next case, maybe. Just 1 minute. Okay, Nagpur, is it? Unmute, Nagpur, unmute and talk.
Hello.
Yes.
Hello.
Yes.
Hello.
Hello.
Hello, speaking from Pune. Hello.
Okay, go ahead. Pune, go ahead.
Yes, see, the fever has come down and there is really no need to start amoxicillin on day 5. And that's why starting amoxicillin itself is irrational. And secondly, the fever has gone, but the viral infection triggered cough will continue for some time. So there will be delayed resolution of cough in this patient because the child probably has hyporeactive airways. So it is possible that the initiation of amoxicillin is itself irrational, and the child has a viral infection in which the cough will persist for fairly a long time.
Thank you so much, sir. So the key question was, as Amdekar sir said, past history of cough, which would give you an idea that this child has that atopic tendency or whatever, and his coughs following any viral infection are likely to last longer. So the child improved over the next few days, roughly by 2 weeks, without any other intervention.
From Bangalore?
Yes, please. Bangalore.
Good morning, sir. Sir,
Good
this
morning.
is a 2-year-old child just with a fever of 2 days, and then there is cough was there. So whenever child comes with fever and cough, there are 2 things we have to appreciate. One is to find out what type of cough, and if it is there any noisy breathing, and if there is any work of breathing is more. If these 3 things are not there, it could be simple viral episode. But in the past, if there was a similar type of cough and there is a history of atopy, yes, we can think the child might go for to wheezing later on. But as and now, this looks like a simple viral fever, and we know with viral fever can last for 2 to 3 days, and cold and cough can go on for about 20 to 25 days. So I would rather bet on a viral fever, a simple viral fever, where we need to counsel. Counseling is the most important, and no investigations, no antibiotic. If there is no tachypnea or if there is no disturbed breathing.
Thank you. Thank you so much. So the key thing was that you need to pick up that situation, that this is going to last and I need not do anything. And the way to pick up that was by asking for the history and by looking at the trend. So you had already reached day 10 and the cough was somewhat getting better. So you would have looked at the trend and said, okay, wait for some more time. Sorry, it was my mistake. Nagpur is in a one-way list of cities for today, for today's session, as in Nagpur can see this live webcast, but we don't have a two-way communication from Nagpur. So Nagpur can put in their questions on the chat box and we will try to take that. Okay. Now let's move to the second similar looking case, which is a 2-year-old presented with fever and cough. Fever subsided over the next 3 days, but cough continued for 2 weeks. Again, amoxicillin failed. So we are roughly at 2 weeks of the illness now. The child is coughing. Again, on examination, there is nothing. Again, when we ask what more questions, all the earlier questions, so there is no thick nasal discharge. There is no, in this case, there is no past history of frequent cough. There is no family history of atopy. So still, would you like to ask any other question?
Family history of fever, sir, for pertussis. Family history of fever and cough.
Okay. So family history of fever and cough. So here there are 2 other family members who have been coughing badly for the last few days. And therefore now the options become redundant and this child is pertussis. So the point that we wanted to make in these 2 cases is that you need to ask some key questions in history which will tell you the way forward, whether you need to just wait for it to resolve or whether you are looking for something different, etc., etc.
Jagdish. I think the most important question here I would ask is the cough getting better or worse? If the child is getting worse at 2 weeks, then obviously this is not a resolving viral infection, this is something else. And I think we can, if this child is vaccinated, then pertussis may not be so high on card. You need to look at other etiology of chronic cough. So I think that's probably a question I would ask.
But I think what Jagdish said, unfortunately, we don't even ask that one simple question that are you getting better or worse? We just take things at a face value at that point and we just do some action based on that.
Can I have a comment? So if the cough is getting worse, certainly we start thinking of other possibilities. But when other members are affected, pertussis, I would say in today's scenario, adenovirus is equally likely as an option for pertussis.
Okay. Move on to the next case. 4-year-old child came with persistent cough for a month. There is family history of asthma, followed by a itchy skin rash all over, which continued and the cough continued for another month. And then for the last 4 days, this child is running high fever. CBC, ESR, chest X-ray, gastric aspirate for AFB are all normal. And on examination, there are no positive findings. And your options are repeat tests, including chest X-ray, in addition, CT scan of the chest, and consider allergy tests. Okay, now Lucknow can come in again and tell us what is your thinking in this story. We'll discuss the options later, but just tell us in short what is your thinking in this story. Anybody from Lucknow or Delhi can come in. Delhi?
Bangalore, sir?
Lucknow is coming in Lucknow.
Yeah, as choice is A, because the 4-year-old child came with the
Yes,
persistent
Delhi,
cough for a
please
month.
come in.
No, I'm from Lucknow talking.
Okay,
Dr.
first
Jokani,
Lucknow,
I'm
then
from
Delhi.
Lucknow.
Yeah, first Lucknow, then Delhi.
So I think the repeat test, including chest X-ray, will be the best choice because it's a 4-month-old child with a persistent cough for a month. And there is history of asthma also. So there can be a secondary infection or something like that.
Okay,
So
thank you,
repeat
Lucknow.
chest, including chest, seems to be the choice.
Okay, thank you. Delhi, do you want to come in? Any comment on the analysis of the history or your comment on considering allergy tests? A lot of people voted for allergy tests.
Delhi is confused.
Okay.
Patna will come, sir. Patna, sir.
Okay, wait. Patna will give someone else a chance. Wait. Okay, Nasik.
Yes, sir.
Nashik.
Yes, sir. Ramakant here again. Here in this,
Ramakant.
I would like to ask again past history of cough, past history of similar allergic illness, which will tell me whether this is really a person recurrent allergic symptoms. And here I will like to further elucidate on the cough, whether it is a productive cough or not in this child. So probably it may hint me something like persistent PBB or like that, persistent bacterial bronchitis. But keep aside the diagnosis, past history of cough and similar history of allergy in past may help me in diagnosis further.
Sure.
Hello.
Thank you. Thank you. I think we'll wait now. We'll let Amdekar sir analyze and then we'll come in for the next case.
I think like earlier we said family history of cough, past history of cough, atopy, etc. Another point which was made up just now is dry cough or a wet cough. We often forget to ask this question. This child had a dry cough. Okay, that's number one. Second is it a persistent cough or an episodic cough? This is a persistent cough. Okay. Now you have a persistent dry cough. Okay. Each of this case tells me which another question I could have asked. Now giving you an idea of persistent dry cough going on for last 2 months, to begin with only cough, then also some itchy skin rash for another 1 month, and lastly fever. How do you construct this whole story? Come back in the first 1 month of this patient, and he had no itchy rash, he had no fever. He had a persistent dry cough. Dry cough is an upper airway cough. You have nothing to look at in the pharynx. You have no hoarseness of voice. Where is the site of this cough? It's an upper airway, all right. And it's going on in the same persistent, and therefore it is unlikely to be an infection. The question is, has it been further worsening over time? It's not easy to make out, but there is no breathlessness as such. So you start thinking whether this is an airway cough. What are the airway problems inside the airway, inside the wall or outside? Had it been inside the wall, we would have made out at the pharynx, larynx, hoarseness, etc. It's unlikely in the wall, so it must be outside the wall. So it must be a compressive upper respiratory problem. Right in the first 1 month. So it must be a come again. So now add on. So we already got a compressive upper airway problem. Now you have an itchy rash. Okay, it's not infective. Obviously, it's not a skin disease. So it is some allergic rash. But allergy doesn't mean only the inhalation or ingestion. It could be any intruder in the body. Okay, so we keep that in mind. And now fever. So it's also an inflammatory disease. But inflammation coming at the end of the story. So it's not infection, it's non-infective inflammation. What is non-infective inflammation? Not rheumatological in this, so malignancy. Now compressive upper airway, mediastinal, okay, mostly lymph node, okay, malignancy, lymphoma, okay, well, tubercle always in the lymph node, but more likely malignancy. And if you read Nelson's or any book, Hodgkin's is one cause of itchy skin rash. Okay, so this turned out to be a Hodgkin's disease. The point is, we have to ask all these questions to cough. We are going to have a pulmonology session. But dry cough or a wet cough is what we learned in undergraduate days. When did you ask this question last? Probably never. Cough is cough. So many things which we learn, which we have learned already and forgotten to implement. Okay, this was a dry, persistent cough.
Okay, we move to again two similar looking cases. So case 8A, 14-year-old presents with periumbilical pain off and on for the last 4 months. Routine tests normal, treated empirically with some drugs which have not relieved him. And on examination, no abnormality detected. Do you need any more information? Do you want to ask more questions? Bowel habits. He goes to the washroom every day with his mobile.
Aggravating and relieving factors.
No specific aggravating or relieving factors. No, he doesn't awaken at night.
The diet history of the child. What does the
Typical
child
14-year-old eats junk food always.
pain is mild or severe?
So how do you judge that? Mild or severe? He says it's severe, but he's saying it smilingly. It doesn't interfere with the routine activity.
Children say during not avoiding the school. That
Good. So fine. So now let's look at the options.
Is there
Endoscope-
a family history of similar illness in the family, hyperalgesia suggestive? So whether we are dealing with disorder of gut-brain axis or functional disorder.
Okay. The options are endoscopy to rule out inflammatory bowel disease and celiac disease, tests for H. pylori, MR angiogram or MRI of abdomen, or consider functional disorder and counsel parents. Okay. So now question to all the 85% who said counsel. What evidence do we have that this is not the beginning of IBD or this is not the beginning of celiac disease? Pain in abdomen is a presenting symptom of both. Okay, weight and growth pattern. Anything else? Okay, happy or sick?
Delhi wants to ask something.
At 14 years of age, I would like to investigate this child.
I would like to investigate this child because he's 14. Yes, Delhi, come in.
Yes. Hello.
Yes, Delhi, come
Child
in.
is 14 years old. There is no weight. There are no symptoms. Bowel habits, urine, everything is normal. Child is not losing weight at all. So I think we should counsel our parents on these grounds.
Okay, thank you so much.
I think when we talk about functional, we need to have a justification of why not organic disease. Functional, there may not be obvious evidence, but at least a reasonable justification of ruling out organic disease. So how do you get about that? Periumbilical. Which organ in the abdomen, periumbilical? I know right hypochondrium, I know right lumbar, I know which organ, which part of the abdomen is periumbilical? Difficult, no? Yeah, because we know quadrants. Periumbilical is intestine, lymph nodes, or a peritoneum. Okay, largely three structures. Typically, acute periumbilical pain in appendix moves to right iliac fossa after 24 hours because appendix is a part of a midgut and it represents the embryonic development of an appendix in the middle. So here, a long-term abdominal pain must be lymph node, intestine, or a peritoneum. If it had been a lymph node, the lymph node causes pain only when the lymph node is large enough and the capsule of the lymph node is stretched. So I would have palpated it, USG would have shown it. So it's not a lymph node. Peritoneum is a generalized one. not just periumbilical. Therefore, it must be intestine. Anatomy, intestine. What about further? No diarrhea, no constipation, okay, nothing. So intestinal, physical, organic diseases are unlikely. Therefore, intestinal functional disorders. What a functional disorder like dyspepsia, okay, but that is up there. That is not periumbilical. So something equivalent. What is that equivalent? The disease is coming out of mind and not out of body. So I have ruled out intestinal, peritoneal, lymph node. All other tests are normal. Okay, I won't do invasive tests. How do I counsel? That is very important. And I think this is a very common problem. I'm sure all of us are seeing this. The question is, how do you convince the parents? So you tell them that there is certainly a disease, but not necessarily in any part of the body that can be seen clinically or by the CT scan or a test. And what is that organ? The mind. And the moment you say that, the parents say, no, there is no problem in our child, no problem in our family. Now the question is, brain controls the whole body. Who controls the brain? Okay, so answer is, intestines control the brain. How intestines control the brain? Intestines are the first to smell the trouble. When you see something frightening, पेट में गोला आता है. What is पेट to do? The intestines cramp and send a message to the brain, there is some problem. What problem? I don't know. Intestines sense fright. When you go for a Viva exam, you go to the loo once more. Intestines are cramping, stressed. Okay? Enough evidence, even a lay parents understand. Yes, I also used to do it. So intestines sense the stress and the fright. And lastly, if you ask me, why did you say it? I say it's my gut feeling, not brain. What more information and evidence you want to say that intestine also feel pain in the mind? When I tell this, the parents say, yes, I agree. पेट में गोला आता है. I go to the loo once more. Yeah. And this is a fact of life. There is always still a debate whether the mind remains in the brain or the intestine here. But that's not our problem. Our problem is functional abdominal pain is very common. And then how do you treat it? So find out where is the stress. Now, who the hell has no stress in this life? Life is stressful. The question is, can you cope up with it? If you can't cope up with it, you suffer. So the question is he having a problem with school, with studies, with parents, with friends? Go on further discussing, but don't go on doing endoscopy or further tests. Okay, difficult problem, but at the end you say, let's wait and watch, considering this. While you look at the stress, I will keep a watch on his weight, any new symptom. That is also, because let's see the next case, similar case. Again, a real case.
Sir, just 1 minute before we move on, there have been a few questions on the chat from the centers which are not linked two-way. Most of the questions were as we were discussing the case, so they've got answered. One person from Indore has asked, why did the fever go away for 2 days in that immune-mediated osteomyelitis?
Oh yes, what is immune? Immune is sudden appearance, sudden disappearance, recurrence. Simple. Urticaria, no? Sudden appearance, sudden disappearance, recurrence. You'll say, but how did it disappear? That's what is an immune or allergy means. Asthma is episodic, no? In the morning, there is no asthma. No, there is asthma. Okay. So, episodic nature, appearance, disappearance, recurrence is typically not infection, immune allergy. So that answers that question.
Okay, so let's go to the second similar case. 14-year-old presented with lumbar back pain off and on for the last 4 months. CBC, urine routine, stool routine, USG normal, dewormed 8 times. Antibiotics, anti-amoebic course did not help. On examination, nothing detected. And again, need more information. So you would have asked for all the same questions which you asked just now.
In fact, this patient, I remember, this is a pediatrician's grandchild. And when I asked the boy, what is bothering you? He said, sir, I've got pain all right, but my parents and grandparents said, don't go out to play. It will increase your pain. Don't eat this, don't eat that. So I told them, let him eat what he wants. Let's see what happens. Okay, whether he can be happy. And he said, no, I'm happy now. But he was not very maintaining weight. There was a small drop in weight. So it was decided that we go further on that.
So options are endoscopy to rule out same options, IBD or celiac disease, repeat USG, CT abdomen, or consider functional disorder and counsel parents.
Small difference here. Child was allowed to do what he wants. He is happy, but he is still not doing well. He lost a kilo. There's something amiss, right?
The question, Dinesh, question नहीं आया, वो क्या आया?
Hello. 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 Hello, sir. म्यूट हो गई है.
Okay, so now for this question, does Patna or Ranchi want to come in? Any comments from either Patna or Ranchi? Patna is unmuted. Patna, do you want to say something? Okay, Ranchi.
Patna.
Yeah, Patna.
Yes, sir. Good morning, sir. Sir, here I think we'll go for CT abdomen because again, celiac and all we cannot think because as there's no failure to thrive. There's no other associated history like diarrhea, vomiting, and the weight gain also. I mean, it's not a weight loss.
There is 1 kg weight loss over 4 months. It's not mentioned here, but Amdekar sir just said orally.
Okay. And in that case, I think we should go for the A part because the age 14-year-old and then there is a weight loss and persistent pain is there for last. So A.
Okay, so you wish to do for endoscopy. Okay, fine.
Right, sir.
Okay. Anyone from here wants to interact? What do you think you should do?
I'm calling from Kolkata. Has
Yes,
deworming been done in these patients, sir? The previous
times.
patient or this patient? Because I did not find any history of deworming in these two patients. Because in any case,
Yes, sir.
abdominal pain can occur due to worm infestation, sir.
You're right, sir, and that is why all of us reflexly deworm. So this child has been reflexly dewormed 8 times, but the pain still persists. But point well taken. Okay.
So the basic difference between the earlier case and this case is the site of the pain. So periumbilical pain, as Apley has told us 60 years back, that most likely, if it is not something, consider functional. But here there is a pinpointing, there is a localization of lumbar back pain. And we have not been told about is there any local finding about that? So the last part, consider functional disorder and counsel is definitely out of question in this.
Very good.
So Upendra,
there is a small difference. Okay. Therefore, we decided to review the whole situation and another ultrasound was done and opinions were taken. It showed that one ureter looked a little dilated. So there was a pathology. What was important was not how we missed some of those things like what Upendra brought to the notice. Then when I asked the boy, he said, yes, sometimes I get a colicky pain. Earlier he said, no, it's a dull pain. Okay. Colicky pain meant some tubular structure. There was a dilated ureter. It turned out to be a retroperitoneal fibrosis. The question is, sometimes the abdominal pains can be so diverse that we don't even think about it. Like an MRI angiogram was done and you found an abnormal vessel there. But that is not it. Here, I think Upendra brought a very good question, that there was some clue to tell us that this is not functional. But overall, it looked functional. Everything is going reasonably well. So again, a learning point.
Sir, from Hyderabad, can I come in? One moment, one comment.
Yeah, 1 sec, sir. Just 1 sec.
Why not a CT abdo instead of a repeat ultrasound in this case?
I think that's again thing. Like all clinicians, we see but not observe. Even the radiologists will do the same. Only thing they write in black and white, we don't write.
So
That is
actually,
all. See, what the point is, yeah.
No, sir, forgot to mention one thing. So that boy also told sir that because I have pain in abdomen, my father and my grandfather
Yeah.
are not allowing me to go to play cricket.
Yeah, I
Cricket,
said that.
okay, yeah.
Yeah. So I thought it must be functional only, but the fellow did not improve even after that. But see how Upendra brought that point important.
So,
we
Jagruti,
had missed that point.
Yeah, so
We had missed that
initially it
point.
was
Okay.
considered functional, and then it was a question, are we going wrong in our functional diagnosis? So a USG was done, but you're right, you could probably do something more than that. Okay, Hyderabad, come in.
Yes, sir. Sir, in my experience, I always found lumbar or loin pain never to be functional. That's one
Yes,
point.
absolutely. Absolutely. Yeah, point well taken.
Last-
Let's move to the last case for today. Yes, sir.
This pain lasted for 4 months, and with the weight loss, these two are significant pointers to in origin.
Yes. Okay.
Hello from Patna.
Yes, Patna, come in.
Spinal tuberculosis.
Yeah, spinal tuberculosis would have some local tenderness on the spine or some local findings, and it would be a progressive story over a period of time, right? But well thought of. Now let's go to the last case for today. Case
One more comment. Why not CECT? Why to repeat an ultrasound? Why shall not we believe the ultrasonographic findings in the first place? And then if there is any doubt, go for contrast enhanced CT, which is going to reveal much more than repeating
So,
ultrasound.
sir, you are right. The first ultrasound was done in the beginning of the illness. It's over 4 months that it is being reviewed. So it is probably anybody's choice whether you want to first repeat a ultrasound after 4 months and then do something which is a little more, radiation and things like that. Yeah. Yeah. Okay. Now, last case for today before we end this session and move on to the next session. So an 18-month-old presented with developmental delay noticed around 1 year of age when he was not yet sitting. This is when the parents realize that this child is not like other children, no other complaints. That on detailed questioning, the development quotient on history turns out to be gross motor 45% roughly, fine motor 40%, language 50%, social 60%. And on examination, growth and nutrition was fairly okay. There were signs of spasticity. Now, do you want to ask any more questions? Maybe we'll not answer those questions and then we'll look at the options. So what questions do you want to ask? You want to ask birth history. Birth asphyxia. Circumference. Anything else you want to ask? Okay, eye contact. Eye contact is there. So they noticed at 1 year, when you are not sitting like other children. So on our history, this is the DQ that we are getting.
The dysmorphia from Patna.
Major illness in first 6 months of life.
No major illness. Yes, Patna, what did you say?
Any dysmorphia?
Yeah, dysmorphic features are not there on examination.
From Ranchi,
Any seizures? No seizures. Okay.
family history?
No family history.
Sorry, may I come in, please, sir?
Question regarding
Yes.
the term pregnancy, the delayed cry.
Yeah, very good. So I think all of you want to know about the birth history. So the birth history.
So I think the most important part of any development delay is it static or progressive? That's the first thing. It will divide everything totally. This was a static problem. He was not worsening. Okay, he may have been improving a little. Of course, static problems could also worsen, especially in a gross motor when contractures develop. Okay, but otherwise, this was a static. So obviously, options now are, so we have a cerebral palsy, spastic CP. Okay, whatever the cause was, we don't know. Options are
MRI brain, in addition tests for inborn errors, in addition genetic tests, and last is no tests but counseling parents. Okay, so majority of the house wants MRI. A few want inborn error of metabolism tests, genetic tests, and a few were only for counseling.
I think the question of inborn error metabolism is out because this is static. So that part is clearly out. MRI brain, what are we expecting in MRI brain? The expectation should not be just to look at some structural changes, pathological changes, but would that change my outcome, prognosis, management? And the answer is no. Okay. Dr. Rajesh Udani keeps on telling us during our PG sessions that a classical CP does not need any neuroimaging. As a good neurologist, he says that. Of course, there are few exceptions, and that we must keep on asking ourselves. One is a normal birth history. Oh, then it may not be a CP. Second is a familiar history. No, CP is not familiar. Okay, hereditary. So if you have
Normal
no-
head size.
Yeah.
A normal head size is again a red flag. So
if
child
you have
looking
no
like
risk
CP.
factors, and if it's a classical story of a birth HAE, then you don't need MRI. Okay, so that is out. Genetic tests are only when you're suspecting a syndromic problem. Okay, so that is another thing. And therefore, again, counseling. Okay. We just wanted to bring out some type of cases where we all have chosen not to go further for evidence. Here there is no evidence of a CP, but a reasonable inference out of situation. And no test will improve upon our understanding, our management, our prognosis, etc. And we just wanted to show that we are all for evidence, but there is a limitation and we must counsel the parents. But if some parents today insist that let us do all tests possible, don't say no. They may be right. Okay. So never fall into that trap of saying, no, 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 I know everything. But tell them that I think the tests are going to be not useful, but yes, if you want to do a test, please do it. When the tests come negative, I get confidence that yes, my impression was right. And I also guard against my mistake that can occur, and then it's a slap on my face. So never respect the parents, okay, allow them to do tests, but don't take a blame. Aajkal doctors go on asking tests and all tests are negative. That also should not happen, right? I think we should stop at this point of time. We are given 2 hours. We are through 2 hours, okay? And Bala is already here.
Thank you, Dr. Amreka sir and Dr. Rajesh Chokhani sir, for this excellent session. So now we can have a short tea break and come back in 30 minutes time.
We will have a tea break. The tea is there outside.
Please come back in 15 minutes so that we can
Okay.
start early.
So before moving up for the tea break,
So we also have tea break and tea is ready outside this hall.
So tea is being prepared. So just give us 5-10 minutes. You can sit here. We'll serve it here also. So we would like to just give a token of appreciation to our chairperson and moderator. So I would like to call Dr. Anil sir to please come, and Jitendra ji, please give sir a token of appreciation from our side, a small memento.
Well, actually, all India is participating now, so I will make available. No worries.
There, put it average, don't worry.
We will do.
I can manage.
Whatever I can do.
But even without slides, I can do this session.
Yeah, I know. Which one, sir?
Yeah, the Enteric fear I'll come. That's all. The questions are, the font is changing.
Yeah, it's got changed.
Why?
So sometimes font is take approximately that local font. We use something different font.
Oh, but it's not coming well. No.
So do you have your laptops? Can I put your
Yeah.
laptops?
Yeah.
Better to have.
Yeah.
I can put your laptop.
Apple.
Yeah, Apple. No problem, sir. It will work. Arvind? जैसे तेरे को देंगे ना वो फोटोग्राफर वीडियोग्राफर करने दे, जैसा मोमेंटो देंगे ना हल्का सा दे। हाँ वो ए है और किसी का है और किसी का है अरे उसका हो गया, अभी ये जो रिसेंट आया इसका नया है।
हाँ नहीं इस नहीं जो उन्होंने एक का नहीं डाल रहा था वो बोल रहे थे टाइम लगेगा। विजय सर का ही था। विजय सर का एक बार पूछ लो कि हो गया क्या अच्छे से।
Reduction of typhoid following. Let's start.
Okay. So the next section for today is enteric fever changes over 4 decades. And for this particular session, I would like to welcome Dr. S. Bala Subramanian sir. He is visiting consultant in pediatrics and former medical director, Kanchi Kamalkoti Child's Trust Hospital, Chennai, trustee, Child's Trust Medical Research Foundation, chairperson, IAP Infectious Diseases Chapter 2022. He has 150 indexed publications, mostly in PID, and 40 orations, over 500 sessions in IAP forums, and over 500 PG sessions. So I would request presentation of bouquet and memento to Dr. Balasubramanian sir.
Thank you. Good morning. Thank you all for gathering here on a Sunday morning to listen to me, wherein I'm going to share personal thoughts on enteric fever with reference to changes over the last 4 decades. This brief session, I'm just going to take up the therapeutics of enteric fever. I thought I would share some case scenarios from my practice where I had dilemmas, very similar dilemmas all of you must be going through with regard to enteric fever. And I'll also share some personal experience with regard to those cases and give an overview of antimicrobial resistance in enteric fever and the changes that have taken place. Let us start with the case scenario straight away. This is a common scenario in our practice. 5-year-old child having fever for 4 days, not improving, worsening fever, vomiting and a few loose motions and anorexia. Young pediatrician, any fever for 4 days, gastrointestinal symptoms, any time of the year, any part of India. The first treatable bacterial infection all of us are going to think of is, of course, enteric fever. And he or she suspects enteric fever. But then he has a few options before him. 4 days fever. What do you do in terms of investigation? What is the appropriate way to investigate this child for a diagnosis of enteric fever? That's my dilemma. What is the best way? What is the most rational way to investigate? I have given some options. Option 1 is, of course, blood culture. Option 2 is the Typhi.IgM, the serum test for enteric fever. Third is the old, like whiskey, Vidal, time-tested Vidal. Fourth is a combination. Nowadays, whether it is drugs or whether it is tests, nowadays it's all combo, duo tests. Even dengue nowadays we are doing duo tests. So like that, blood culture with Typhi dot, blood culture with Vidal. I have a dilemma. Suppose I put this to the audience in terms of a poll. Most of you would vote for 1 or 2 or 3 or 4. Please raise your hands for 1. Okay. For 2. No, they said they will do it. They can vote it. Okay, fine. Okay, they have already voted. Fine. And thumping majority for blood culture. And, like coalition politics, duo test is coming up in a big way. 22% have voted for 1 and either 2 or 1 and 3. I'm happy Vidal, nobody is voting, but I don't know whether they are really doing it in practice. That I don't know. I'm not sure. At least voting wise, Vidal is out. Combo is coming in a big way. Culture, everybody is agreeing. No, but the correct answer is, of course, doing a blood culture. When it comes to diagnosis of enteric fever, when I was a student, I remember we used to do only Vidal and treat enteric fever. Blood cultures I have never seen in a government hospital. In my 70s and 80s, growing Salmonella typhi. Though my microbiologist in 90s used to say, if your lab cannot grow Salmonella typhi, change the microbiologist and the lab. The easiest organism to grow. Culture of culturing yet to become routine. It's very unfortunate in a country like India where we could do PCR for COVID even in the remotest corner of our country. People say, no, sir, it is difficult to do blood culture. They will do CT and MRI, but they'll say it is very difficult to do blood culture. And typhi dot, unfortunately, it's, I hate serology tests because they create disease only in laboratories, not in human beings, right? They pick up disease only in laboratories. Serum tests are becoming outdated nowadays, most diseases. And this IgM, the kits that are available have not been standardized. The WHO has not given clear directives on the kits to be used. Many kits are available, suffers from lack of standardization. I personally don't recommend. From our own hospital, there is a published paper on typhoid IgM being useful. But our own unit, we don't do. I've not done a single case of typhoid IgM. The reason is sensitivity is more than specificity. It's almost like early Vidals. If you do 6th day or 7th day, it may be positive. A negative IgM has got more predictive value than a positive IgM. Vidal fever. I call it Vidal fever. What is this Vidal fever? O1 in H1 in 80, slide test, side lab. Okay, that is Vidal fever. That's not enteric fever. So that is still prevalent. And we have not done Vidal in the last 10 years in our unit. We have not done even a single case. I'll come to that later. Coming to the blood culture, though we say gold standard, it suffers from a few problems. The problems are, one, taking a culture before giving antibiotic. It's like urinary infection. If you don't do culture and start antibiotic, you will always miss UTI. If you start antibiotic and then do urine culture, you will miss. So it's almost like that. And inadequate sampling. They'll take 0.5 ml for blood culture. No, it's not going to grow Salmonella typhi. Ideal volume, even in an infant, for Salmonella typhi to grow, you have to have 2 to 4 ml. Though they say neonatal sepsis 1 ml is enough. For infants, for enteric fever, you have to give 2 to 4 ml of volume. And children and adolescents, you have to give 10 ml. You have to instruct your lab. In fact, our microbiologist is very strict. If you put a query enteric, she will ensure that this volume is there in every case. And that's why our yield is extremely high. First week, 80 to 90%. Second week, 75%. Third week, 60%. And beyond 3 weeks, it comes down to 25%. Basically, we all miss enteric fever mainly because somebody starts antibiotic before culture. Somebody does not send enough volume. And of course, bone marrow culture is something which is extremely useful. In fact, even if there are 5 organisms per cubic millimeter, 5 typhoid bacilli per cubic millimeter, you will get it from bone marrow. So it's highly sensitive if you do a bone marrow culture. Because many PUOs where we have thought of all diagnosis, 3 days later, Salmonella typhi is picked up. The other day, Dr. Vijay was commenting, many of the PUOs which are missed are all enteric fever or diseases labeled as enteric fever. That's what happens. And before we talk about some more practical problems in enteric fever, these definitions are very important. These definitions have been given by our Pakistani Microbiology Association. Very nice definitions. First is non-resistant typhoid fever, where all the first-line drugs are effective. All the first-line drugs are effective. Second is multi-drug resistant, where you have resistance to chloramphenicol and ampicillin, amoxicillin, etc. Third is extensively drug resistant, which are resistant to your cephalosporin, etc. or even azithromycin. And last is a new term, ESBL positive typhoid fever. Fortunately, in India, this is not very common. This is very common in Ukraine, I believe, in Russia, some parts of Pakistan, where they produce ESBL and they may not respond to cephalosporins or even azithromycin and quinolones, of course. You may have to use meropenem or aztreonam. This is the definition which is now accepted. Let us move on to the case number 2. This is fever for 6 days, 4-year-old, 6 days, spleen is stiff, child is very stable, child is not toxic, oral intake is good, leukopenia, eosinophil 0, urine routine is normal, somebody has sent blood culture. Clinically, the entire picture looks like enteric fever. In contrast to a 4 days fever, it almost looks like classic enteric fever, except that you don't have microbiological proof. Clinical evidence is there and some laboratory evidence suggesting it could be enteric fever, not that E0 always means enteric fever. It can occur in any bacterial, severe bacterial infection. Now for this child, if I put an audience poll, what will it do for this child? So 6 days fever, stable child, clinically looking like enteric, culture sent. The options for us, start cefixime, start azithromycin, coalition, start cefixime and azithromycin, and sorry, not 6, 5, admit and start ceftriaxone, particularly in lean days, if you have a nursing home, admit the child and start ceftriaxone. Let us put it for an audience poll. And here again, majority are right. Most want only cefixime. 3% would start azithromycin. Very sad to note that 1/8 will start cefixime and azithromycin, coalition politics, and admit and start ceftriaxone. If the child is stable, I wouldn't admit. Somebody is suggesting. The correct answer, of course, is only a oral cefixime. You can get away with cefixime. Stable child. I put not toxic, intake is okay. You can start with oral cefixime and wait. You need not start 2 drugs. Let us go into the further dilemmas. The biggest dilemma we have is the choosing the first line drug. I'm sure we have. Everybody might say cefixime, I'll start. Somebody will say azithromycin, somebody will say ofloxacin, somebody will straight away start ceftriaxone only. Second is the dosage confusion. Third is a change of drug. When to change from one drug to another, when, what, and how. Fourth confusion, coalition politics or single party, single or combo therapy. These are the 4 dilemmas. Let us take up one by one. First line choice, I am sure everybody would agree, first line choice today for enteric fever in India is cefixime. Cefixime. The only problem is most pediatricians, when it comes to cefixime dosage, they don't calculate. I have seen enteric fever will be the diagnosis, but dosage will be for dysentery, 8 milligram per kg. The dosage of cefixime varies from UTI to dysentery to enteric fever. For example, for dysentery, 8 milligram per kg will do. For UTI, 15 milligram per kg might be required. For enteric fever, 20 will be required. The next problem is older children. Older children. People restrict to only 200 milligram BD or 400 milligram BD. You can go up to 600 milligram BD if it's an obese child. 1200 means the child is 60 kg, you can give 600 milligram BD. Adult maximum dose is 600 milligram BD, not 200 BD, not 400 BD. That's something which you should remember. Second is azithromycin. Invariably, we see prescriptions of only 10 milligram per kg. It's not going to work. 20 mg per kg, single dose. Here again, we must remember 50 kg child, you can give azithromycin 1 gram OD, not 500 milligram. 500 milligram OD will not work for enteric fever. Okay. The next problem is duration. Cefixime, 14 days. Azithromycin, it used to be 7 days. You can go up to 14 days. Even azithromycin, if there is a slow response, We do extend beyond 7 days and give up to 14 days. Ceftriaxone, 75 to 100 milligram per kg. The WHO recommends 75. I personally use only 100 milligram per kg. I never give it intramuscularly. The child will never come back to you. It's extremely painful, ceftriaxone injection, extremely painful. The other caution is it has to be given a slow infusion, never a push. 50 ml normal saline, slow push, never mix with calcium. Maximum dose is 2 grams BD. OPAT, outpatient antibiotic therapy, in a child who is weighing only 20 kg, you can give 2 grams OD also. Daily ask them to come to the OP and take it. Okay. This child, you are given 5 days of cefixime. The blood culture has grown Salmonella typhi, pan-sensitive, sensitive to everybody, non-resistant enteric fever. But good dosage you have given, 20 mg per kg, you have confirmed it is typhoid, fever is persisting. Parents are angry, they are coming to you. Now at this point of time, if I put an audience poll to you, what to do? So, pan-sensitive typhoid or non-resistant typhoid, 5 days of cefixime, fever is persisting, angry parents. I'm sure all of you would agree, you would see at least one case every 3 months like this. Yes or no? Yeah, maybe more also. Busy practitioner. I see only one or two per 6 months. Okay. Blood culture is showing Salmonella typhi. And at this point of time, what do you do? 6 days cefixime over, Salmonella typhi confirmed. What to do? The options are: 1, add azithromycin. Easiest thing to do. 2, admit and start ceftriaxone. Cefixime is not working, admit. 3, continue cefixime. Conservative people. No. Child is stable. 4th is reassess for a decision on OP versus IP care. Re-examine the child. Take history. How is the intake? How is the toxemia? What do you think is the best answer? I am sure most of you would choose what? Let me see. Let us have the audience poll. The best answer is you have to reassess. The child is stable. 5 days or 6 days cefixime. Child is stable, not worsening. You have a confirmed diagnosis. You have a good lab giving you sensitivity report. You don't have to worry. You do a clinical examination. There is no complication, no setback. There is no need to admit the child or change the antibiotic or give ceftriaxone, but there is absolutely no role for adding azithromycin. The next question is, which 12% voted for a combo, isn't it? The initial opinion poll, 1/8 said you give 2 drugs for enteric fever. Now, if you are going to treat enteric fever with 2 drugs, which combo would you prefer? And
The audience
prescribe
poll is
in your
not coming
practice?
here. Please inform.
Which is the combo you are prescribing in practice for
Sir.
enteric fever? For a
Sir,
case like this,
Sir, Bala sir.
1 cefixime plus azithromycin,
Hello, sir.
2
Hello.
cefixime
Hello.
plus a quinolone. It may be
Hello,
ofloxacin.
sir.
It may
Hello,
be
sir.
catifloxacin.
Sir, this is
Maybe
from Kolkata. Hello, sir.
ciprofloxacin
This is
also.
from Kolkata. Hello, sir.
Third is
Sir.
ceftriaxone plus azithromycin. IV
Sir, can you-
ceftriaxone, oral azithromycin. Fourth is none of the above.
Sir, can you
None of
hear?
the above. Let us
Sir,
see what
can
the
you hear,
audience
sir?
poll says.
Sir, can you hear? Sir, can you hear?
Nearly
This is from
half
Kolkata.
give cefixime plus azithromycin. None of the above, unfortunately, only 1/3. I'm upset. Only
Mumbai.
1/3 would say he wouldn't use
Hello.
combination. 50% would use combination.
Sir,
us
can
listen
you-
to the
can you hear,
correct
sir?
options. I think the correct answer is
Sir,
today in literature, there is no evidence to support dual therapy. There is no evidence. Like a gram-negative infections where you use a beta-lactam and an aminoglycoside as synergism, here the synergism does not exist between a macrolide and a beta-lactam. There is no evidence at all. Or a quinolone plus a macrolide. There is no. And this is what we studied and we published in 2006. What we did in 2000 to 2006, in our unit, we used to follow only one antibiotic for enteric fever. Many other consultants in our own hospital used to give 2 drugs. We took up the cases. And we found out that the duration of fever as well as the time taken for deferescence, whether it is single drug or two drugs. Two drugs means cefixime, azithromycin, cefixime, quinolone, all sorts of combinations. The duration was not at all different. And we said that there is no need to.
Excuse me, sir.
drugs.
Hello.
No
Audience
need to
pool not
use
coming in
drugs.
Kolkata, sir.
Only one drug is enough. Only one drug is enough. If you have culture evidence of responsiveness to a particular antibiotic, it's enough if you use only one. Case number 3. True case, which happened in April. 12-year-old boy, he had fever for 25 days. High-grade intermittent, anorexia, abdominal pain intermittently, obese boy. No respiratory symptoms, no diarrhea. And he was given multiple antibiotics. I'm going to show you his antibiotic diary outside before he came to our hospital. Name any antibiotic: ciprofloxacin, ofloxacin, metronidazole, cefepime, sulbactam, artesunate, azithromycin, levofloxacin, doxycycline, piperacillin, tazobactam. All within 25 days. All within 25 days. Except blood culture, all investigations are done, except blood culture. And he came to us and he had anemia, he had borderline total count, he had thrombocytopenia, and his bilirubin was high. SGPT was minimally elevated, albumin was low, and third spacing was occurring. And we did ferritin. Any fever like this, we always do ferritin for HLH, 2000 odd. LDH was 1853, and blood culture, no growth. We investigated for HLH and all sorts of hepatitis, as icteric. And we did a bone marrow to rule out malignancy. Bone marrow was reactive. And finally, blood cultures were negative. Bone marrow culture, it was actually a Salmonella typhi pan-sensitive. And he recovered with azithromycin. This is actually a typhoid hepatitis. And the clue that we got for typhoid
Hello,
hepatitis.
sir. Hello, sir. Sir, this is from Kolkata. Hello, sir. There is a technical problem that the audience poll is not coming in the Kolkata center.
Okay, sir. Sir, I will take care, sir. I'm calling.
Okay.
Thank you.
There was one clue. Can anybody tell me what is the clue that is there for typhoid hepatitis in the lab reports? Anybody? Okay. The clue that we had was the clue of very high LDH in contrast to minimally elevated SGPT. In typhoid hepatitis, LDH goes up much more because it is a type of ischemic hepatitis. Whereas in viral hepatitis, it is the SGPT which goes up much more than LDH. This is what we published. We said, we proved, we compared the SGPT and the LDH ratios in typhoid hepatitis and viral hepatitis. And we reported that if you have a ratio between ALT and LDH which is less than 9, that means LDH is more elevated, ALT is not more elevated, that is typhoid. On the other hand, if the ratio is more than 9, it favors viral hepatitis. The reason why I put up this case is that jaundice is not uncommon in typhoid fever. Third spacing is not uncommon in typhoid. Like dengue, it can happen. Last case. This is an infant with fever, irritability, 6 months old, fever, bouts of crying, bulging fontanelle, no other signs. Counts are normal. We did a blood culture and started on ceftriaxone. 6 months old, only 1 day fever. To our surprise, the blood culture grew Salmonella typhi and child recovered with ceftriaxone. CSF is normal. This is the first case of pseudotumor cerebri, only reported case in literature as a manifestation of typhoid. The reason why I put up this case is because we always tend to think of typhoid only after 4 days fever. I'm afraid it's not correct. You have to start thinking of typhoid in any child who's toxic even after 48 or 72 hours or even 1 day in an infant, particularly if there are gastrointestinal manifestations. Last audience poll. Have you given ever steroids in enteric fever? If the audience answer is, how many of you have given steroids in enteric fever? Please raise your hands. Okay. Now, if yes, in which of the following situations would you use steroids in enteric fever? Prolonged fever like the case 1 where the child did not respond to cefixime in spite of appropriate antibiotic. 2, shock encephalopathy or myocarditis. 3, you do ferritin, it is high, and you suspect HLH, you're going to do investigations, you give steroid. 4, all of the above. 4. Okay. Now the answer that I got is, okay, it is divided between all of the above and shock encephalopathy or myocarditis. In fact, my answer, I'm afraid, would be it's only shock encephalopathy or myocarditis. Studies have shown that giving steroids increase the risk of ileal perforation. Giving steroids prolongs the fever. It doesn't bring down the fever. So you should not be giving steroids routinely to enteric fever. In fact, Bhutta in Pakistan has done cytokine study in enteric and has reported benefits with short course steroid, but it is not recommended. It increases the risk of perforation. So you should use steroids only if there is shock encephalopathy or myocarditis. There are Vietnamese studies, there are African studies. The dose is very high, dexamethasone 3 milligram per kg, then 1 milligram per kg every 6 hours. And the prolonged administration causes relapse. So you should give only when there is encephalopathy, myocarditis, or shock. Other indications are not accepted. Last dilemma. 5-year-old, fever, 10 days, spleen tip, culture is negative, already on cefixime. Better after 3 or 4 days of therapy. Child is seemingly better after 3 or 4 days. And your culture is negative. Culture is negative. Okay, you have got the culture report. You started cefixime. Child is better after 3 or 4 days. What do you do? This is a dilemma which I face in practice quite often. One, no, this is not enteric. Culture is negative. Stop cefixime and observe. Let us do Vidal. If it is positive, we will continue. Third, don't take chance, give cefixime for 14 days. Fourth, continue cefixime for 4 days and stop. I'm sure this problem all of you would have faced. Yes or no? Yeah. 6 days fever, you have done cultures are negative, and you put an audience poll for this. Many say continue cefixime for 7 days. I don't know how they arrived at 7 days. In fact, I used to wonder, in most conditions, they have arrived at the number of days of treatment during lunch break or tea break. Most of them don't have real evidence. 3 days for pneumonia, 5 days for dysentery. Most of them don't have evidence. Similarly, 7 days, somebody wants to give and stop. Somebody wants to continue. Most of them want to continue for cefixime for 14 days. Minority want a Vidal, and a minority want to stop. Let me tell you what is the correct answer. None of the above. It is purely a holistic decision. Somebody like Professor Amdekar has to take a shrewd clinical judgment, which should guide you the correct decision. For example, child is very well right from the beginning. Culture is negative. Spleen is not palpable. Child has got better with 1 day of cefixime. Definitely it is not enteric fever. You can stop. On the other hand, spleen is palpable. Okay. Everything looks like enteric, culture is negative. You must know about 80 to 90% only you will get blood culture. In which case, I would continue for 14 days. Holistic clinical judgment is the solution for this problem. Last, an unorthodox view from our unit. In our unit, what we follow as switch therapy for the last 10 years. We give ceftriaxone initially for toxic patients, hospitalized patients. Otherwise, we give only cefixime as OP. We don't use 2 drugs. We always add in Chennai doxycycline, because we get quite a few patients from Andhra who have rickettsial infection. Benefit of doubt, we add doxycycline in case it is not looking like enteric. And the switch therapy we follow is unconventional. The moment the child is better, we stop ceftriaxone, switch out to azithromycin 20 milligram per kg OD. And if relapse also, we treat with azithromycin. We do not use cotrimoxazole or amoxicillin. The reason why we use azithromycin is that our relapse rate is nearly 0. In the last 10 years from our unit, we have followed up cases. Only 1 relapse has occurred following use of azithromycin for the switch therapy. And finally, the antibiotic map in enteric fever is undergoing change. When I was a student, I used to prescribe chloramphenicol. Fever used to come down in 4 or 5 days. In the 90s, ciprofloxacin came. My own professor under whom I worked, he never allowed me to use ciprofloxacin. We used to give only chloramphenicol and plus amoxicillin. Fever used to go on. Without telling him, I used to purchase ciprofloxacin, give to those patients, and within 48 hours, the fever used to crash. Nowadays, the enteric fever does not respond to ciprofloxacin. Ciprofloxacin resistance came in 1997, first reported from CMC Vellore. Now we all know ceftriaxone resistance is there, azithromycin resistance is there, even meropenem resistance has been reported. And this is what we observed in Ramachandra Medical College in the 1990s. We found that 85% were multi-drug resistant. This was in 1990s. 2009, it reversed. Chloramphenicol sensitivity had come back. Nalidixic acid resistant had gone up. This is what has happened. Now, if you give chloramphenicol in enteric fever, it will melt in 2 days. But unfortunately, we have safe reagents. But our own hospital statistics of enteric fever suggest that we don't have problems at all with drug resistance in Chennai. 100% sensitivity to ceftriaxone, cefixime, and azithromycin. Other centers like Mumbai, Delhi are reporting azithromycin resistance. We also checked up with genetic studies in CMC Vellore. We don't know, for reasons unknown, the bugs in Chennai, the enteric bugs in Chennai, they all respond very well to ceftriaxone as well as cefixime as well as azithromycin. Coming to the future, I hope to see India, Bharat, without typhoid. In fact, in Japan, USA, UK, for any fever, they don't consider typhoid as a DD at all. I am praying for those days to come in India. And that will come only because of vaccination, only because of improvement in our economics and hygiene, and of course, control of antibiotic resistance. The moment our GDP goes up, we are going to see less and less of enteric fever. And conjugate vaccine is the best tool because, like, we don't have alternative test to culture. We don't have the perfect vaccine for typhoid. Hopefully, we will have one and we'll eradicate typhoid. A day when enteric fever will become a rare cause of fever, when clinicians like you and me, we should not be considering enteric fever as a diagnosis for somebody who presents with 4 or 5 days of fever. That is the day we should dream. Thank you very much.
Thank you, Dr. Bala, for this wonderful talk. And I have one question before we take questions from other centers. Or let's take questions from other centers. Lucknow, any questions from Lucknow? Okay, while they unmute and yeah, who's
Bangalore?
Yeah, Lucknow, please.
Bangalore?
Bangalore, yes.
Yeah, can I go ahead?
Yeah, please go ahead. Dr. Anna.
Sir, yes, sir, yeah. See, you've been talking about antibiotic policies. Now that we know ceftriaxone can be followed with cefixime, instead of using cefixime, why did you opt for azithromycin? Is it not cefixime is good enough to continue as a follow-up therapy?
My question is
Absolutely correct question.
No, it's
You can see in the principles of step-down therapy, nowadays, modern ID experts allow change from one molecule to another. That is one. Second, azithromycin use has been associated with lesser relapse than with cephalosporins or with chloramphenicol or with other beta-lactams. Third, it's far easier to give a single dose of azithromycin than 2 doses of cefixime or outpatient ceftriaxone. That's why in our unit, we have chosen this policy and we have been successful. I'm not recommending this for routine and we don't do this for anybody who is not culture positive.
But sir,
Hello, sir, I'm from Lucknow.
Hello. Sir, Lucknow wants to come in.
Yeah,
Lucknow.
from Lucknow. I wanted to ask one question. It's very frequent that we get the fever for 4 days, 5 days, who have already been treated with cefixime in low dosage. And then the issue is there, we send the culture report is going to come after 3-4 days. And even if it is coming early, whether it is a growth, some growth is there or not, what is the approach in such cases? Should we continue in adequate dosage of cefixime and go for Vidal test instead of culture? Or there is no scope of Vidal culture at all, Vidal test at all in these cases.
Okay, I knew this question would come up. Vidal had been there for nearly about 7 or 8 decades. It's an indirect antibody test. It has got very good sensitivity, but poor specificity. The reason why we don't do Vidal are as follows. One, in fact, I still remember a joke which my late professor of microbiology used to tell us when we were undergraduate students. In a village, one 90-year-old man died. Everybody was drinking and celebrating, but there was one old lady who was not even related to the man, who was sobbing and crying and crying and crying. So everybody got irritated and went and asked that lady, "Why are you crying? Are you related to this man?" "No." "Do you know him?" "No." "Then why are you crying?" "Stupid fellow. I didn't cry for this old man. When this old man died, I remembered my husband who died 20 years back." That is the story of Vidal. Vidal goes up whenever there had been exposure to salmonella in some form, not necessarily typhoid, non-typhoid and salmonella, gram negatives like E. coli and Klebsiella. So your H titer can go up, even O titer can go up. In Chennai Corporation Schools, Dr. Devanayagam has published in Indian Pediatrics, up to 1 in 160 O positivity can occur in normal children. That is one. Second is, Vidal can be false positive in viral infections, hepatitis, rheumatoid disease, autoimmune disease, even mycoplasma. So there are so many false positives. It is better not to rely on Vidal for diagnosis. Having said that, if you have a properly performed agglutination test from a lab, if Vidal is negative, less than 1 in 160, if after 1 week you have a report with you, it's very, very unlikely to be typhoid fever, but the prediction rates are very low. You have very high yield with back-tuck cultures, automatic cultures today with salmonella. We should not depend on Vidal. We should go by blood cultures. In fact, sometimes when we are in doubt, if the child has received antibiotics outside, it's better to do two simultaneous blood cultures to increase the yield from 2 different sites. 1. 2, go by a holistic clinical judgment. In such a situation like what you said, fever persisting, if I think it is clinically enteric fever, I would continue cefixime rather than stop it or depend on Vidal. So I personally don't like the test, and I have not done it for the last, say, 10 to 12 years.
Bala,
My humble submission is,
there are 2 questions from Delhi. 1 minute, Lucknow,
just a minute.
Sir, my humble
Even
submission-
Kolkata also.
Yeah, just hold on for 1 minute. Lucknow and Kolkata, please hold on. Bala sir, there's a question from Indore here on the chat, which says child with fever for last 7 days, having a report of Vidal O320, H320, vaccinated 15 days back with conjugate vaccine. Are these antibodies because of vaccine or disease?
Vaccine will never produce 1 in 320 titers. I don't think vaccine influences the reports of Vidal. There are no good papers to correlate Vidal test in vaccinated as well as unvaccinated. In fact, this O in 320 within 7 days, I don't know what method, which lab has done the test. I would still go by my clinical judgment and cultures and not by the Vidal numbers.
Kolkata, you may come in. Suman?
There are 2 questions from Delhi as well.
Sir, this is from Kolkata. Sir, you know me, I'm Suman. So, sir, the first question is regarding this blood culture volume. As you said that 10 ml is the minimum required volume for the pediatric segment. Absolutely, we agree to it. But the problem of the company, that is the Backtake or the BD, they recommend the pediatric bottles or PET bottles, they recommend that the maximum volume allowed is 5 ml. Even if someone gives 5 ml, that is enough, and we are getting enough of Salmonella typhi randomly positive. The second, sir, so the question is, so still can we put 10 ml in this normal PET bottle? First of all. Second question is regarding this azithromycin. Is it that it has better post-antibiotic effect, and that is the reason because of this the relapse is less? So these two questions are there. And third, there's a comment regarding HLH. Sir, your take on at least how many percent or what percentage of cases you really find HLH after Salmonella? Because we sometimes see a clustering of HLH cases occurring sometimes following Salmonella. So is there anything that you can comment? So three questions, sir.
Expectedly brilliant questions from Sumant. I think the first question, you are the best judge. I put it as 10 ml only in older children. That
Yes,
10 ml is not necessary for young children. 3 to 4 ml is good enough. As you rightly said, 10 ml, the bottle supplied won't be enough. Agreed. You know more than me, Sumant. That's one. Second is coming to the use of azithromycin. In fact, interestingly, one of the things in fact, in our own hospital, one of the things I did as an administrator, I talked to the microbiologist and ensured, this happened about 15 years back. I ensured that she did not report sensitivity of Salmonella to aminoglycosides. But you would have seen many labs giving reports of Salmonella typhi sensitivity, which includes amikacin, gentamicin. And I have seen people tempted to use ceftriaxone plus amikacin for enteric fever because the lab report has come, sensitivity. The fundamental point that you must remember is that aminoglycosides do not act on organisms which are intracellular. And these intracellular organisms include Enteric and Shigella and Salmonella. So I requested our microbiologist to stop giving reports. In a similar note, I made her even throat swab. I ensured if it is group A beta hemolytic streptococcus, please don't give sensitivity reports. So like that, for Salmonella typhi, azithromycin is a wonderful drug for the simple reason azithromycin achieves very high concentrations intracellularly. In fact, the MIC reported for azithromycin in the labs actually may not truly reflect the efficacy of azithromycin because azithromycin is an organism which is going to be inside the cell. That is why it exerts, as you rightly said, post-antibiotic effect. That is why it doesn't cause much of a relapse. That is question number 2. Third question, what is it that you asked, Suman?
So the third question was...
In fact, to be very honest, I have seen lots of typhoid in our institution, but I've seen only one case of typhoid with HLH. For reasons poorly understood, in our institution,
Sir, we
dengue
sometimes see
and rickettsial infections causing HLH rather than typhoid. We have seen only one.
Sir, we sometimes see clustering of cases. So is there anything?
Human, it is known. HLH, though not common with Enteric, it does occur. Yeah. In the interest of time, can we move on to the next center?
Sir, Chennai, sir. Thank you. Hello? Chennai, sir.
Chennai,
Sir.
please.
So thank you very much, sir, dear SPS, sir. It's always inspiring hearing to your lecture with a Josh. My question is that when we talk about the de-escalation, the question of the oral third generation cephalosporin has been discussed. And whereas considering the relapse rate with azithromycin, you said only 1%. What about the relapse rate with third generation oral, when we de-escalate? Is there any studies?
Literature-wise, the incidence of relapse rate is around 8%. With cephalosporins as well as chloramphenicol is far less. I don't know the numbers in azithromycin, far less with azithromycin. Okay. That's what.
My next question is that related to the vaccine, sir. I think our mentor, Oide Amdekar, is here. He said in one of his lectures that he had never given a single shot of a typhoid vaccine so far in his practice. And what about your comments, sir?
Relating to that, I think a single dose is not seems to be effective.
Now the 2 doses have been recommended. What is your take on that?
Currently, it's a very controversial question. In fact, I faced the music when I was in the ACVAP when we withdrew the second dose of typhoid vaccine. Currently, there is evidence that the immunity lasts for at least 7 years. So second dose, currently there is no evidence to strongly recommend. We need more data. As of today, unless the ACVAP changes this year, with the evidence available, there is not enough data to recommend the second dose. But having said that, I have also seen cases coming after second dose of typhoid vaccine also, typhoid occurring. The best vaccine is yet to arrive. We probably need a more effective vaccine.
Well, thank you. Can we
Sir,
move
there
to
are
Delhi?
3 questions from Delhi.
Delhi,
You
please.
can take. Yes, Dr. Sani.
So I just wanted your comment on the vaccine only. If a child who has been vaccinated with a conjugate vaccine develops enteric, is there any role of a second dose after he's cured? Like that's what I wanted to ask.
There is no data. There is no data on it. That's my answer. I don't know, Vijay, you have any data on it?
No, there is no data.
There is no data. That's a frank answer. We don't have data.
You want to ask?
But
Hello.
if you want,
There's a second question.
Hello.
This is a safe vaccine if you want to give 1 month after the disease, even if it is a relapse or if it is a post-vaccine typhoid. There's no harm in giving, though there's no data in literature.
Yes,
Is there any role of furozolidine in typhoid resistance cases? Furozolidine. Any role?
Furozolidine was earlier reported to be effective. It is like nitrofurantoin. It's a locally acting GI drug. I don't think furozolidine should be given for a child with typhoid because typhoid is a bacteremic illness. I wouldn't be using furozolidine in 2024 when we have so many other alternatives, safer alternatives.
Coming back to the same question on Vidal test, though I completely agree that Vidal test has got very, very minimal role. But yes, today in the era of evidence-based medicine, when we expect that the blood culture is going to be negative in a partially treated case where cefixime has been given in low dosage for 4-5 days, we agree that we send the blood culture, but rising titer of Vidal test, do they help in making an evidence in favor of the diagnosis of typhoid?
Literature does not support your view, sir. Reliance on Vidal is not recommended by experts. The problem with Vidal is that it has to be standardized, it has to be done in a proper lab, it has to be done with a good kit, it has to be done and reported by a good microbiologist. And your so-called 4-fold rise in titer, which you will do after 2 weeks, by which time the fever would have gone, your clinical judgment is probably superior to Vidal. That's my answer.
Let's take the last question from Hyderabad.
Sir, one more question from Lucknow.
Sir, there's one more question from
There's
Delhi.
one more question from Lucknow.
Hold on. Let's go on to Hyderabad. Hyderabad, please.
Sir, good afternoon, sir. Regarding azithromycin, if we started azithromycin as a first-line drug, how many days we need to give? This is one question. And the other one is,
Minimum duration of azithromycin is 7 days. You can extend up to 14 days. In fact, I have given cefixime for 3 weeks also. In cases which have taken long time to respond, we have extended beyond 2 weeks. These are all, 14 and 21 and 10 and 14. The differences are minimal. It's clinical judgment.
Is it rational to start azithromycin as first-line drug instead of cefixime, sir?
First line, I wouldn't recommend for the simple reason it's a reserved drug. If ceftriaxone resistance is going to emerge, we may only have to depend on azithromycin or aztreonam or cotrimoxazole.
Now let's take the last question from Rajesh, which is from one of you.
There are a lot of friends from Varanasi, Pune, Bhagalpur, etc., who have all asked questions on typhoid IgM, IgG, which Bala sir has already answered, and about Entrocheck and Typhidot. And again, all of these were answered, that they are not really reliable and we shouldn't depend on them.
Sir, one last question from Delhi, if you can take, please.
I want to ask one question.
Okay, one question from Delhi. Last question. Delhi.
Last question from Bangalore also.
I think this will.
Jnana.
Can I request, in the interest of time, let's move on with this last question. We'll wind up the session on enteric fever. Delhi, please go ahead. Delhi.
Also one query from Rachi.
Lucknow is still unanswered.
Hello? Yeah, sir, one question is from my side that some patient with a salmonella typhi positive in their blood culture, they are also having thrombocytopenia during febrile phase along with the leukopenia. So child seems to be dull and all, but not having shock and encephalopathy. So should we consider it as a complicated enteric fever and should give the DEXA, or we have to wait for a thrombocytopenia to resolve by own? And second question is that when we are saying that it's a myocarditis or a shock to the patient with an enteric fever that is proven in a culture of a 24 to 36 hours, so what will the maximum dose of a 30 kg kid? Because in a Delhi we are getting a very obese kids. So maximum dose of DEXA for the first dose from the 30 kg 3 into 3 must be 90 milligram.
Okay, to the answer to your first question, in our own series, large series of typhoid, we had seen 25% had platelet counts less than 1 lakh. Thrombocytopenia can occur in typhoid very commonly, in addition to leukopenia. And you don't
But
have
sir,
to
it is
treat
like 30,000,
You
20,000.
don't have to, if the child is not toxic, platelet count is 70, 80,000. And if you have a confirmed typhoid fever, you don't have to treat differently. But on the other hand, if the child is sick and if there are features to suggest HLH or co-infection with malaria, which doesn't occur in Chennai, co-infection with rickettsial infection, co-infection with dengue, that has to be thought of. That is one. Second, I don't know the maximum dose of dexamethasone. Honestly, I plead guilty. I would refer and tell you.
There is going to be more discussion on typhoid in the dilemma session in the end. So let's close this session in the interest of time. Thank you so much, Dr. Balasubramanian.
Last question for Bangalore.
Gyana will take it in the last session. There are more cases of
this
typhoid
is with
within
regarding
last
medical legal aspect. Maybe Dr. Jagdish Chandra can answer this if you could take this question.
We'll answer it in the last session. Thank you so much.
Sir, we can clarify during the last session, whatever query we have now from here.
Thank you, Dr. Balasubramanian sir, for taking this amazing session on enteric fever. Now, moving on to the next session, which is how do I manage a child with respiratory symptoms? Now, for this next session, I would like to welcome our esteemed speakers, Dr. Jagdish Chinappa sir and Dr. Prakash Vaidya sir. Dr. Chinappa is an acclaimed pediatrician with more than 44 years of experience in the field of pediatrics. He presently practices at Manipal Hospitals, Bangalore, in the Child Central Clinic and Pediatric Daycare. Dr. Prakash Vaidya is a senior pediatrician with special interest in pediatric pulmonology, Fortis Hospital, Mumbai, and Child Health Clinic, Mumbai. He is a joint national convener, Asthma Training Module, Revision 2021-2022, co-convener and writing committee member of Under 5 Visas Module of IAP, national trainer for IAP NTP TB Module, NRC Cuff Module, and past president of IAP Thane branch. I welcome our esteemed speakers and I request the presentation of bouquet and memento to our esteemed speakers. I will request them to take over the session, sir.
Hello, audible? Yeah.
Hello.
Yeah. Yeah. Thank you very much, Dr. Vijay Avle and the organizers, respected Dr. Amdekar, and all the participants from all the centers. We've had a wonderful session in the last two sessions here. They have been absolutely very informative. So let's go. What we have decided between the two of us, between Dr. Prakash Vaidya and me, is to go through some of the cases quickly so that we can highlight some of the respiratory issues. Now, we'll start with the first case. Yeah. The 4-week-old baby brought with cough for 2 days, no recorded fever. The term baby Neonatal period is uneventful. Weight gain is appropriate. Child has a nasal discharge. Throat, ear, and chest is clear. Weight gain is appropriate. Feeding well on breastfeeding only. Do you need any more information if you see a child like this in the clinic? You can say no or yes if anybody has any questions. No, there's no breathlessness. This child chest is clear, throat is clear. No, there's no vomiting here. Weight gain is appropriate. Occasional possetting is there, but no vomiting. Breastfed only. Family history of cough. Mother has some cough, but nothing significant. Frequency of cough. Okay, frequency of cough. Okay, very good. Well, Dr. Prakash, any more question? Any more you want?
Yeah, I think they've answered. But would you like to know a history of illness in the family? I think somebody mentioned.
They
that.
mentioned that.
Yeah.
Yes. So okay. So I think here we asked for some more questions. The mother was not vaccinated against AP during pregnancy. Father is a smoker, so environmental history is important. This child has been using sambrani. Sambrani is that smoke which they put to dry the hair.
Dhuri.
The massage lady uses oil to clean the nose, and the baby had eye discharge a week back. Elder sib had cold and cough. So does this change your change what you want to look at? Okay. So now what would you do in this situation? You have nasal aspiration with saline and nasal drops, nasal aspiration, saline nasal drops, and oral ambroxol. Add azithromycin to that, and add breast milk in the nose. Some people put breast milk in the nose. And finally, you have nasal aspiration, saline nasal drops, and review in 24 hours. You can start voting now. So this is a common problem. So Dr. Prakash, what would you do here?
I think, let's see what.
Yeah.
So the best thing is to observe the baby, especially if the baby is very small. Yes, you certainly can put nasal aspiration and you can do saline drops if the block is very severe. But otherwise, nothing beyond that. There are only 2 points I want to make. One, even in this day and age when the drug controller has banned combinations, we do see usage of chlorpheniramine as well as phenylephrine, even in this age group. That's strictly a no-no in a small baby. The other thing is, what do you think of the possibility of using xylometazoline drops in a small way? I would not personally use it at this age.
Yes, no medicated drops at this age. Saline is more than sufficient. The one thing which I've seen very often is not used is a good nasal aspirator, because babies are obligate nose breathers. And if their noses are blocked, they cannot feed well. So now cleaning the nose is an art which has to be taught to the mother. And there are 2 ways of doing it. One is to use a nasal aspirator, a mechanical aspirator. The other is to use what is called as a Frida's mouth aspirator. That is, it is a small little bulb where the one end goes into the baby's nose and the other end goes into the mother can suck out the mucus. Now, both these are acceptable, and the mother must be taught how to clean out the nose, especially if it is blocked. And the mother rarely knows how to use it. So demonstration is important. Because one side has to be closed, saline has to be installed, and the nose has to be cleared. So this is a very important thing that has to be taught to the mothers in a nasal block.
So physical measures and not medication. This is the take-home.
Absolutely.
Yes.
So that can we give a message that we can put nasal saline drops only if there is problem in feeding, rather than blanket prescription of 3 times a day, 4 times a day. As you very rightly said, if it is causing a problem in feeding, you should put. Otherwise,
prior to feeds is the right thing if there is a problem in feeding. Okay.
Prakash, ambroxol you have mentioned.
So ambroxol also, there is really no evidence that it helps. We would certainly not be using ambroxol in any child, and also most certainly not the other 2 that I mentioned, that is CPM as well as phenylephrine. Absolutely contraindicated.
The only thing that the ambroxol does is it's a good placebo, but it's better to be avoided completely. So we'll come to that, I think, a little later. So the best investigation in such a situation is a good follow-up. Now come to the next case. This has been discussed partially, but we'll go through this again. It's a 6-month-old baby, comes with fever, rhinitis and cough for 2 days, developed fast breathing since a few hours. There's a few retractions also. It's a term baby, 3.2 kg at birth, vaccinated for age, growing appropriately, is breast and bottle fed, is well grown and nourished, crying unconsolably, Respiratory rate is 70 per minute. Retractions are there, subcostal and intercostal. There's some degree of wheeze bilaterally. Do you need any more information here? Saturation, very good.
Okay.
Anything else? History suggests of aspiration. This child has started off with a viral infection with fever, rhinitis, and it is a progressive respiratory condition.
It
So,
did start off suddenly as a sort of aspiration story. Yeah, feeding quite well.
is
No.
breast and bottle fed. Yes, very good. So feeding needs to be asked. So here, there's a season of bronchiolitis. Many children are coming with some similar history. Saturation, as somebody asked, is 90%. There's a family history, positive family history of atopy and a positive past history of atopic dermatitis. So I think the important thing is to ask for basically two things, any antecedent history and also the severity in terms of feeding, saturation, and the seasonal component. 6-month-old. Yes, the child can have even before.
That's a point well taken.
Yeah. So the options here are supplemental oxygen and breastfeeds, admit for observation, trial of nebulized salbutamol and breastfeeding, nebulized salbutamol, ipratropium, oxygen, IV fluids, and don't feed the baby, nebulized hypertonic saline, oxygen and breastfeeding, oxygen, IV fluids, and breastfeeds. Right. So two questions here. One is the use of salbutamol. Is it necessary in patients with bronchiolitis, in babies with bronchiolitis?
So I think most protocols will say that a trial of salbutamol is permitted, but if it fails, do not persist with salbutamol. And the salbutamol may not work, especially if there is no bronchospasm in the first place. And it is more likely not to work in the first episode. If a child has got recurrent episodes, yes, we know that he's got reactive airways, but one trial of salbutamol is surely permitted.
Okay. And the other thing is regarding hypertonic saline.
So I think the most difficult problem in bronchiolitis, especially when you admit a child, is to do nothing. Because this is where really you face a barrage from the parents. What are you really doing? So we are tempted to give unnecessary things. Hypertonic saline, there has been a lot of study. The jury is still out. We still do not know whether but the Cochrane reviews clearly say that there is no clear evidence that hypertonic saline works. It has worked in a few trials. So I think maybe a short trial is also permissible.
Yeah. So I think as Dr. Prakash mentioned, the trial of salbutamol is because there's a history of atopy in the child previously. So you could try salbutamol, it might work. As far as hypertonic saline is concerned, the current recommendation is that it has no effect at all. So you may use it and try it. If you think that it works, then you can continue using it.
Ipratropium in bronchiolitis, there is really no evidence and no data for that. So there was a thought that beta-2 receptors are not present in such small children. That was in the past, but now we do know that even younger infants do respond to salbutamol if there is airway reactivity. So yes, there is a role at this age as well.
Epinephrine is primarily useful for upper airway obstruction. And if you have a child with significant croup, then epinephrine will work. But it rarely works in bronchiolitis, where the obstruction is lower down. Okay. This is a 1-year-old boy with rhinitis, fever, and cough 10 days prior to presentation. Now he has a purulent.
Can we come in from Kolkata 1 second?
Yes, please.
Yes.
Sir, this is Pallav from Calcutta. Your choices said only 2, but in bronchiolitis, I think oxygen is the one that we should always keep. So that should be our option also.
Yeah, I think the oxygen was there.
It was there. No? Oh, no.
In your choice, no? Your choice, you said only, yeah.
Pallab, of course, at 90% SpO2, 100%, we will definitely be giving oxygen. I think that was a mistake.
Yeah, yeah.
Okay.
Yeah, so this is a 1-year-old boy with rhinitis, fever and cough 10 days prior to presentation. He has a purulent nasal discharge, no fever and dry cough when he sleeps. There is no wheeze. He is feeding adequately. He has been immunized for age except for the influenza vaccine. There's adequate growth and development. Ears are normal, throat is congested, and he has few posterior cervical nodes. Rest is unremarkable. Do you need any further information here? So this is the end of a cough and cold. He comes up now with a purulent nasal discharge, but no fever and a dry cough. So there's a family history of similar illness. He goes to daycare, has taken a course of azithromycin. Mother says he falls sick often with coughs and colds. She feels guilty of not giving the influenza vaccine. So what are the options here? Would you give oral coamoxiclav for 10 days because he's got a yellow discharge and 10 days are over now? Admit and start with ceftriaxone. Investigate for immunodeficiency. Saline nasal drops and review in a couple of days, or start azithromycin with coamoxiclav.
The point we wanted to make here was that merely the presence of a purulent discharge or a greenish discharge is not a peg on which you can hang your antibiotic therapy. That's one thing. Why do you get a purulent nasal discharge? A, because the leukocytes go up in the secretions after some time, and B, there are some enzymatic changes. So these alone, these two things are not a reason to start antibiotics. As the right answer would be just observe. Unless there is features like toxicity, fever, tenderness, sinusitis features, you will not be starting antibiotics.
Yeah. So just the presence of a yellow discharge doesn't mean that you need to start antibiotics. Okay. Purulent nasal discharge can be seen at the end of a viral infection, especially on day 10 onwards, and then you don't need to start an antibiotic just by the presence of a yellow discharge. Okay. Now this is a 8-year-old child. Comes with fever, mild on day 1, 2, worsened for 3 to 4 days, better now, cough and wheeze from 10 days onwards, on coamoxiclav and bronchodilators with little response, has severe ear pain now for the last 1 day. He's been immunized, past history is not contributory, he is well nourished. And this is the eardrum which you can see here. So do you need any more information from this? Anybody? There's no past history of wheeze. There's insidious onset with rhinitis and cough, progressively worsening cough, no skin rash or oral ulcers here. So options are: 1, wait and watch with symptomatic treatment, refer to the ENT, send off an upper respiratory biofire, send blood tests and start a macrolide or a doxycycline, admit and start ceftriaxone.
Jagdish,
Well,
you only take it up.
Well, no, they're still voting. I don't think we can have a dictatorship, no? Well, Dr. Prakash, what would you do?
I would agree with the first one. Now, there have been some studies where they say that now, Dr. Jagdish showed a picture of bullous myringitis. Now, there have been studies where certain association with macrolides, with mycoplasma is there. But in my opinion, it is neither specific nor sensitive for mycoplasma. Would you, what is your comment?
I think the important thing here is to look at the progress of the disease. If you look at it, this child is an 8-year-old. So otitis media is relatively uncommon at that age. That is one. Second is it has started with significant cough and wheeze. So coughing and wheeze means that is significant airway involvement. Third is there is no response to comoxicilla which has been given. So it's unlikely to be pneumococcal in origin or or H influenzae. This child has severe ear pain from one day. So a bullous laryngitis comes with a very severe ear pain. And therefore, this probably fits into mycoplasma as the possible cause of bullous laryngitis. Because bullous laryngitis comes with three organisms. Either it can be viral in nature, pneumococcal, or mycoplasma pneumonia. And here, the progress suggests that this is probably mycoplasma. And with severe pain, I would start this patient on either macrolides or doxycycline.
How would you separate from virus?
Yeah, the point is the time frame. If the viral infection had started on day 1 and this child had worsened on day 2, 3 with a ear infection like this, then the diagnosis is most likely viral. But this child has recovered reasonably well from the initial infection and landed up with a severe problem on day 8. So therefore, it's more likely to be mycoplasma here. Here, antibiotic first and then watch. If there is no response, then what you need to do is to just open up the bulla, because that is where the pain is coming from. It's basically on the symptoms that this child progresses with. What is odd is that it is not fitting into the pattern. That's very important to note. One is that the age is not right. The onset of the respiratory symptoms and development of otitis media, there's a 1 month gap. So which seems odd for any ear infection, because in ear infection, the moment the child starts off with a cough and cold, within 48 hours, you will have a ear infection. Here, it's come after 8 days. And the pattern of what you see on a otoscopy is definitely odd.
I think the bottom line is we should all be doing otoscopies. That is something that is not yet universally practiced.
And recorded. And otoscopy can be done by many people, but the recording is important.
Right.
This is a 7-year-old with cough and mild fever since a month. Started with fever and cold. Had throat pain initially. Was treated with initially with no antibiotics for 2 days. Comoxicilla for 3 to 8 days. Azithromycin for 8 to 12 days. Fever is now occasional. Cough is very bad, disturbing sleep. The child has taken cough syrups, nebulization, Montelukast, honey, CBC shows mild leukocytosis. CRP is high on day 3. Vidal is negative. X-ray test is normal. Mantoux test is 10 millimeter positive. Yeah. Initially started with cough and mild fever, subsequently persisted with cough through. It's a single episode lasting more. No.
It's not intermittent.
It's not intermittent. Not significant weight loss. No significant weight loss. Any other information that you want? Headache? No headache.
What about ESR? ESR.
What about the ears? What
Yes,
about
sir.
the
ESR?
ESR? I will come to that. So past history, no major illness. Family history, no TB. The nature of the cough is wet. There is no exposure to environmental pathogens. Travels to school in an auto. Is immunized except influenza.
Sir, is it a case of persistence since it is a wet cough and history?
We'll come to that. We'll come to that. We are going to give you the options. So what would you do here? Admit and start nebulized steroids and ipratropium with salbutamol and ceftriaxone. Do a PFT and decide. Admit for gastric aspirate ball. Refer to a pulmonologist or give a course of comoxicilla for 2 to 4 weeks.
Bye.
Yes, sir. Dr. Prakash.
So PBB is a very likely thing here, considering that there is wet cough. But let's remember two provisos for PBB. One, the cough has to be going on for a month, and there should be no other explanation for that cough other than, like, for example, this child should have a normal growth chart. And since Dr. Amdekar is in the audience, and we always remember, sir, how you have brought it out in the open that if you do not have growth charts, you're not practicing pediatrics, you're practicing adulterated medicine. So I think we should all remember that growth charts have to be there. If the child has not lost weight, the growth is fine, and there is no other explanation for the wet cough, then PBB is your answer. But I'll just take one small corollary here. It was a 7-year-old child. What about a child of 3 years? Can we really, because PBB can occur at that age, can we in practice say that a child of 3 or 4 years have wet cough?
Yes, I think the important thing is the nature of the cough is very important.
Yes.
I think we can classify cough into 3 ways. One is you can look at whether it is acute or chronic. And chronic means it persists beyond 4 weeks. And basically, we are dealing with that particular segment of children who cough beyond 4 weeks on a continuous basis. That is one. The second is to look at what is called as dry cough or wet cough. If you have a predominantly wet cough, then you would put this as a wet cough, which is chronic.
No,
And the third thing, wait, I'm coming to that, wait. And the third way to classify a cough is when you know a specific etiology is there, like you have a postnasal drip, or you have a reflux, or you have a specific diagnosis. And a non-specific is where you don't have a clear diagnosis. So if you have a chronic cough lasting more than 4 weeks, which is wet, and you don't have any other diagnosis, then the most likely diagnosis is PBB.
Sir,
No, my
would you
question
still
was-
like to do a gastric aspirate staying in a country like ours.
Yeah.
It's worthwhile still doing a gastric aspirate and rule out. I mean, of course, you can give co-amoxiclav for 2 to 4 weeks,
Yeah.
but simultaneously, wouldn't that also be a good
Would you,
idea?
would
to
you
do
do
both?
would you do a gastric aspirate first or give a co-amoxiclav first? See, if there is a dry cough which is persistent with a suspicion of tuberculosis after doing an X-ray, then I would do a gastric aspirate first. But if this is a wet cough, which has no other, which is a phlegmy cough, which is lasting for more than a month, then I would treat as PBB first. If there's no response, then go ahead with the gastric aspirate.
My little tangential question was, can you say whether a 3-year-old child genuinely has wet cough if the parents say so? So yes, you can, because there has been studies in Australia where they have said that parental history is very reliable for wet cough. And what are the things that they look for? A, that you look for gurgling sounds in the chest. If they are there, it could well be. And the second thing is that when you auscultate such children, often there are crepitations. So these are the pointers that this could truly be a wet cough. And therefore, even a 3-year-old child with with a 4-week history of persistent cough, with a little phlegm or with these symptoms, would qualify for a trial of co-amoxiclav or an equivalent antibiotic for at least 2 weeks before you go on for any invasive tests.
Thank you. Thank you.
Yeah.
Any other
Sir,
comments?
I have got one query. In persistent bacterial
Classify cough basically into 3 groups, whether it is dry or wet, acute or chronic, and specific or non-specific. And if you have a non-specific chronic wet cough, most likely diagnosis would be PBB. Okay. Now,
Chinappa, sir.
yes.
I have got a query. Are we justified in giving?
We will come to that in the next.
Yeah, it will come in the next.
We have some chronic.
And second suggestion was there for NTEP, unless until we give 2 weeks of antibiotics in history suggestive of tuberculosis, then we are going to do for gastric acid.
Beg your pardon. Sorry. Can you please repeat the question?
No, it wasn't a question. My queries were in persistent bacterial bronchitis, are we justified in giving antibiotics before pulmonologist opinion, or whether the bronchoscopy is essential? And second suggestion was there in NTEP, in the flow chart, we are saying that in history suggestive 3 cardinal symptoms with weight loss, we are supposed to give antibiotics and then think of gastric aspirate.
Yeah,
Yeah,
absolutely.
Protocol does say that you give 2 weeks of antibiotics here in cases of suspected PBB, which fits in your guidelines, that there is a 1-month story, there is wet cough, and there is no alternative explanation for that. So I think that is enough to give a trial.
Yeah, I think the other point which he made was regarding PBB, bronchoscopy is not mandatory.
No, it is only mandatory for repeated PBB,
Absolutely.
not for first
If you have
episode.
either non-responsive or repeated PBB, then you can do a bronchoscopy. Otherwise, bronchoscopy is not essential for a PBB.
Shall we go to the next case? In the interest of time, we have a number of cases. So this is a 6-year-old boy with recurrent runny, itchy nose for 1 year, mouth breathing and nose block at night. And parents are now worried that he snores heavily in his sleep. Do we need more information on this?
What
Beyond
type of
this-
snoring is there?
Yeah.
That is one of the important, whether he's having snorting or there is a apnea in between. So video recording of this snoring is very important in this child.
Yes, yes. So you want to know the history of the sleep pattern. How does he sleep? So that's a
Yes.
good thing. Yeah. So let's have first, we'll come to that. Let's have a multiple choice here. These are the 4 options. Snoring is always abnormal and needs treatment. 10 to 15% of all kids snore normally. Absence of snoring rules out OSA. And all children with snoring must undergo X-ray nasopharynx. Which is the right statement here? And your time starts.
A, B, C, and D.
Yeah, I think why did that come?
I think the correct answer is 10 to 15% of all kids will snore at some time in their childhood. So which may be normal. And again, snoring is of different categories. You can have children who snore, what is called as benign snoring, without any airway obstruction. The second can have snoring with airway obstruction. And third is the most severe one, is snoring with breathing difficulty or apnea. So basically, if you follow up children, many of them may snore, but that may not be significant. Yeah.
So almost this many children snore regularly. Now the last one, many of us have the habit of asking for an X-ray nasopharynx. Now as more and more evidence has come, we find that this is not a reliable test. Because if there is a sleep problem, it occurs in REM sleep and in the child in the sleeping position. This X-ray is taken with the child wide awake and in the sitting position. So that does not really reflect the diameter of the nasopharynx or any compression at that time. Secondly, the size of the adenoids is not a reliable indication of OSA. So therefore, X-ray nasopharynx is of very, very limited value. You want to add
Yeah,
something?
I think the important thing here is
Jagdish?
again the neck position will change
Dr.
the
Jagdish?
size of the adenoids. If you have a
Dr.
flexed
Jagdish?
neck, you'll have a larger adenoid. If you have an extended neck, you'll have a smaller adenoid. So it's not a very good sign, a very good investigation to do. Yeah.
Dr. Jagdish from Bangalore.
So let's continue this case. This child was somewhat 19.5, BMI of 20.3, vitals normal, hypertrophic turbinates, pale nasal mucosa, moderately enlarged tonsils, and a high arched palate. That was the clinical picture. How will you investigate? Will you do a X-ray nasopharynx, a sleep questionnaire, pulse oximetry, polysomnography, or audio or video recordings? Audio video recordings. So yes, it does give some indication of the problem, but basically the diagnosis comes on polysomnography, which is really not a enough used test in our country. By definition, the diagnosis of OSA comes on polysomnography. However, there are other things which might point out. So you want to add something, Jagdish?
Yeah, I think the important thing to note here is that there are multiple issues in this child. The first thing, this child starts off with an allergic rhinitis. Second thing that is happening here is that this child is slightly on the BMI is on the higher
He is
side.
obese.
He is obese. The third thing that is he's got some craniofacial anomalies.
Yes.
Because he's got a high-arched palate, etc. So basically, we need to find out what are the components which are causing this obstruction. Now, for example, if you do an X-ray nasopharynx, it will only tell you about the size of the adenoids, nothing more. Sleep questionnaire will only tell you the quality of sleep and nothing more than that. A pulse oximetry is not a very sensitive thing because for the simple reason that you need continuous oximetry monitoring with a Massimo oximeter, which will pick up not intermittent oxygen tracings, but a continuous oxygen tracing. So that is important, which is rare, which is not easily available. and audio video recordings are good as screening tools. But if you want the gold standard, it is a polysomnography. A polysomnography will clearly tell you what is the quality of sleep, what is happening to this child during night. So it's important that polysomnography is used more often to delineate obstructive sleep apnea, which is the thing which you are looking at.
Chinappa sir,
Yes.
if there are no good sleep labs available, whether the direct nasal endoscopy will help in whether dynamic obstruction is there. Of course, we understand if sleep lab is there, polysomnography is correct, but whether the endoscopy will help us.
Endoscopy again will tell you only the adenoidal size, but it will not tell you what is happening dynamically when the child is sleeping. So it's good for defining anatomy, but not for looking at the pathophysiology. If you want to look at the pathophysiology of what's going on, only a sleep study will tell you what.
So as we pointed out, that it is the dynamics that matters, because whatever is done, even if it's an adenoid size which is large, it is shown in the waking position with the person erect. What really happens in sleep is that there is so much hypotonia. In REM sleep, there is profound hypotonia. And that is the time when you start getting OSA. So you need to do a study which reflects that situation rather than a study which reflects the waking situation. Okay, so how will you manage? There are 4 choices. A trial of antibiotics plus second generation antihistaminics. B, tonsilloadenectomy ASAP. C is INS plus Montelukast trial for 8 to 12 weeks. And D is trial of saline nasal drops plus Montelukast levocetirizine for 8 to 10 weeks.
Yes, sir.
So basically, this is mild to moderate OSA. Now, this definition actually comes from doing a polysomnography where you see the hypopnea to apnea index. That is the AHI index. Now, if the index, but even if you don't have, if the child is very severely affected, wakes up during sleep, choking, this is what the parents will tell you. There, of course, it is tonsillectomy ASAP. But in a mild to moderate case, there is a strong role for giving INS plus or minus Montelukast trial for 8 to 12 weeks and then review the child. Yes, Jagdish?
Yes, I think the important thing here is tonsillectomy and adenoidectomy could be a good choice in this child. But what we know from this history which you have given is that this child has got some degree of allergic rhinitis. And therefore, we know that Montelukast and intranasal corticosteroids are good choices when you have OSA associated with an allergy, because that will reduce the inflammation in the nasal passages. So I think the important thing is, one, the cause of the OSA. If there is an allergic basis, then this will probably give a good relief to the child. That is one. The second important thing is that this child, we do not know whether this child has got obstructive apnea. If this child has apnea significantly, then this B may be a good choice. Do a tonsillar adenoidectomy straight off because he's got multiple morbidities. So that's the second thing. The first one, antibiotics are not needed at all here because there is no role for antibiotics. And finally, saline nasal drops with Montelukast and levocetirizine for 4 weeks is not optimal. You can use saline drops if it is just a nasal block. But Montelukast levocetirizine is not a good choice.
First of all, levocetirizine Montelukast combination is not approved by any guideline. If you're giving it, give it separately. And certainly you don't want to give levocetirizine for such a long time. So best to give Montelukast separately and levocetirizine as needed if you need it. But in this situation, the right choice would be INS plus Montelukast trial, unless it is very severe OSA as defined by polysomnography, or if the child really gets up gasping every now and then of course you won't wait, you'd probably go for a tonsillectomy ASAP.
Sir, here I have got one question.
Sir,
patient has got craniofacial anomaly like Barrett and moderate ASA. So
there have been,
will you not advising tonsillectomy, adenoidectomy along with nasal corticosteroids?
So even when you do,
Tonsillic adenoidectomy.
I think,
is it Dr. Ramakan? Yeah.
Yes, sir.
Even when you do nasal, when you do adenoidectomy and tonsillectomy, you do continue to give nasal steroids for a period of maybe 1-2 months after the surgery. To answer Dr. Bala's question, there have been studies which looked at only INS, there have been studies which looked at only Montelukast, and there have been 2 studies which looked at both together. So the efficacy of both together was found to be a little better than using INS alone, which is why we opted for that choice.
okay, let me
Dr.
also
Jagdish,
answer. Yes.
Dr. Jagdish from Bangalore.
Yeah.
Is it not enough if we just give only international steroid? Because
Yeah.
Montelukast, we have our own problem in using it.
Yes, I think there are pros and cons for both. The reason for using intranasal corticosteroids is the studies which have shown both reduction in adenoidal size as well as in the nasal mucosal congestion after intranasal corticosteroids is much better than Montelukast. As far as Montelukast is concerned, there are contradictory statements on the use of it. The reason for using it is because there are leukotriene receptors found in the adenoids, which are independent of an allergic response. And therefore, there may be a use for Montelukast independently. However, another problem with Montelukast is it also disrupts sleep. So in a child who already has a disrupted sleep, Montelukast may cause a problem. So what you need to do here is to probably start off with both. And if there are issues with Montelukast, you can take it off.
And I think if somebody has reservations on Montelukast, it is perfectly fair to give only intranasal steroid.
Absolutely. Yes.
Sleep lab, how does one manage hypertrophic adenosis?
I think you need to get a sleep lab. That's important.
Okay, let's take the next case. This is a 2-year-old boy with recurrent episodes of cough and wheeze, bronchiolitis at 6 months, admission once for so-called Walrai viral pneumonia, 2 ER visits for asthma, reactive airway disease, many consultations for chest congestion, and this is clearly a child with recurrent wheeze. So what is recurrent wheeze? Would we just have a quick, what do you mean by recurrent wheezer? Any definitions from the audience here? When do you label it a recurrent wheezer? So now there are many definitions. Some people will say recurrent is more than 3 episodes in a lifetime. Some will say in the past year. But I'm sure most of us do see people with at least 3 episodes of recurrent wheezing through the year. So I'll continue this child, playful, active child, no family history of asthma or allergy, normal growth chart, no allergic markers. Do you need any more information before you treat this child? Are we happy with the information and we go ahead? Yes. I think it was 2-year-old child.
2-year-old.
Any past history of atopy in the baby child?
Past history of?
Atopy in the child.
No, no history of atopy. No history of atopy.
Or at birth,
Was he in creche or daycare?
birth was it normal? Any birth history?
Birth history was uneventful.
Uneventful, okay.
Yeah. He was in a creche, yes. How will you treat this child? There are some...
Investigate.
How will you investigate? X-ray chest, MANTU, serum total IgE, somebody who is sophisticated and has access might do an impulse oscillometry, or just wait and do nothing of the above.
None of the above.
So most of us would not investigate.
I think you should do an IgE. What do you say, Doctor?
See, total IgE alone has absolutely no role in any of this. If you want to do a specific IgE, looking for a thing, that's a different story, not total IgE.
So again, this only tells you that there is probably a history of some atopy in this child. It doesn't tell you that atopy is the cause of the symptoms in this child. So just doing an IgE is not going to help you in any way at all. What about doing a MANTU test?
So today, most of the protocols, NTEP, really there is no role of the MANTU test at all. It only...
Nobody voted for MANTU. That's reassuring.
That's a very good thing, because MANTU is only and only for latent TB, and that it's not coming, does not come in the diagnostic algorithm of TB in any which way. Okay.
And what about impulse oscillometry?
In 2-year-old child.
Which tool or of this practice?
Doable. It is doable.
It is doable, but I think its cousin brother is now available, the forced oscillation technique. So I think that is also coming in now. And
so even if FOT were available or IOT is available, would you do it? The answer is no, not in this child, which is a clear recurrent reason. So what do you go from here then? What do you do here? How will you treat? You're not investigating. How do you treat? So will you nebulize with levosalbutamol, ipratropium, the old favorite, or would you give salbutamol by MDI and trial of budesonide, or oral bronchodilators plus montelukast plus levocetrizine, or as needed antibiotics and nebulized budesonide? I think all these are done in practice. Please vote. Perfect, I think. So absolutely right that we will first give salbutamol by MDI and do a trial of budesonide. Would you like to just clarify what is trial of budesonide?
Trial of budesonide, you give it for, basically this is a preschool visa. So in here, what you would do is give a 12-week trial of budesonide and see what the response is like. If the child has responded very well, then you might choose to continue. If the child has not responded, take it off.
So I think one take home here is that if you are starting inhaled corticosteroids in a child below 5, it has always to be as a trial, and the trial lasts for 3 months, after which you suddenly stop. You don't want to taper it off and then take a call depending on the outcome.
I have a question, Prakash.
Yeah.
Suppose the child responds well to 3 months trial and then comes back wheezing. What do you offer? A week of salbutamol and 2 weeks of budesonide, or only salbutamol?
So there are two options here. If the child does a trial, does well during the trial and promptly comes with another infection, you will, or with another episode, you treat it with salbutamol.
Only salbutamol?
Yes, but if keeps on getting again, you may consider a second trial of ICS, or you may put him straight away on the step of treatment as per GINA guidelines.
That second trial would also again be for 3 months?
For 3 months.
So how will it differ from MART? Can be said that this will be MART?
MART is basically above the age of 6 years, not below the age of 6 years. Though most of the MART trials are above the age of 12 years. So right now, it has come down to 6 years. It may come down even further. But right now, the usage of a long-acting beta-2 agonist with a inhaled corticosteroid is only recommended above 6 months.
MART is an excellent option, but as of now, GINA guidelines advocate it only above the age of 6 years, as Jagdish said. But it is quite likely that with more and more studies, it may become approved for a younger age group. But today, at younger age group, it is an off-label therapy, which is, of course, sometimes used in practice.
Yeah, but the important thing, again, in under 6 years of age.
Just wanted to say something.
No, I was just saying that second 3-month budesonide is not a trial now.
It is a second trial.
How is it a second trial? You've done a one trial, he's got better, so he fits into the person who needs a preventive therapy.
So you have an option there of straight away assigning him into the step of GINA guidelines, but literature does mention that there is a possibility of a second trial of ICS. That is mentioned in the guidelines. So now to come to cough. Cough can be classified in 3 ways: acute, chronic, dry, wet, specific, non-specific, as Jagdish said. What is chronic cough? Chronic cough is cough of at least 4 weeks duration. So let's take up a case here. A 10-month-old girl born of non-consanguineous marriage with frequent cough and wheezing started from the 2nd month of life, failure to thrive, off and on loose motion since the 2nd week of life, and poor response to inhaled salbutamol and an ICS trial that was done. Do we need any more information here?
Yeah.
We have given enough information. Pardon?
60%.
So, which option is, if this is basically a child with chronic cough and failure to thrive, which are the options possible and which is not likely in this? So this is where we vote for it. No, I'm saying which is the wrong option. So is it cystic fibrosis, PCD, uncontrolled asthma, child with interstitial childhood lung disease, or IgA deficiency?
Uncontrolled asthma.
Okay, let's vote.
Yeah, I think.
Please vote. Oh, no, sorry. I put the cat out of the bag.
I think IgA deficiency and uncontrolled asthma both are correct answers because both of them rarely come with failure to thrive. And uncontrolled asthma at 10 months is a wrong diagnosis in the first place.
So there is a one. So if it's an older child with uncontrolled asthma, you can conceivably get growth failure.
Yeah.
But asthma usually doesn't have growth failure, but IgA deficiency is not associated with failure to thrive, whereas all the other conditions are. So that is your clinical judgment of looking for a child with chronic cough and failure to thrive. So which investigation here is not likely to give us any useful information? Huh?
Allergy test.
Yes. So, yeah. So we look holistically, but the question was only for failure to thrive with chronic cough. In the case. So which investigation is not going to provide useful information here? Please vote. Not working? I think some failure of.
Question is not launched for voting.
Okay. There is a lag. Jagdish.
I think the audience has answered absolutely right. 91% have said allergy testing is of not much of use at all. The other three, of course, are very important because the most likely diagnosis in this patient is probably cystic fibrosis. And at 10 months of age, doing sweat chlorides is not that easy, but it can be done, no problem. And now if you can't get a proper diagnosis with a sweat chloride, then exome sequencing is probably the thing of time.
So now when there is chronic cough, we are all tempted to do trials. Now these are the various trials that you think of. Which trials are not valid? AKT trial, azithro trial, bronchodilator trial, PPI trial, ICS trial. There can be more than one correct answer. So, people use azithro. Chalo, let's see if it works. So is it permitted? I'm seeing. Okay. Yeah. So for one thing, AKT trial, complete no. That AKT trial has gone into history now. We never talk of AKT trial. AKT treatment is always based on sound microbiological evidence as far as possible. What about azithromycin, Jagdish?
Absolutely no. Azithromycin should not be used indiscriminately as a trial drug.
Bronchodilator trial is certainly permitted for the reason that the child may not have bronchospasm when you actually auscultate, but he may have a variable bronchospasm at other times. So giving a trial of preferably inhaled bronchodilator is permissible in chronic cough. What about PPI?
PPI, many people have tried it especially in infants with chronic cough and wheezing, considering GERD as a possibility. But more and more, we now know that PPI has significant side effects, and therefore it should not be used as the first line for as a trial basis.
Yeah. So there is something called as therapeutic creep, where PPI has crept into our treatment, but PPI cannot be used randomly unless there is real strong evidence of reflux, and that too there are a lot of reservations in that. So PPI is not a trial. Lastly, ICS trial. Yes, in the algorithm of chronic cough, they do mention that a trial of ICS is permitted to look for evidence of airway reactivity, which is reversible, and that can be given, and then thereafter you go on the algorithm for investigation. Now, to take up Dr. Bala's question on specific, what was your question, Dr. Bala, in the last?
What is specific cough and non-specific cough? Yeah, when you have a definite...
Yeah.
Yeah, if you look at the paper which presented by Ann Chang and subsequently by a couple of other authors, the non-specific cough is cough where you don't have an obvious etiology like an upper respiratory infection and which progresses, or you have some other etiology which is identifiable on investigation. So when you have nothing like that, it is a non-specific cough.
Okay, I think we'll quickly, let's take this case. What?
Talk about the trial of ICS. We are talking about 3 months, that is 12 weeks. What about a trial of bronchodilator? How long do you go?
Maybe for a week or so.
So-
See if it works.
And is it a good idea to start with both and then stop the salbutamol or the bronchodilator?
I think the point which you're mentioning is if a patient comes to you with wheezing, obviously you're going to give him a reliever medication. So that is a reliever medication, but the decision to give an anti-inflammatory medication like a steroid will be on a trial basis in a baby who's under 5 years of age and who comes to you for the first time.
Yes, sir.
So that's a trial. Because you're giving it for a longer duration. You're giving it for 3 months. Whereas this you're giving only for relieving symptoms for maybe a week or less than that.
Yeah, so in the previous MCQ where you mentioned trial of bronchodilator, you meant it for 7 days or
Correct,
so, right?
correct.
And it was not meant like a reliever. It
No,
was meant more like trying
It was meant
out.
as a reliever.
As a reliever. As a reliever.
Because sir mentioned that bronchodilator, while you are examining the patient, the child may not be into bronchospasm. Therefore, you can give a trial of
See,
bronchodilator.
what happens is if you say in some children, the wheeze may not be obvious. You
Yeah.
may have cough, which is an obstructive kind of cough. But you could try with a salbutamol. That's what he meant.
Right.
Okay. Let's quickly go to the next case. Okay. So this is the child with stridor, as you saw. We'll quickly hurry through this because we are short of time now. So which are the red flag signs in congenital laryngomalacia? Any of these, which are the red flag? One of it is not really a red flag sign, or maybe more than one. We just want to, yeah, I think because there is one more case, I'm going into it. So, okay, there's already voting. No, but not necessarily. This is a, okay. Yeah, Jagdish, would you like to take this up?
I think the important thing as far as stridor is concerned is most of the laryngomalacia start about a month after birth. They don't start at birth. So the first one is obviously wrong. That's a red flag, correct? Retractions will be seen very often in laryngomalacia. So that is not really a red flag sign unless it is very severe and there is associated hypoxemia or failure to feed properly. A biphasic stridor is another thing which tells you that the obstruction is not at the laryngeal level. Now, one of the key features of a laryngomalacia is a musical sound which is predominantly inspiratory. But if you find a biphasic stridor, it is much lower in the airway, not up in the upper airway. And therefore, a biphasic stridor also is a red flag sign. And 1 minute, Bala, please. Otherwise, you come, please take it. I'll go. No, that's okay. We have already said that, before. And and finally, with GERD, we have to definitely look at a red flag sign. Okay, next.
So failure to thrive is certainly a red flag sign. We are not denying that. Okay, let's quickly go through let's move on. So what is the management of laryngomalacia, of this condition? Is there no specific treatment, wait and watch? Do you do bronchoscopy if stridor persists beyond 3 months? Do you give PPI, speech and swallow therapy, or bronchodilators and inhaled steroids while sticking strenuously to exclusive breastfeeding? What is the management? Yeah, and please vote for this. Okay. Jagdish.
Yeah, if the baby has significant obstruction as evidenced by failure to thrive or significant retraction or hypoxemia, then we definitely will have to look into the larynx. And we do a laryngoscopy to look at what's happening there. And otherwise, no specific treatment is required. Wait and watch, especially watch if the child is otherwise growing well and feeding well, and if there is no other issues.
So one of the main indication for bronchoscopy in laryngomalacia is if there is failure to thrive, feeding difficult. So now, last case, 10-year-old girl, recurrent episodes of breathlessness since the last 2 years, 6 episodes in the last 9 months. There is exercise-induced cough, temporarily better with nebulization of levosalbutamol, ipratropium, and never received ICS. So which is the most appropriate investigation in your opinion? Late onset. So obviously spirometry is the correct answer here, which most people have got it. That is the test that will tell us here whether we are dealing with an asthma or not.
The
PFR is a very inferior way of delineating the same thing. So the choice is spirometry. Yeah, Jagdish, would you like to
I
comment
think
something?
with the advent of the FOT, I think it's becoming more and more popular, and it's probably better than the spirometer because it picks up more of the small airway obstruction, which the spirometry does not. And therefore, over time, I'm sure most of the referrals for diagnosis of asthma will go through a FOT.
Now, most of us are truly familiar with spirometry, I think with more and more. So let me quickly say which of the following spirometry values to you would suggest asthma. FEV1 70% predicted for age, or improvement in FEV1 10% over the pre-reading, improvement 20% over the pre-reading, or FEV1 upon FVC ratio 8% better than the pre-bronchodilator, or any of the above. I think the majority have got it right. So it is 20%. The cutoff is actually 12%. It is said that there is a 12% improvement in FEV1 beyond the pre-bronchodilator reading. So 10% is borderline. And FEV1 FVC ratios are not actually defined as a way of diagnosing asthma. FEV1 less than 70% predicted for age. There are too many variables in that depending on the height of the child, the ethnicity of the child. So we don't go for that 70% prediction. So the answer here will be improvement of 12% or more in the pre-bronchodilator reading. You want to add something? Yeah, Vijay?
Yeah, can go quickly, 2-3 more. 2-3 more only,
Okay.
simple. No cases can go through.
You wanted to add something there?
Yeah.
So the most appropriate treatment plan would be what? Please vote. As needed oral salbutamol is good enough, or start budesonide inhaler or NEB daily. Daily budesonide formoterol as needed salbutamol both by MDI spacer. Intermittent budesonide plus salbutamol or any of the above. Yeah. Jagdish.
Yeah. I think most of them have answered correctly here. So we'll just move ahead. I think this is the demonstration of the MART therapy.
Yeah. Would you like to elaborate a little on that?
No, I think the basic thing is that the changes which have taken place in GINA has been primarily because they believe even the milder degree of wheezing, etc., will have some degree of inflammation. And therefore, there's a combination of budesonide and formoterol, which is given every time that the child wheezes and even on a maintenance. So use one inhaler both for the controlling as for the relieving medication.
Do we have time for spotters or?
No, you don't have time? Yeah. It will take 5 minutes more.
Yes, sir.
Go ahead quickly.
Jagdish, start.
8-year-old child with cough since 3 weeks, characteristic short, single, dry cough, more prominent during office visits, absent during sleep, poor response to bronchodilators and cough suppressants, history of upper respiratory tract infection 1 month back. You have the options? Yeah, so basically spirometry, gastric aspirate, upper respiratory biofire,
Vijay said
honey
no,
and
just
reassurance.
go ahead.
Honey and reassurance. Okay, we'll move to the next one. Everybody's answered that correctly. Excellent. Move. Okay, 7-year-old child, known case of asthma, comes with flare up. The PSI worsening, since ABG was done. This is the ABG. PaO2 is 85, PaCO2 is 39, pH is reasonably okay, 7.37, and HCO3 is 23. Next. So what do you do here?
Which is the correct response? I
Which
don't
is the
think
correct
we're
response
voting time.
quickly?
Should we vote?
No.
Banda ke liye, okay, ठीक है.
Anybody?
Anybody in the room wants to just... So the only point we have to make here is that PCO2 is the first to rise in asthma. It is a very ominous sign because asthma is a case of expiratory obstruction. So the PCO2 is to rise. So if PCO2 is high normal, we start worrying about the child and we think of shifting him to PICU. That was the take-home message.
Yes. So this patient has to go to PICU primarily because if you look at asthma, acute severe asthma, initially the PCO2 will go down because of hyperventilation. Then it will normalize and then start going up. So the moment it starts going up, it's a dangerous ominous sign and you need to shift the patient to PICU. Okay. Next. Next. Okay.
Yeah.
All right. The 5-year-old had otitis media, treated appropriately, review on 10th day, no symptoms now. So this is his otoscopic picture. What would you do here? Start high dose comoxiclav, review after 2 weeks, refer to ENT, do a tympanometry, do an audiometry.
People have already... Jagdish.
Yeah, so the correct answer would be do a tympanometry. And the reason for that is you need to follow this child up. He's got otitis media with effusion. Otitis media with effusion will normally be there on the 10th day after starting antibiotic, but it gradually reduces and will disappear by around 12 weeks. And if it is persistent, you will have problems. So therefore, you need to do a tympanometry to see what the tympanogram is showing you. If it is showing you a B type, you'll have to follow it up over the next 8 weeks to see whether it responds to normal or not. Okay, reverts to normal or not.
Just a word about high dose amoxiclav.
Yeah.
Otitis media, just your comments.
Yeah. So high dose amoxiclav basically is a combination of, it's basically you are trying to cover 2 organisms. One is a resistant pneumococcus and the other is a H influenzae, which is producing penicillinases. So you want to cover both. Now, if you give the normal dose of amoxicillin, some of the pneumococci will not be covered, especially the partially resistant ones. And therefore, you increase the dose of amoxicillin to 80 to 90 milligram per kilogram per day and add a small dose of clavulanic acid to inhibit the Moraxella and the H influenzae. So that is the rationale beyond by this combination. Yeah. Okay.
But I think let's emphasize one thing, that ES is only meant for otitis media and not for other
Absolutely.
conditions.
It's only meant for otitis media because you want the high dose in the middle ear.
So 7-year-old girl with cough and fever, cold for 3 days, a turbinate that is small and purple, does it have any diagnostic value?
So your options are these.
I think, yeah. Yeah. Carry on.
Yeah. So actually this sign is described, very well described in New England Journal of Medicine. Anybody can Google and see it. This is called as the small blue or purple turbinate syndrome. This is characteristic of adenoidal hypertrophy. The correct answer is adenoidal hypertrophy, primarily because there is reduced airflow through the nose. The baby is mouth breathing, reduced airflow through the nose. So there is vasoconstriction in the adenoids and it produces a small flow-related vasoconstriction and therefore that purple nature. I didn't know about this sign, and after I saw this sign, I've been seeing many patients. Okay, so basically you can start.
Eyes do not see what the mind does not know.
Absolutely.
So this is the last one.
Huh?
That's a better way of diagnosing adenoids.
Well,
But
probably it's
not
not
a
there
very
in
high
all adenoids.
specificity or sensitivity, not a very high sensitivity.
Yeah.
Okay.
Show the picture on small.
Yeah. So this is the X-ray
Go back. Dr. Bala wants to see the picture.
picture.
Previous picture.
Sorry. Yeah. And by the way, that is not a textbook picture. That is the picture I have taken. So this is
When you had a
this is
purple
not from a
patch.
textbook.
You had a purple patch in your practice.
He continues to.
Yeah.
Yeah. So
This
there is a child who came with cough, cold, and fever. Can go back to the clinical history.
history.
Yeah. So there's a 9-year-old with fever, nasal discharge, cough, and swelling below the eyes. And that's the CT which was done. So what would you do here? Admit and start IV ceftriaxone. Give a nasal drops and cetirizine only. Send a nasal swab for biofire. Urgent ENT reference for possible surgery. None of the above.
Only monocyte. House is divided, yeah.
Yeah.
Okay. I think we're late.
So you want to see the correct answer? The correct answer is none of the above. Actually, the treatment here is just oral coamoxiclav because this is a preseptal cellulitis. This is not orbital cellulitis. And the clinician needs to go back to the
X.
Yeah. So here you can see that there's swelling below the eyes, but their eyes are relatively spared. There's no ophthalmoplegia. There's no increased vascularity in the eyes. Movements will be normal. So this is a preseptal cellulitis. Preseptal cellulitis is a normal accompaniment of acute sinusitis. You'll see it quite often. And here the treatment is treat a basic sinusitis with coamoxiclav. There is no need for any further
So with
treatment.
this, just because there is a swelling in that area, do not go overboard on the treatment is the moral of the story.
Yeah.
Okay, I think we are done.
Yep.
Thank you.
Thank you so much for that wonderful session. Actually, the topic was very wide and vast and open, child with respiratory symptoms, but well done in the with the time constraint. Thank you so much. We will break for lunch, but it's going to be a short lunch of 20 minutes. Before that, we felicitate the speakers.
Meanwhile, Dr. Vijay, can I ask one question? Jagdish Chanappa.
So, for the modern chairpersons, first of all, I request Dr. B.K. Manachar, sir,
Dr. Jagdish.
I know the chairperson momento to. Sir. Sir. Hello. Before we break for the lunch, honors for our esteemed chairperson moderator. So I would like to request senior Alchem managers to come ahead. Thank you.
Srinivas.
I would request Dr. Chunipal sir to come forward.
So we will now move out for lunch and regroup at around 2:25.
2:20.
Hand over the moment to Dr. Pallab Chatterjee. Sir, please.
Because two experts like you are where they are.
I request Mr. Srinivas to please honor. Oscar. So please. Now I request Dr. Sandeep Mukhopadhyay sir to come forward to hand over the moment to Dr. Dr. Suman Poddar sir. So it is our privilege to have you session. Thank you very much for your participation. And I would like to request Dr. to come ahead to receive the memento from Mr. Naresh Rao and Mr. Srinivas. Thank you, sir. Thank you. Now I request Dr. Dibendra Rai Chaudhary sir to come forward and hand over the moment to Dr. Anup Mangal sir. Anup Mangal sir.
For making the session interactive and fruitful.
Sir. I'm party দেব ছবিগুলো আপনাকে। Thanks a lot for waiting.
Now we can break for lunch.
Just a minute. Just before we break for lunch, there is next session after the lunch with ये screen लगाना.
Hello. Hi, sir. Sir, just unmute and talk. Hi, how are you, sir? Can you hear me? Just unmute, sir. 1 minute. Unmute karo na. Mic unmute karo na, sir. Sir, just unmute, sir. SK Raja. Okay, you can't do. Oh, 1 second, 1 second. I will allow you, sir. 1 second.
Hello, hello, sir.
Now it's okay.
Hello, sir.
Yes,
Unmuted now.
Agarwal here, sir. How are you?
Yes, sir. Hello.
Yeah, sir. We can hear you. 1 second, sir.
Okay.
Yes, yes. It's okay.
So it's 11:20 there, I believe.
Hello.
Or maybe 9 o'clock. 9 and 9.
This is 10:38.
So maybe in an hour's time we'll be joining.
Okay, sure.
Sir, just share your screen, sir. If you have any PPT or something, we can test it.
No. I think Dr. Vijay is going to share, and then there's a question answer session. I'm not going to share anything.
Okay, sir. Done. Thank you.
Right, sir?
It's okay?
Okay, sir. Done.
Okay, done. Bye bye.
Thank you so much, sir.
Okay.
So with your local time, 11:20 we'll be joining. Right?
Okay. Okay.
Thank you.
Welcome to the post-lunch session. So the next session for today is New Frontiers in Pediatric Nutrition. And for this particular session, I would like to welcome Dr. Upendra Kinjaurikar sir, who is the Director, Kamlesh Mother and Child Hospital, Nerul, and consultant at Apollo Hospitals, Navi Mumbai. National President of IAP in 2023. He is in clinical practice for the last 33 years. He is a member of the International Pediatric Association's Committee on Non-Communicable Diseases and Mental Health 2023 and 25. He is a member of the National Council of Educational Research and Training Maharashtra, NCRT, and Chairperson Sankalp Sampurna Swasthya Program of IAP 2023 and 25. Welcome, sir. I will request presentation of bouquet and memento to sir. I will request sir to take over this current session. Light change.
ये भी चलेगा Can we have the slides, please? So thank you so much, the organizers and Dr. Yevle in particular, for your invite to participate in this wonderful interactive national symposium. And we have had great discussions since morning, talking about so many clinical scenarios. And Dr. Yevle has categorically put this session as a post-lunch session. After everybody is happy and the Satiety Center is satisfied with wonderful sumptuous meal. And let's talk about a little bit about what is happening, what's new happening in pediatric nutrition. All of us need to know a little bit more about it. Can we have the first slide, please? Loaded in the afternoon. Yeah, okay. Thank you. So if I have to sum it up the entire presentation in just one slide, I think this would be the most important part of it. What's new in pediatric nutrition? So what last 2 decades have been really fascinating. And at the same time, last 5 years in particular, so many new things are happening in pediatric nutrition. All of us, those who have graduated about 30, 40 years ago, know that it was only about marasmus, kwashiorkor, nothing more was happening on nutrition front. But now there is something called as personalized nutrition. So not only your present medical condition is taken into consideration, but also your taste preferences, your geographical background, and the lifestyle that you are following is taken into consideration. So slowly and steadily, I think we always remember that homeopathy and Ayurvedic practitioners ask so many questions about your personality. Probably we allopathic practitioners are also moving towards personalized nutrition. Microbiota, human microbiota, I think the research project is amazing. And all of us know we just cannot survive without a healthy microbiota. We have more microbiota in our body as compared to the cells in our body. So that just shows that importance of them. Then of course, nutrigenomics. Every nutrition doesn't act in the same way in every individual. That is also being thought about. So now your genetic variability is considered as far as your ability to process any particular nutrient, and then your recommendations would change. And epigenetics, I'm sure all of you are already aware of it. I have talked about it in the earlier one of the conferences. So this is a big way that how your diet and your environment ultimately decides without altering your DNA code. Still, it is making so much of difference. And still, it is the most important reason for the rise in the autoimmune diseases, the cancers. What is happening around us is all because of this. And infant and toddler nutrition, I'll touch upon some of the key changes that have happened. And I am a practitioner, so I'm going to talk more about what you and I can do in clinical practice tomorrow onwards. Childhood obesity prevention is become big problem now. And fortunately, as president last year, I could hold a first national pediatric obesity conclave under the leadership of Dr. Khadilkar and Dr. Amdekar. Many of you have attended that. And of course, I'm sure that you have all downloaded and using the IIP pediatric obesity guidelines that we have published. Nutrition and brain development, the emotions, the cognition and the behavior, three key aspects of a child are totally now changing concepts that your diet can change everything. Of course, sustainable and environmental nutrition, you don't want to, the eco-friendly diets and the lesser the waste, because there is enough for everyone's need, but not enough for everyone's greed. All of us know that. Digital apps are going in a big way. In a study in Korea, what they did, the kindergarten schools, what they did is that the school menu is entirely decided. So they feed whatever is cooked across South Korea into the app, and then the variability changes come, and then the final school menu, the kitchen menu is decided. So this is how it is going to happen. Breastfeeding, I'll come about a little bit important things, and human milk research, it's fascinating. I'll just share one example. Last year, I attended American Academy of Pediatrics National Conclave, and there was a session on breastfeeding. And can you believe that it was a full house, more than the ID session, which was going in the parallel session. So I was really taken aback, and they were talking as if the session was happening in India, that how these baby food manufacturing companies are making us prescribe such things that we must promote breastfeeding. So the point is, and even the West is following exclusive breastfeeding for 6 months. Nutrition and immune development is new changes have come. I'll just talk about it a little bit. Food allergy is another thing. All of us know there is a sea change which has happened following the LEAP study, the peanut allergy or in general allergens. And now the concept has changed. Initially, it was you should not use or introduce the allergens much before the first birthday. But now they said, in fact, earlier introduction is better, especially the US and the West. They talk a lot about peanut allergy, but now the changes are happening. And of course, finally, the adolescent and prenatal nutrition is also seeing changes. So this is what is, every topic is itself a talk of 20-25 minutes, but let's see what are the key changes and what are the important things that you and I can tell our colleagues, OBGY as well as us also. So preconception now, I think you and I as pediatricians do not want LBW, the small for date babies, so SGA babies, though we do not want such kind of babies. So what best can be done? So LBW now, I'll just go through a couple of presentations which have come in last couple of years and the standard publications which have come and what are the key messages. So pregnancy intervention, which our OBGY colleagues do perfectly, it's only affecting 13% reduction. But if you want a proper 24%, that's a 12% more, 11% more reduction. So preconception and pregnancy intervention. So point is, the onus is on us. If you want a 3.5 kg healthy baby delivering at 40 weeks, crying immediately at birth, adolescent girls have to be healthy, and even the boys. So I think it is us that we are, the moment they are 18, we should, it's extremely important to see that they follow into proper healthy parameters. But what's a ground reality? As you can see, 20% are thin, 20% are obese, 50% are anemic, 10% are short, and 5 million are too young. Even now, all of us know that COVID, the number of marriages that happened in the pre-adolescent or 12 to 16 years of age, that was really, we were all taken aback by seeing the figures. So we need to work on that at whatever front that we are able to. Look at the change which has happened. It is considered in India that 21 to 23 years is the age when a girl delivers her first child. So if I put 23 years over there, look at the BMI. The low BMI, that's 18 to 22 is considered as healthy. And what has happened, the blue line, if you can see, it's slowly falling. At age 15, if 46.5% were having 18.5 BMI, now it is coming down to 20% by 23. And look at the red line, which is creeping up like anything, obesity. Only 6.5% of my 15-year-old are obese, and that at 23, it is touching 30%. So 30% at 23, and all of us, those who attend deliveries, now all of us know the GDM is on the rise. Almost every alternate baby is GDM. We had never heard of such terminologies 10, 15 years ago, and now it has become so common. So the point is, we need to work on that. Adolescent nutrition, you can see the micronutrient deficiencies, 85% to 87% have at least one micronutrient deficiency. You can see B12, folate, zinc, iron A and D, and only 13 to 20%, 13% girls and 20% of boys has zero deficiencies. And from starting from 1 to 2 to 3 to 4 to 5, look at the amount, why it is happening. So again, the point is, pre-adolescence, so childhood nutrition, then the infant, then the breastfeeding, every category is important to understand that we don't want micronutrient deficiencies. Okay, so what is the way millets are revisited? And they have been talking about, Modiji introduced the terminology as Shri Dhanya. It is considered millets are called as Shri Dhanya, and now they are coming in a big way. Though India was aware of millets, but what is happening? What are the benefits of millets? We must understand. So it has a very low glycemic index, minimum water. So even banjar zameen pe millets can be grown. It does not require any fertilizer, no pesticides. So imagine everybody wants healthy, crop. The fiber amount is huge. It's gluten-free, so even if you're gluten sensitive, you can use it. The niacin reduces cholesterol and the cardiovascular disease, dyslipidemia. With legumes and millets, it's excellent, like dal chawal. You can just replace that chawal and substitute it with millets. It's complementary. It has antioxidant, reduces carbon footprint, and just compare it with the rice, which is the commonest staple food that entire India eats. 30 to 300% more nutritional elements as compared to the rice. So that is how the beauty of millets is there. These are the different millets that we are known: pearl, finger, foxtail, proso, kodo, little, barnyard rice, and compare it with rice and wheat. And you can just see the amount of protein, the amount of fiber. Rice has 0.2 as compared to that. Foxtail millet has 8. Everything has much more calcium in ragi. All of us know 344 as compared to 10 in rice. So point is, at least one meal a week, we should start off by changing to millets and probably some legumes or pulses. And then only I think we'll have slow and steadily, you have to develop tests for millets. Any evidence in pediatrics, or it's just a general talk and Modiji just wants to, enforce it among Indians? Not at all. Look at it, millets have a promising role in reducing IDA. Results from regular rice-based diet change to that kind of diet. Positive gain in weight and height. Why do you want to write tonics for Dr. Sahab bhook nahi lagti, vajan badhne do? Spend 2 minutes and tell 1 or 2 recipes of millets. Excellent millet recipes books are available. Please spare some time and ask them to replace at least one meal from rice and wheat and change it to millets. Significant improvement in stunting and BMI. Karnataka government did this study, and they're trying to replace, most of the schools are trying to replace and use at least one millet in their midday school program. So that is what is about millets. Okay, let's come to adolescent and this general nutrition. Come to breastfeeding. We start off, the baby is born. What is changed? Breastfeeding remains the norm. And my dear friend, doctor, oh, sorry, why is it gone ahead? Okay, so maternal and child nutrition is important. So this is Dr. Rupal Dalal. Many of you must be knowing her personally also. She's a pediatrician, settled in USA, keeps coming to India and works in Nandurbar. She has said that breastfeeding, even if exclusive, can be suboptimal if the skills of mother are not appropriate. We have to empower mothers of these skills. Appropriate attachment, hold and positioning, some time is to be spent. It cannot happen immediately, especially the primary. And what she has shown is cross-cradle position is supposed to be the best one for milk transfer. So if we can use this method, and it's not at all difficult, very easy to see. And she has found a huge study and she has published that cross-cradle position is probably the ideal one, though we all say that whatever is comfortable for mother and baby is a general statement, but this is going one step ahead. And if you can, yourself can start using it. The final thing is the weight gain. Most of the Ministry of Health and Family Welfare guidelines of India say that 500 gram baby should gain in every month right from birth. So imagine a 3 kg baby who has gained 500 grams. has become just 1.5 gram more than that. So it is becoming already going into less than third percentile. So it is not at all satisfactory, and we need to change these guidelines. And every healthy term newborn baby has to gain 30 grams per day. There has to be certain figures are to be followed, and then and only, because we do not want them to slip into MAM and SAM later on. So that's why I think these first 3 months are important. Later on, next 3 months, and then by 6 months, we are going to tell them about complementary feed. The point is we must put some more efforts on that. Talking about complementary feeding stage from 6 months onward, we know 90% are not taking any iron-rich food. Minimum dietary diversity is also pathetic, and the meal frequency is not great to be talked about. So we have to work on all these things. So at 6-month visit, please spend at least 6 minutes talking to the patients, telling them more and more, and that gives you double advantage. 6 months is the time, I feel, if there is a neurodevelopmental disorder coming in, earliest sign you must, if you cannot enjoy your flu shot visit that the baby makes for 6 months, which has no other complaints, you're missing something. You should enjoy those 2 minutes playing with. It's a fun, all of us know, playing with a 6-month-old baby. If there is both advantages of complementary feeding as well as cues for that. Okay, certain important practical questions, and fortunately, WHO has answered them very clearly without any ambiguity. So 23, the WHO guidelines finally came on complementary feedings. You can guess what I'm going to talk about. So which milk to give from 6 to 11 months? There was no answer. We said about 6 months exclusive breastfeeding, but what happens later on? So they have said that babies 6 to 11 months who are not fed milk other than the breast milk, either milk formula or animal milk. Now it is very clear. So whom to give milk formula and whom to give animal milk is also very extremely clear. So now why sudden change of giving a milk formula or animal feeding? Because we were always told that the animal milk can cause more of GI bleeding. Animal milk can result into iron deficiency anemia. So solute load on kidneys. These were the questions that we were asked. And then we said, no, sorry, we are not going to give animal milk. And even the AAP also said till first birthday, no animal milk, give only formula milk. But now WHO says no. It is the animal milk protein, which is extremely important, which stimulates the insulin-like growth factor alpha-1, and which is responsible for increasing the bone and muscle mass of the babies. So baby deserves to get some sort of animal milk protein. That is number one. And the micronutrients starting from proteins to potassium, from calcium to phosphorus to manganese to zinc, everything is much better in an animal milk. So if the mother is not able to feed, if there is less breast milk, non-breastfed babies. And what is the percentage? 37% of our women from 6 months onwards are not giving exclusive breastfeeding. So there is a clarity now that we can offer them animal milk. So type of animal milk, pasteurized, reconstituted, evaporated, fermented, whatever it is, yogurt. But milk is now officially recommended even till from 6 months onward, especially for these babies. Of course, no flavored or skimmed milk in infant from 6 to 11 months. Animal milk, full fat. There is a debate about full fat, half fat, no fat. Nothing of that sort, not required to get into details, because safe storage and handling is important, but we need not go into the debate of full fat or low fat milk. So the final choice is second milk, choice milk formula. It was never a first choice. Even WHO says first is animal milk and second is milk formula. But before giving any person a milk formula, ensure that safe water and sanitation, there is sufficient formula is available. Mother and caregiver can prepare, clean frequently enough so that it creates low risk of contamination and hygiene. So point is, number one is animal milk. Number two is milk formula. This is only about 6 to 11 month old. What happens to 12 to 23 months? This is another common question which is asked to us. So there the baby says follow-up formulas are not recommended. They're only animal milk. So even AAP has followed this. After first birthday, all of us know that all these formulas as 1, 2, and 3 and follow-up, everybody knows, they keep on knocking at our doors and asking about it. After 12 months, there is zero business of any of the follow-up formulas. Very clear. Even the WHO supports that. Plant-based, now more and more fancy things, almond, soya, and this and that. Not at all requires hardly any studies. Dairy milk has more energy, more high quality protein, more vitamins and minerals. So forget about plant-based proteins. Full fat, I already said, no conclusive of low fat milk. So even for 6 to 11 and even for older babies also. Dietary diversity, another very common question asked. Those who eat non-vegetarian, doctor, when can I introduce egg? And we tell them probably till first birthday egg and fish are not allowed. but not at all. Animal source, including meat, fish, and egg, should be consumed daily. The WHO guidelines says those who eat, of course. Then fruits and vegetables are to be consumed daily. There is again, people feel hafte mein ek baar phal dete hain. Daily baby will not be able to digest it, of nothing of that sort. Pulses, nuts, and seeds should be consumed frequently, because if baby is not able to get any animal milk, then why should you? So eggs and vegetables and fruits always remain a recommendation even from 6 months. Coming to another important publication which came in 2023 is protocol, our own Indian publication on management of malnutrition. And very important point, because the neonatal survival is improving everywhere. And what does this document say? That every baby, who are the ones who can slip to MAM and SAM, if the baby has not regained birth weight on day 14. So it's our responsibility that every baby under our care has to be birth weight at least for day 14. If it is not something at all, spend time, talk to a lactation consultant, send them somewhere, but day 14 is extremely important. Weight loss on 2 consecutive visits after second visit is not good. Small babies are surviving, but less than 1,800 gram first month is very crucial. Every one of us right now can think of at least 10 babies under our care who have born less than 1.8 kg, but for them the first month, if you're not ensuring proper lactation and breastfeeding, they are the ones likely to go into the MAM and SAM. And then for management, they said whole milk formulas, no palm oil. That's a management of SAM, that's forget. But first 3 lines are extremely important for us as practitioners. Okay, the nutrition and immunology, I just said, now final verdict is out. We always feel what is the exact effect of nutrition on immunology? And look at this. These are the things, remember, that unaffected by malnutrition. So with what is your TLC will not be determined by your nutrition, your T cell count, CD4 count, IgG-IM, CRP rise with infections. You cannot say child is malnourished, so CRP has not returned, nothing. It has nothing to do with nutrition. These are the things which are affected by severe malnutrition. Most of us will not see, but probably MAM, all of us see a lot of patients. So thymus size, Th2 cytokines, Th1. So these are the things which are affected by nutrition and nothing else is affected. So that is very important. Now TB is another thing. Our goal is no TB by 2020, then 2030, 2025. But malnutrition, look at the wonderful statement that 1 in 5 incidents TB cases is attributed to malnutrition. Now we do not have HIV-related AIDS, but this nutritionally acquired immunodeficiency is a big thing, and we are totally neglecting that part. And it is said that neglected cousin of HIV in global TB elimination. Every HIV patient gets tested for TB. Every TB patient, all of us screen them for HIV. That's in the protocol of both. But what about nutrition, which is important for 1 in 5 patients? So your progression to TB, the severity and ultimate outcome, friends, will be determined by that. So spend time and ensure that any one of your TB patients is not malnourished. If not, you have to act fast on that. So then provision of this cognitive, the nutrition part is the complementary feeding stage. If you feel that somehow the baby is not doing great, so this is a small quantity lipid-based nutrition supplement. It's come a big way, and look at the results it is showing. This is very promising, and it will take care of all the micronutrient major deficiencies. It's just a 20-gram sachet, and you have to just give 4 teaspoons per day. Otherwise, all of us remember those formulas that we were giving to the babies, which are large quantity, not able to do test, and the appetite test was done. But this is extremely important to understand. It has peanut butter, oil, milk powder, vitamin, other essential nutrients, and this can be treated the malnutrition and prevention of malnutrition also. It's not only therapeutic but prophylactic also. So look at the beautiful power. Total energy value per 20 gram. 20 gram itself is 124 calories. That's amazing. You name even from omega and omega 3 and 6 to all the micronutrients to sodium, everything is perfect. So this is huge amount of great macro and micronutrients. And for whom? So babies who have recently recovered from severe wasting, yes, they are the one. Children showing signs of growth faltering identified through repeated growth monitoring. So for that, again, humble plea to all, please plot growth charts. And the moment you see no baby goes to SAM without crossing the MAM line, so please try to act at that time. And these are available how freely it is to be seen, because at some of the centers it is very easily available. You have to just open it. It's a 20 gram, that means 4 teaspoons, and put it in the child baby's mouth, or you can mix it with the ready to make cereal. Minimum of 6 months it has to be given. At risk, of course, if the conflict zones and floods and such situations, they can always be used. But this LQSNS is game changer. And how? Look at the changes: mortality, wasting, severe wasting, stunting, IDA, developmental delay, everywhere changes are happening. So that's why WHO, UNICEF, and let's hope that it becomes much easily available tool for us, because it's a small quantity and power-packed nutrient supplement that should be remembered. Coming to the after delivery intersection factors of gut microbiota, I just said it's changing the intersection of undernutrition, microbiome, child development in first year of life. Look at the way it is happening. The changes after vaginal and LACS delivery of change in microbiota, healthy microbiota. The bifidobacterium, Escherichia bacteroides, look at the pink and the red ones and the orange ones up to yellow Citrobacter. Above that, they're pathogenic. And look at the change. It's in front of you at 4 hours, 7 hours, 21 hours. Look at the change in LACS delivery, microbial flora vis-a-vis vaginal. But you see the beauty in infancy, they all again come to same. So the point is, while the fecal microbiota of 72% of vaginally delivered infants resemble that of their mothers, those delivered by C-section, the percentage is only 41%. So what the scientists have not stopped only on understanding this. So C-section babies are missing key microbiomes. So they're swabbing C-section babies with mother's microbiota. So the vaginal flora, because you're not coming through the vaginal pathway, you're directly coming up from the uterus. So they swab it and paint the baby. So this has not become a standard of care, but I felt I must share such kind of publications and interesting things that the scientific community also is contemplating upon. And finally, a word about, imagine a word, this is a 2023. So a lot of things happened in 2023, reduction of maternal mortality along with infant mortality. What best can we do? So these are the ways. Let's not get into what are the OBGY colleagues are implementing. But as far as baby is considered, look at this. All of us are dreaming for a single-digit NMR, isn't it? But we are not yet able to. And even if you project it further, we are not going to touch that magical figure of 12. Now, today, Maharashtra has 18 to 16 as a neonatal mortality rate. So the figure, if Kerala has almost already reached a single-digit NMR, and if we have to do that, certain interventions for these babies. A baby is born preterm SG and low birth weight. Look at the way these are high-risk babies for not only NEC, but also any sepsis. So the baby receives powdered probiotic. So Bifidobacterium infantis is a probiotic which is mixed with mother's milk inside the baby's gut microbiome. The mixture gets to work, and the sugars in the breast milk, the human milk oligosaccharides, they help the good bacteria, and the HMOs are the best food that the gut microbiota can get. And this is how you are protecting your baby. So this is another thing. So henceforth, these babies may not only get exclusive breastfeeding, but this may become a standard of care. Of course, it has not yet become, but this is the way they have said. Studies show that they help not only the final weight gain, but the protection and prevention of infection is the big thing that everybody is talking. And finally, for you and I, in our day-to-day life practice, we need to know certain basic things, and which is a general recommendation for all. Avoid refined carbohydrates. Plenty of vegetables, legumes are a must, friends. Fruits and vegetables cannot be talked in the same breath. It is vegetables and fruits. Fruits, you be careful about the fructose in, but vegetables, amazing, everything, immunoprotection, you name it, the fiber, we have to have all three classes, the green leafy vegetables, the fruity vegetables, and the salads, especially the non-vegetarian eaters. There is no single food in non-veg which has fiber. So every morsel of non-veg food that our patients are eating, we are eating, we have to equally take number of either a tomato, carrot, cucumber, or something of beetroot, or something of that sort. Eat fermented dairy and vegetables, healthy fat, nuts and seeds. For adults also it is recommended. A fistful of nuts and seeds is a must. Different seeds as well as nuts. Every one of us need to have it every single day. High quality proteins for even for our bug growth. Select meat with little or no, not under our control, but if you can. Acid in stomach is very important. And that's one of the first line of defense, like tonsils we have. And I must send a word of caution. Avoid, reduce. Dr. Jagdish also talked about it in a big way, that PPIs, every indiscriminate use, every patient in a corporate hospital where I work gets a prescription of pantoprazole with ceftriaxone, even though it may be for 3 days, 2 days, 1 day. What is the need? The prescription coming simultaneously. You write ceftriaxone and you write along with it a PPI. What is the need? So one has to think about it. Are we not, because PPI is the worst killing the human healthy gut microbiota. And that's why I do not want to, the acid in the stomach is getting, because which is the first line of defense. Excessive use of NSAIDs is another thing. And of course, the indiscriminate antibiotics. It takes 3 months for our microbiome to recover only with 1 course of 1 week of antibiotic. So let's be careful about that part also. And finally, the ultra processed food. And that's why I think all of us know that the world witnessed a sea change. Initially, everybody blamed the fat, then everybody blamed the sugar. That is because the rise in obesity, because everybody is worried last 40 to 50 years, why obesity is on the rise. And now the world has started noticing, along with it came the industrial influence, and it is the ultra processed food which is causing all the problems. You are becoming overweight, you have heart disease, the stroke, the tooth decay, blood sugar, blood pressure, inability to fight infection, and yes, many number of cancers related to it. What is the easiest way to know ultra processed food? You can tell, because I don't have time, because we do it in detail in Sankalp Sampurna Swasthya. Those who have attended know about it. You take up any packet, and if there is a single ingredient on that packet which is not a part of your kitchen ingredient, you have upma, you have poha, in indigo you must have eaten, but you just go through the list. And if there is one ingredient you feel, oh, I also make upma and poha at home, but this is not in my kitchen, so that means it's ultra processed. As simple as that. Keep it down. So if there is nothing which is you're feeling doubtful about, please use it. But if there is a single ingredient which is not a part of your kitchen cabinet, please do not use it. So this is the way, and this is what is happening. It's killing our next generation, our current generation. Our lifespan is going down. They said in America, the current generation may not outlive their parents. It's such a shocking and shameful statement. And it's just from Ladakh to Tamil Nadu. You go anywhere, it is the same malas which are latkofying everywhere. And we have to ensure that our children finally do not get it. I received this as a WhatsApp forward, but look at this. I just loved it, so I use it. So this is what is who eating whom. And one should always remember that we should need to stay away from. And final word from the dietary guidelines of India, even the Indians are working 2023. Look at, I just copy pasted because I just wanted to give this severe impact to all of you. Please introspect you yourself. Sugar, salt and maida are our biggest killers. Amongst them, sugar is the worst. And do we really need sugar? Do we really need added sugar? Our 5% total energy intake, or 25 considering 2000 calories, that is 5 chammach shakkar is more than enough for a day. And then it is the WHO is considering, because 10% say they're also bringing 5%. I'm happy our this 24 guidelines have already published it. If possible, added sugar may be completely eliminated from one's diet, as it adds no nutritive value to other than calories. Calories are healthy only when they are accompanied by vitamin, minerals, and or fiber. So I think once we have known about it, look, calories, only plain calories have no value. Along with it, so sugar is there in apple, sugar is there in banana, but along with it, I'm getting vitamin, minerals. It is there in gehu, it is there in chawal, but along with it, I have other nutritive value. Then I'm going to use it. But plain added sugar, let's all stop using it. So thank you for putting it post lunch. And thank you so much for your patient hearing. And this is what we did, try to tell the entire country, school children, trying to tell them the prevention of non-communicable diseases in the last year, continuing this year and probably in the next year also. Thank you. Thank you so much.
Thank you. And any questions here? Yeah, Samir.
Yeah, so phenomenal talk, and your experience with SSS, talking to the consumer, the children really shows. So brilliant as usual. I have 2 comments and questions to ask. Since 2007, when the second family survey came out and we saw that 8 million children in India have SAM, and of course, so many were malnourished. One of the things to remember is what you said very rightly, those multiple micronutrients and type 1 and type 2, not just the macro, but the micronutrients are very important. We have a problem with the word formula when it is accompanied by milk. But we should not have a word with the problem with the word formula if it accompanies feed. And hence, this distinction, as you have rightly pointed out, should be enhanced. The second point is, I learned one very important thing from you today. On day 14, the child has to regain the birth weight. What do you do if it doesn't?
it's lost in the follow-up. So that's why the follow-up in the
Thank you so much.
ECD programs also, we tell them that the first visit. So if you feel, in fact, I call every baby after 48 hours of discharge, maybe for the icterus part of it. But if it is not, and if there is any challenge before discharging the baby, one has to ensure that the lactation is well established. If not, call after 2 days, 4 days, 7 days. So 14 is the final day. Don't wait for 14 days. So keep acting even from first day onwards. So ensuring that part before discharging the baby is the best way. That is the only way that you can teach the mother and empower.
The baby has not reached, then what should the pediatrician do to mark that?
Yeah, that's what I said. Then you have to ensure that if you are not able to give that proper guidance, probably take help of professional lactation consultants and then ensure. But strict breastfeeding is the norm and ensuring day 14.
Upendra, just one word on sugar and salt in the first year of life.
Yeah, absolute zero, almost close to zero. So jitna kam ho se utna, zero is the ideal way, but everybody, so yes. But if you ask me, even our recommendations and even AAP talks about the sugar and salt, no till first year, second year maybe little bit, but yeah, zero salt and sugar.
Dr. Upendra, your suggestions and guidelines on
So we have questions from Kolkata.
fiber intake in children, because I can tell you when we were all students, we used to see diarrhea every day. Today we are seeing constipation. It's the reverse. Like malnutrition becoming becoming extinct and obesity becoming rampant. Constipation is a problem. What is the correct way to advise parents on adequate fiber intake, particularly in under 5s?
Under 5s, the restrictions are more, but 5 and above, there are many more choices are there. But the general overall guideline is half of your food plate has to be vegetables and fruits. That's the one golden statement that you can make. Half, so you draw a circle, you draw a vertical line, and on the left side, so vegetables and fruits become the half line. So for adults also, it is recommended 400 grams of vegetables every single day and 150 grams of fruits only. Mind you, 150 grams. So a big banana is good enough. You just cannot having 3 bananas because they're healthy or 3 mangoes just because you love it and they're healthy food options. So vegetables become the number 1 option, and all 3 in whatever best way, because certain things like salads can be eaten raw and certain things have to be cooked. Then there are certain recipes which we can tell, and we have a recipe book in which which is applicable in entire country. I can share with those who are interested. In fact, it is available on the website also, that you can make. There are some dishes called as thalipeet, cutlet, parathas in different ways, because children do not have liking for broccoli, they do not have liking for methi, they do not have liking for palak. And how do we ensure that this can be given? So these are the different ways in which one should ensure, and it all starts from complementary feeding stage. And by the time 5 years, I'm sure the next generation will be eating more of vegetables and fruits.
So we have question from Kolkata. We have question from Kolkata.
Dr. Upendra, thank
Yes,
you
sir.
for such a mesmerizing lecture. We are seeing an increasing number of obesity nowadays in our clinics. I mean, across the country, especially in the urban areas, but in all areas. So you've just touched upon the subjects of genetics, epigenetics, and microbiome. And in spite of that, I mean, we know that the diet is wrong, but not in all. Some mothers are really making an effort. They tell us that we are now restricting the calories, no fast food, we are encouraging exercise. In spite of that, these children are becoming more and more obese. What is it that we can do in terms of genetics, epigenetics, and in the practical field? I mean, so that we can protect these children for their future. I know we can talk about diet and all, but is there anything, are there any more tools through AI, through other apps that we can access and try to help these children and their families to reduce?
Yeah, there are many apps available for telling you about the dietary recommendations, but I'll give you a simple clue in your day-to-day OPD practice. You have singled out a child. First of all, the child has no business to go to obesity if he's under your or she is under your care since birth. You have to pick them up at overweight. It's extremely difficult to treat obesity, extremely easy to treat overweight. So number 1, so our IAP charts have to be followed. Point number 1. And point number 2, you look at the family. So if the child is singled out, he's only the obese person and mother and father are perfectly all right, you consider that something is wrong there. But 98% of the times my experience is it is not the child only who is obese, the entire family, even the younger sibling, older sibling, whoever is in the family. So that means there is a faulty diet is at the root cause for obesity. Of course, there is a syndromic obesity. We pediatricians are quite enough, from Prader-Willi to hypothyroid. All of us know Cushing, that where the cause of obesity is an endocrine cause is different, and genetic is less than 1%. So it's like same thing, saying constipation, 95% is functional, 5% is organic. Similarly, 1% of obesity is either a syndromic or a genetic cause. Rest of the times it is only nutritional obesity.
There is one more question from Delhi.
Yeah. Please.
Yeah, hello. Yeah, I am Dr. Surendra from Dwarka, Delhi. So, my question is, like, as you have suggested, from 6 months onward, we are advising full cream animal milk source. So instead of, because once we are advising milk, so most of the parents, they keep on giving breastfeeding milk, and most of the children, they keep on developing constipation and anemia. So instead of milk, if we advise them to continue breastfeed supplemented with milk preparation diet. Don't give milk at all, but to give milk preparation diet in the form of banana shake, mango shake, chawal ki kheer, suji ki kheer, khichdi, dalia. So baby will get wholesome nutrition, constipation will not be there, and there will not be any anemic child in India. Thank you.
I completely agree with your suggestion. Rather than recommending only milk as a diet, milk can be, preparing something else and using milk as a vehicle is fine. The only way, because there's a pediatric community and people have asked questions, not known that animal milk, totally no till first birthday was the ultimate discussion that we have all had, and the recommendation which all we were following. Just wanted to make them aware that animal protein are fine even from 6 months on. That's it. But I completely agree with your recipes.
I have one question.
Sir, Lucknow has a
From
question.
Bangalore.
Chennai, sir.
Hello. Sir.
Question from Chennai first. Nasik,
Yes.
hold on, please.
Sir, you
Yeah,
recommended the animal protein milk from 6 months onwards. Can we suggest that the government procured milk like Av in Tamil Nadu and different states, pasteurized milk from 6 months onwards? Because they also have the categories like high fat, low fat, and medium.
Sir, first of all, correction, I am not recommending, I just shared the WHO document. I am no way a person authority to tell that everybody should have. Just a way of putting it that now it is WHO document, which is telling us that yes, animal proteins are fine. And yeah, you're right that just a couple of weeks ago, I was in Kerala and they have a ragi-based preparation and wherein they use milk as a vehicle, which is fine. Government of Kerala is propagating that. So that's fine. So it's completely all right to have your own local recipes belonging to your area, using milk as a vehicle and not recommending to have milk as a diet, because that's perfectly all right, because all of us know that we need not. And the iron deficiency anemia, you can complementary feeding, you can recommend something which is good in rich in iron. So that's perfectly all right. If at all you can give some iron supplement, but don't, and we do not want any babies to have exclusively milk fed 6 months onward. That's a huge disaster. All of us, not only constipation, anemia, so many problems start with that. Yeah, I agree. Thank you.
Thank you, Dr. Upendra ji. Like your tsunami of thoughts which will never be forgotten.
Hold on, Bangalore and others, please. Nasik, come in. Nasik.
Hello. Yeah. Hello.
Yeah, please.
Sir, Chennai has one more question, sir.
Nasik, I'm not able to hear you, madam.
Okay, Bangalore can come. Bangalore wanted to ask something. Bangalore?
I want to know oats. Oats, everybody is introducing oats. At what age we should introduce? And animal meat, when should we introduce? Egg, fish, and chicken in any order? And
No, sir.
makhana, I want to know about.
So oats and makhana have become the new age fascination. Again, oats, plain oats is fine, but the oats which are coming as a part of the ready to eat preparation which comes in a packet sold by one of the world's largest company, let's not take the name, it's completely a big no-no. So oats can be used, but then plain oats without any additions, it's fine. If you like the taste, it can be used. Same is with makhana, it's fine. But then do not use it as a complementary feeding set, maybe probably at a later stage. And of course, there are chances of choking and all such things we need to take care of. And madam, I already said that there is no order in preference as compared to, because all of us know that the 5 key allergens that we have talked about, only peanuts, but the egg, fish also remained, milk and wheat are the other 4. The 5 most studied allergens are, these are the ones. And one has to be careful. So wait and do not introduce all these things which are supposed to be allergenic, and go slow and steady. But there is no order which is recommended by WHO in this particular document that go in this way, then start introducing next. No.
Last question from Nasik.
Hello from Nasik.
Sir, Lucknow has got 2 questions.
Do,
have a question.
Hold on. Nasik first.
the hormones which are given to the animals, And if you're going to give long-term animal milk, so does that concern us?
Yeah, I agree with to that part also, that going organic or such things, which is extremely cost prohibitive, cannot be recommended as a general recommendation. Forget India, even the US does not follow it, organic thing. But I agree that reducing the use of antibiotics and the hormones with the dairy industry is using, we need to be careful about, but not under our control. Certain answers which cannot be given, madam.
Lucknow. Lucknow, please come in.
हाँ उपेंद्र जी, राम राम सवेरे की, और आपको साधुवाद, आपने इतना अच्छा बोला, इतने शॉर्ट टर्म में बोला, इतना डिटेल बताया कि वी आर हाईलाइटेड. तो मैं केवल एक पूछना चाहता था कि व्हाट अबाउट द ओलिव ऑयल, और सेकंड क्वेश्चन आपने बताया कि नमक और शक्कर बच्चों को ना दें, तो कितना ना दें और कितना दें? कुछ तो देना ही पड़ेगा, और कुछ चीजें तो नेचुरली आ जाती हैं उसके अंदर, तो ये जरा जानना चाहता था. थैंक यू.
यस सर, द चेंज इज वेरी डिफिकल्ट टू अडॉप्ट. सो अपने से चालू कीजिए, पहले शुगर कम कीजिए आज शाम से. So second part is how much. So it is recommended 1 or 2 grams. So 5 grams of total amount of salt, which has 2 grams of sodium. The recommendations do not talk about salt and sodium. So they talk about sodium. So 2 grams of sodium come in 5 gram of salt. So we talk about salt. So it is considered 1 to 2 grams is more than enough. So even for a small baby after the first birthday. So 6 months to 1 year, they do not, none of the guidelines talk about salt and sugar recommendations. And they say that probably we must go to 0 figure, because all the things, we cannot be deficient in salt. You cannot be deficient in sugar. If you have a proper complementary feeding, which is, you know, we have the millets, you have all the vegetables, you have all the fruits, you have the dal, you have the curd, you're getting enough of rest of the things. So jitna 0 ki taraf ja sake utna acha hai. That is number 1. And number 2, as the age advances probably, and the other reason why it should not be given is sugar and salt are extremely addictive. Sugar is more addictive than alcohol. Yeah, I made it a very strong statement. Sugar is more addictive than even alcohol. So that's why we should stay away from that. And most of our health hazards are following sugar. So, and of course, salt and then maida. So stay away.
Sir, one more question from Chennai.
Good afternoon.
Olive oil.
Hello. Excuse me. Thank you,
One
Dr.
last question
Pedraji.
from Chennai. And
Somashekar sir, nutrition
Yes, sir.
expert.
Yes, sir.
Vanakkam, sir.
Yeah, vanakkam, sir. The pediatric nutrition per se, I think, must be conducted as a one-day workshop, because you see, most of the questions are only bombarding against you. Sir, I'm sure that you have brought out the comprehensive presentation on pediatric nutrition. We all know that no animal milk until 2 years of age. The WHO says at least until 2 years of age. Now, the change is the one which is constant, because the recent guideline says that, which can be used as per your recommendation, which you have brought out the controversial subject into. But the thing is that from 12 weeks onwards, the indication for animal milk must be brought and taught to every practicing pediatrician with a footnote on it. Otherwise, we tend to use it when a child, suppose, without any proper counseling, likely to use it with probably no evidence. That should be very clear cut in my statement, sir. That is only thing I wanted to just pass on to all of you. Thank you, sir.
Completely agree with you, sir. That's why I did not use any word or made any statement for less than 6 months. We all should, in equivocally in the same language, just speak about exclusive breastfeeding. If there is a problem, go for lactation consultant. See to it that the mother gets a proper supportive environment. Then only mother will be able to breastfeed. So I only talked about from 6 months onward. Before that, I never made a statement of using animal milk, sir. I completely agree with you.
a bigger round of applause for Upendra. Thank you for the lot of trying. Let's close this session.
Sir, can we take one last question from Lucknow, please?
Good afternoon, sir, from Lucknow. Thank you, sir. A very inspiring talk as usual. We've been used to hearing you. So, I mean, like every talk inspires us a lot. But sir, small query. You highlighted the importance of SQLNS. So can we as pediatricians do something to ensure free availability and adequately priced SQLNS for our children?
Madam, the only agency to approach is UNICEF. So if the local UNICEF is able to provide it for the general pediatric population, nothing like it. But it is available at some centers. I inquired in Maharashtra also, only 4 to 5 centers had a free availability of SQLNS. Otherwise, it becomes very difficult for them to procure and give it to you for general use. So wait for some time. Probably it will come as a general Government of India product which would be available, which may be able to give to our babies who are, drifting away from the normal growth percentage.
So, sir, as pediatricians, from IAP side, can something be done like
so that a lower price, high price may everything will be available, but lower price for the people who need it actually need a lower pricing. Agar free
I
nahi
agree
mil raha, then
with you.
ko lower price. So if it could be taken up by IIP for on
Yes.
that platform. Thank you, sir.
Suggestion well taken. Thank
Yes,
you,
sir.
Upendra. We have Dr. Shyam Kukureja.
Yes,
Who is joining us
Copenhagen.
from Copenhagen.
Yeah,
So
thank you. Thank you.
let's move on to the next session. Once again, a big round of applause for Upendra for a wonderful talk.
Thank you, sir, for this wonderful session on pediatric nutrition. So now moving on to the last but not the least session for today, dilemmas in practice, a case-based discussion. For this particular session, I would like to welcome our esteemed speakers, Dr. Vijay Yawale sir, Dr. Bala Subramanian sir, and Dr. Shyam Kukreja sir, who has joined us from Copenhagen, Denmark.
Now this session,
Dr. Shyam Kukreja sir is
moderator
a senior
Dr.
director and
Ayush
head of the
Rastogi.
department
I
Pediatrics,
welcome
Max
Dr. Ayush
Healthcare.
Rastogi. He is a
I
consultant
welcome our esteemed
pediatrician
speakers,
and
and I will
neonatologist
request
at Anand Hospital,
Dr.
Lucknow.
Rajesh Chokhani sir
Welcome,
to
and I
present
request my
our esteemed
colleague
speakers with the
Faushleen
mementos
Mishra
and bouquet.
to welcome Dr. Ayush Rastogi. Welcome, sir. This is our long association of healthcare with you, sir.
I will now request our esteemed speakers to take over the session.
Can I have the slides, please? So we have Dr. Shyam Kukreja joining us virtually from Copenhagen. He is the senior director at the Max Hospital, New Delhi. And I don't need to introduce Dr. Bala Subramanian, but we have heard him on Enteric Fever. And I call him the expert of ID experts. And is one of the most sought after speaker and expert in the country. What I propose to do is walk you through a few cases that I saw in last 2 or 3 weeks and raise questions that I had while dealing with these patients. And let's learn the ability to think rationally from our experts. So these are going to be cases that are not uncommon at all. A few of the questions don't have standard answers found in textbooks. So that is where these experts would be at our rescue. They will enable us to think rationally and manage a patient. And I sincerely solicit active interaction so that the session becomes interesting and interactive. So with this, let us look at this first case. So this is a 5-year-old girl was hospitalized for wheezing, cough, cold, fever, was tachypneic, the room air saturation was dipping, was hospitalized, was given nebulization, oxygen, that standard management was done. She had counts which were 18,000, neutrophilic counts. I usually do a CRP and it was 30. This child received amoxiclav and this is what the X-ray showed. And the child, of course, improved. Next day, the mother revealed that the mother, the grandmother, father's mother, was treated for pulmonary tuberculosis, sputum negative pulmonary tuberculosis, and the treatment was over exactly a year ago, 9 months ago. She received treatment for 9 months, and she was sputum negative. Now, let's hear from Shyam, who is with us from Denmark. Shyam, now the question is, before I call in Shyam to, explain, let's put it to vote. What do we do now? Do we subject this child for induced sputum or gastric aspirate to prove or disprove active disease? Or straight away put this child on TB prophylaxis with INH? Or do a CT scan to rule out active disease, knowing the limitations of X-ray chest in making a diagnosis of an active disease? Or just keep this child under surveillance? Can we have a vote on this, Dinesh? Yeah, so most of us feel that we can follow this child up. Some people have said that let's go ahead and try and rule in or rule out active disease by asking for induced sputum. Some are bold enough to put straight away this child on TB prophylaxis, given the fact that she falls in that window period of 2 years, Cox contact in 2 years, and some have recommended CT scan. So Sham, can you please explain?
Yes.
And what are your thoughts on this?
Good afternoon, everyone. And
We can't hear you.
this
Please
child
unmute, Sham.
muted.
Unmute yourself.
Yeah.
It's unmuted.
Yeah. Now we can hear you.
Okay. On the face of it, this patient appears to be a case of respiratory infection with wheezing. And now the history has come. This child has been in contact with the grandmother. And now I'll put it like this. I'll treat this respiratory infection. And there's no need further. I'll only give INH prophylaxis to this child. Up to 2 years, we prefer to give INH prophylaxis. Because the reason is, on the face of it, it doesn't appear the child has been unwell, child has been having cough for a long duration. If you can give me the history like that, there has been no weight loss, anything is not there. Or you want to give more information on this?
No, there is no additional information. The child has had repeated episodes of, respiratory infections with wheezing. More than infection, recurrent wheezing the child has had. And this is the first hospitalization.
Okay. So in this patient, basically, I'll say, I'll first try to take the whole history in detail. What has been the presentation the child has been having, how the child has been doing before this illness. This is very, very important. Occasionally, I have investigated them in detail. I'll tell you the instances. For example, I had a child who was asthmatic and had to be given oral steroids off and on. This was one child I remember where I had to investigate it further. But in these situations, I'll think in most of the cases, I'll be quite okay giving INH prophylaxis and keeping the child under surveillance. I'm very keen to watch the patient, how the child is growing, how the child remains active, what has been the appetite, what goes on with the appetite, weight gain, and all those things. I'll be supervising this child for maybe about 2-3 months. And if everything remains okay, I'm quite okay with giving INH prophylaxis for 6 months.
I come to Dr. Bala. This child is almost a year post-exposure with a close family contact. The history so far has not been suggestive of anything of underlying tubercular disease. And Sham says we could give INH prophylaxis, though the guidelines say. Would it really help at this point in time? And can we just keep this child under surveillance?
Now, a few comments. One, this child's present illness is not due to tuberculosis.
Absolutely.
1. 2, pulmonary tuberculosis rarely causes acute respiratory distress and wheeze, but it can cause. For example, pulmonary tuberculosis can cause respiratory distress by pleural effusion, pneumothorax, bronchial obstruction, miliary tuberculosis, and even an interstitial pneumonia. That is not there in this child. So the present symptoms are not due to tuberculosis. The question of this child having tuberculosis, as much as what Sham said was very correct. You have to go into the details of this child, growth, development, etc., and the appetite and symptoms, etc. As much as you go into the details of this girl, I would also go into the details of the grandmother. The grandmother also might not have had TB and she would have been treated for tuberculosis. There is every chance she might have also not had TB. Not that it cannot happen.
Assuming that she was diagnosed correctly.
No. You said you have put it as treated. We don't know how she was diagnosed, what type of tuberculosis. If she had had, say, for example, lymph node tuberculosis with no pulmonary lesions, she might not have been infectious. Or if she had pelvic tuberculosis. No, you have not mentioned. You have just pulmonary cox you have put. What type of tuberculosis? How was it proven? Was it drug resistant?
So, if I tell you it was a drug sensitive TB and proven seen by a chest physician and treated properly.
Drug sensitive TB, there is no urgency to do anything at this point of time. I wouldn't be even in a hurry to do any of these tests. I will treat this illness and then follow up. Regarding INH prophylaxis, current recommendations suggest that if there is contact, you give INH with or without rifampicin or rifampicin. We are moving towards to dual drug therapy.
So the point is either after having ruled out active TB, one may put this child, given the recommendation, put this child on the INH prophylaxis, or one may have, one has a choice of keeping this child under close follow-up and surveillance, given the fact that a year has lapsed and she's not shown any sign or symptom suggest of having contracted the infection. Okay, let's move on to the second case. This is a 9-year-old girl, acute illness, 4 days fever, tachypnea, air intake reduced on the right side. She's wheezing also. She has a saturation of 92 in room air. Normal counts, high CRP, platelets also lowish. Now, this child, what will you do? There is a lot of cases of influenza going on in Mumbai city, at least in Navi Mumbai. So let's put this to vote. How would you treat this child? There is definitely lower respiratory tract infection. Would you give only coamoxiclav, only oseltamivir, or both, or add vancomycin, given the fact the child has is unable to maintain saturation in room air? You can vote now. Well, so majority of us feel that the child, given the fact that there is flu outbreak and there is wheezing and lower respiratory tract infection, a combination is justified. Let me reverse the order. Let me start with Dr. Bala this time. Now, the case progress, I'll tell you. This child was started on coamoxiclav and oseltamivir, and next day the fever persisted. Child continued to spike. The distress-wise child was marginally better. We repeated the counts. It further fell to 4,200 and CRP increased. So more of inflammation. And with this now, let me ask the audience, what would you do? Would you add vancomycin? Because the inflammation has gone up. Distress is marginally better. She still requires oxygen. We had a discussion in the unit. Dip in white cell count, increase in CRP. A girl who is unable to maintain saturation room air. Would you think of something like MRSA, which is giving rise to lysis of WBCs? Would you step up to vancomycin? Let's have a quick vote on this. Or would you cover for gram-negative sepsis? Low counts, high CRP, increasing CRP. Well, majority of the feeling that we should continue stay put with the same antibiotics. Dr. Bala.
Please go to the previous slide. Let me tell you very honestly, I would have done CRP either on day 1 or on day 2 for this child. The reason is very simple. She's 9-year-old. She's not an infant who has a severe community-acquired pneumonia. Second, once there is wheezing, if at all there is any physical finding with which, particularly in an older child, you can say this is not bacterial pneumonia, that physical sign is wheezing. Wheezing is there, reduced air entry. Crepitations don't mean anything. Crepitations are not synonymous with pneumonia. Crepitations tell you that there are secretions in the bronchus or in the bronchioles. That's all. So with this status, and that too with hypoxia with a benign shadow like this is not bacterial pneumonia and definitely not
Dr. Bala,
typical. Let me
say not give amoxiclav.
I would not have given amoxiclav for this child. This child has got 9-year-old who's got wheezing, who's got a respiratory infection, hypoxia. Definitely, I would have given oseltamivir. I might not have given amoxiclav, number 1. Second, even if the fever had persisted, there is no indication to repeat counts. I'm not going to get anything out of counts or a repeat CRP within 24 hours. That is 2. Third is, the background history, if she had been a previously normal child, no immunodeficiency, no underlying chronic lung disease, chronic systemic disease, I don't think I would consider adding vancomycin or meropenem. The only area where I can get bowled with an adolescent who has got wheeze and who has got an acute respiratory infection is an atypical pneumonia due to mycoplasma. Okay, so in this child, I wouldn't consider giving vancomycin at all. And if at all I had given amoxiclav, if at all I would start an antibiotic, I will definitely do a blood culture even though the yield is very low. Then perhaps consider starting if the child is toxic, an antibiotic, maybe even amoxicillin, and follow up the child. And at this point of time, I would not add vancomycin, add meropenem. I might consider adding a macrolide.
About 1/4 to 1/3 of pneumonias are dual etiology. Influenza is notoriously known to get super or co-infected with bacteria.
Not like this acutely. Not like, see, influenza will cause
4 days of
staphylococcal
fever.
pneumonia not within 3 days. It'll take at least a week. This story is only acute and there is wheezing. I don't
is
think at
also
this point of time I will think of a.
Let's ask audience, how many of you will not use antibiotic in such a scenario? Those who will not use, please raise your hands.
On day one, certainly no.
Not day one, 4 days of fever and dyspepsia. and
Day one
hypoxic
means day one of day 4.
Okay,
Day
let's
one
go.
of day 4, I wouldn't give antibiotic to this child. I will give oseltamivir,
Yeah, here's the
do a
comment. Please,
PCR
please
and
come
wait
in.
and
Please
watch.
come in.
Vijay, on the face of it appears to be a basically viral pneumonia because there is lot of flu in the environment. I'll put it as if just happening all because of influenza. 4 days is quite a short period. I'll say this is primarily influenza infection and everything fits into that.
But Shyam, would you not give amoxiclav?
I'm coming to that. I think whenever you have a patient who needs admission for pneumonia, I think I'll always do blood culture. I absolutely agree with Dr. Bala sir. Because the reason is the child who needs admission, in the garden variety of pneumonia, I'm not keen for blood culture. But in a patient who gets admitted to the hospital, and particularly in ICU, in such patients, I'm very keen. You do get a blood culture and it can bail out many a times. In this patient, other point is I don't agree to do counts every day. I'll monitor the in my own hospital also. I'm a little concerned. Every day people do counts, and I always tell them, "Aap kya karoge kya?" Once the patient is better, whatever the counts, I'm okay with the treatment. Now coming to your point of adding amoxiclav, I'm not courageous enough like Dr. Bala to not to give any antibiotics. I'll give antibiotics because there's a respiratory distress, saturations are falling, and in some cases there can be a super infection. And influenza is very notorious to have strep pneumonia as well as staphylococcal infections. So I'm concerned. I'll be definitely giving this amoxiclav. I'm quite okay with that. And next, coming to your question of escalating to vancomycin. No, I'm not keen for giving vancomycin. This X-ray doesn't look like MRSA. An MRSA patient won't have improved the next day. So I won't go by counts and everything. I'll go clinical.
So very clear messages, wheezing more likely to be viral given the background epidemiology of influenza outbreak. Dr. Bala is bold enough to give only oseltamivir. He says maybe he would and send blood culture in a hospitalized pneumonia, though the yield is low. And there is no point in doing serial CBC every day in a proven case of LRTI like this. But the background is this child came with the report which was done outside. And it is generally a practice of a corporate hospital to repeat counts. And many hospitals for that matter, when the child gets admitted to there, they rely more on their lab. Anyway, this is the progress. The child went on to have spike. And since there was a debate of whether to stay put with the same antibiotic, yet another CBC was done with CRP. And that showed count of further dipping and CRP increasing. Yeah.
Well be.
Dr. Bala, there is a question. Shyam, there is a question here in the audience present physically. Dr. Bala, he says, could this be adenoviral infection?
Could be. See, the overall clinical picture is very much like a viral pneumonia. Dr. Shyam, on day 1, I would not have started antibiotic. The child had not improved, I would have definitely considered starting antibiotic. And to be very frank to you, for this child, in addition to amoxiclav, I would have given azithromycin to cover atypical organisms empirically, or maybe even consider doxycycline, or instead of azithromycin. And this could well be an adenoviral pneumonia. The only thing is, child is a bit older, 9 years. No conjunctivitis, I guess, no rash, nothing is happening. So it may not be, but you can't say adenovirus is ruled out at this
My
point
take
of
is
time.
most of the adenovirus would have counts which are slightly on the higher side. Secondly,
necessary.
epidemiologically, more of flu was in the season, and we are not seeing adeno
not
these days.
necessarily. High CRP leukopenia can occur in adenovirus or
Fine. Anyway, we went on to treat this child with coamoxil. Child improved and was discharged yesterday.
Vijay, you did influenza test or adenovirus or respiratory panel?
We did not test the child for adeno, but influenza was negative. Influenza was negative. Adeno, there are no adeno cases seen these days, and more of flu we are seeing, and that's the reason we did flu, and it was negative. Okay, let's move to the next case. 2-year-old boy, fever, cough since 28th of July, admitted and treated as right lower zone pneumonia. This is a clear pneumonia. This child was hospitalized somewhere else, became afebrile, received good course of antibiotic, then had chest pain on and off since 15th of August. That was well after almost 2 weeks of the infection. And this is the repeat X-ray. And the counts on 23rd, when the almost a week after the child complained of chest pain, that was the only complaint that child had now. CRP was 81 and the counts were high. Serially, I mean, they were repeated as the child was hospitalized with our place. And the counts had come down. CRP also showed a downward trend. The child came with a CT scan which was done at the previous nursing home. It showed empyematous collection in the posterior aspect of lower thoracic cavity, maximum thickness being 11 millimeter, with patchy consolidation in the right lower lobe. So this is the, what is happening? Oh, the CT is not seen in this. Okay, so we got a USG chest done which showed, this is a magnified image. It shows thick septae and some collection, but again only about 40 ml of non-tappable collection there. The question to audience is, what do we do now? Child is absolutely asymptomatic, no fever, counts coming down, CRP coming down, but the chest CT scan and the sonography shows some collection which is organized, something like antibioma. So should we conserve this child, continue with antibiotic therapy, or intervene surgically, either VATS or decortication? Let's put it to vote quickly. So divided house. Sham, majority is for conservative amongst the two, but even almost 40-45% are suggesting to intervene. What is your take on this?
So let's start from the reverse order. VATS, video assisted thoracoscopy. See what happens. You go back in the previous slide. Go back. Yes, here. See, there's a fever and cough which started on 28th. That's right. Yeah. And chest pain off and on 15. So the hair most possibly the CT scan was done. That's right.
Yes.
That's right. Okay. Yeah, yeah. And at this point, there are something like 18 days have elapsed. Okay. Now what happens if you do VATS after 18 days? You need a phase where this is fibropurulent phase. If it is gone to an organized phase, your VAT will convert to basically conversion thoracotomy. So it becomes a very big procedure. So first of all, I think take VATS with a pinch of salt. There's a time frame where you can do VATS. It is between 7 to 14 days usually. If you go beyond 14 days, it becomes so organized that either the surgeon will tell you I can't do it, or say even if I do it, my scope is going to break inside, and then I have to change over to conversion thoracotomy. So these are the issues. So VATS is out. Second comes, should I go for open surgery, open decortication? I think you said it is 11 millimeter. That's right. Go to the next slide. 11 millimeter something.
And 40 ml.
And 40
Approximate
ml you said.
estimation on sonography, and you see those
So
multiple.
I'll say I leave it alone, and we have a good experience of managing good number of empymas with this thickness or this thick peel, and they become okay in 3 to 6 months. If you remember, Vijay, I had shared a case in diagnostic stewardship where
Yeah, I
I had a
remember.
similar child where I waited for something like 3 months and everything became okay. So I think in the past, in our early phase of our career, we have done a mistake or going very aggressively, worrying that this is going to cause a lot of harm. But over the years, we have learned by our, I think, my colleague and my friend, my batchmate, Dr. Gulshan Sethi and others, that these cases do improve over a period of time and there's no need for a very aggressive therapy.
So, Sham, we had a divided house here on voting. So, let's see if Dr. Bala has a different view.
First of all, please go to the previous slide. You had done the CT on
when the child
23rd.
started complaining
No,
of.
wait.
Yeah.
The date I saw in the CT
Yeah.
was 23rd.
Yeah.
By 23rd, this child is afebrile. Let me tell you, I would have done only an ultrasound and not done a CT at all. Because I'm not contemplating clinically any surgical drainage at this point of time. Because child is clinically improving, fever is coming down. I would have done only an ultrasound. If the ultrasound had showed minimal fluid, I don't think I would have done CT at all. And I would have only proceeded with appropriate antibiotic management and monitoring the child. Because everything is improving. This lock later only 50. The ultrasound has clearly picked up that the fluid amount is so small, you're not going to get anything. And if the fluid is significant, I must get the fluid for microbiological identification.
It was non-tappable, organized and
not
thick thing,
tappable.
yeah.
That is not tappable, then I wouldn't have done CT at all in this child. I would have simply proceeded with conservative management.
Conservative management.
Vijay, the pain seems to be a new onset complaint.
That also disappeared by the time the
So
child.
that was the next question.
Yeah.
From 15 to 23, were there any symptoms?
Pain lasted for a few days and then pain disappeared.
Yeah. Why
At this
do
point,
a
the
CT
child was
scan?
absolutely fine.
Vijay, then why do a CT?
A surgical opinion was taken and the child was underwent.
Vijay, never go to the surgeon, I'm telling you. They will always say surgery
I
is to
would
be
not
done.
have taken a surgical opinion at all.
Absolutely. And the second thing is do CT only if you are contemplating that surgery has to be done. Otherwise, I avoid CT or uncomplicated cases where you feel it is
100%.
going to be necrotizing pneumonia or something.
Sham, one question to you both. You said conservative management. How long would you give antibiotics? How long would you keep following up? And would you repeat an image?
Necrotizing pneumonias, I would give for 6 weeks, 4 to 6 weeks. That's all. Follow up the child 4 to 6 weeks, and after some time, I will start physiotherapy if there is no pain, lung expansion, monitoring the child.
So I believe.
I think in this patient, Vijay, it is already patient is asymptomatic. That's the reason most of your delegates wanted to have a conservative treatment because this child is hardly any symptomatic, no fever, nothing. In this patient, even 4 weeks is good enough because you have done CT and there's no necrotizing pneumonia, so no need to give it further.
And I remember literature that the children's lungs are so plastic that they recover without any volume loss. Regardless of what you do, ultimately they recover. Let's move on to a simpler case. 7-year-old boy, fever for 4 days, high grade to begin with, throat pain since 2 days, generalized rash all over the body. The rash was maculopapular, and it had come up after a dose of coamoxiclav. This child had received paracetamol, ibuprofen, CBC aspirin, NS1 on day 3 were done outside. These are the reports. Slightly a higher count with neutrophilia, CRP is 19. On exam, the child had tonsillar exudates, both tonsils, but had small jugulodigastric lymph node, not very tender. In fact, when I pressed it, it was minimally tender. I could not differentiate whether it was tenderness or my pressure discomfort that the child had. Maculopapular rash all over. So what is it? Let us have vote on this, quick vote. Is this GABHS pharyngotonsillitis? Could this be infectious mononucleosis? Or could this be adenoviral infection? Let's have a quick vote on this. we know a good deal of work from Dr. Bala and his team on group A beta hemolytic streptococcal pharyngotonsillitis, the antigen test, so on and so forth. Let's begin with Bala. House feels this is EBV, and maybe 15% are still favoring a diagnosis of gas pharyngitis.
Okay, we'll have to go back to the basics of pharyngotonsillitis. Once you have pharyngotonsillitis, the differential diagnosis that we are worried about is two. One is group A beta hemolytic streptococcal pharyngitis. Second is diphtheria. These are the two things which you are worried about. This is not diphtheria because your description of the exudate and the presence of a rash makes diphtheria very, very unlikely. So that is one. Second is group A beta hemolytic streptococcus. You have mentioned fever day 4. I want to know how much was the fever.
Very high to begin with.
Very high, yeah, high to begin with. Okay, fine. High fever. And second, I would like to know about the description of the rash and the distribution of the rash.
It was all over maculopapular erythematous.
Pruritic, non-pruritic.
Not pruritic.
Non-pruritic. Okay, that is 2. With erythematous. Was there any skin peeling?
No.
Any perioral pallor?
No.
Other features suggesting scarlet?
No.
Nothing is there. Okay. Now, you're talking about small JD lymph nodes which may be there in any child who's 7 years old. In fact, I'll be worried if there are no small JD nodes rather than if there are nodes. Tonsillar exudates, the color to me is important. It is, if color, you should give importance not only to the presence of exudates, but also to the appearance of few other structures. One is the uvula. Was the uvula beefy red?
No, uvula
like
wasn't.
chili?
No, it wasn't.
That is one thing I look for. Second is overall appearance of the tonsil. Is it beefy red, highly inflamed, or just a few spots of white dots? That would suggest viral.
The child was seen on day 4, or day 5 rather, and by then the tonsils were not very beefy red, but they were exudates.
Okay, with this is most likely to be a viral. And in addition to EBV and adeno, other viruses including HIV, HSV, okay, can also cause this sort of, CMV also can cause this sort of viral pharyngitis. More importantly, there is one organism, of course I have not seen a proven case, but it is very much there in literature. One organism which can cause acute pharyngotonsillitis, a bacteria which is often not diagnosed, which can present with rash, is an organism called Arcanobacterium. Arcanobacterium. It can lead to dangerous complications like pulmonary gangrene, venous thrombosis, etc. Very similar to your the other organism. I'm not getting the name. Some other syndrome. Okay, anaerobic like organism is Arcanobacterium, which doesn't respond to penicillin, it responds only to macrolide. That is another possibility. So in all probability, this is likely to be EBV. And the one clue to EBV, 2 clues to EBV are epitrochial lymphadenopathy with splenomegaly. Another sign called Hoagland sign. It's called Hoagland, Hoagland. Periorbital edema. The presence of periorbital edema in any child with acute pharyngotonsillitis exudative indicates a high probability of EB virus infection. It is not known why it occurs. It may be because of lymphoid tissue pressing on the venous circulation. Periorbital edema, almost mimicking angioedema, will give a clue that it is EB virus infection. In all probability, this is viral rather than bacterial. I will, of course, go by the McKissick score and then find out if there is a probability of bacterial pharyngotonsillitis. I will palpate the spleen. I'll palpate for epitrochial lymph node, look for Hoagland sign. And if something does not count, I would look at the smear for atypical lymphocytes.
Okay, Dr. Bala, no epitrochial lymph node, no puffiness, no spleen. One more history of this child had gas pharyngitis 6 months prior to this. And the counts are neutrophilic, 81% neutrophils. Would you still call it EBV?
No, no. See, this is not likely to be EBV if counts are 80, neutrophilic.
Which
leukocytosis
day
there.
was this CBC?
But it
Vijay?
doesn't
This
rule
was
out
done day
viral.
4. No, this was done day
The
3. day
CBC
2.
was
CBC was done on day 3.
Day 3, that does, that makes EBV and CMV unlikely. But other viruses can only, adeno can again
Adeno
produce.
can come with this. Prakash has some comment.
Was there any palatal
No
petechiae?
no palatal petechiae. No palatal. Sham, you have any additional comment?
Yes. Vijay, this counts are not very suggestive of EBV, so it doesn't look like. And there are supposed to be many glands. You need to have more glands in the neck. We have seen cases where the glands may be absent, only Hogland sign is there. But I'll say in this patient, it appears to be more like a group A streptococcus. My feeling is, out of the three, in your experience, we find whenever there's a pain throat as a presenting symptom, it is usually group A. I have not seen adenovirus child complaining with throat pain. I have not seen EB virus complaining with throat pain. They do get choking, they do get into stridor, they get into respiratory distress very, very occasionally, but I have not seen complaining them throat pain. I have seen children only with group A streptococcus complaining of plain throat. So if plain throat is a presenting symptom, then I'll be concerned. And two, as Dr. Bala was saying, if the base of the tonsil is congested, and then over that the exudates are sitting, it's very suggestive of group A. Third, I think go with the your criteria of your 4 criteria of center criteria. And you see there's absence of cough is there. There's no cough you have described. There's no cough and cold. Only throat pain is there. Only tonsillar exudates are there. The only point which is against is smaller lymph nodes. You have got maculopapular rash today. You don't know it's going to convert to sandpapery rash tomorrow or not. So I'll put it as it could be group A streptococcus. EB virus, I rule out. And coming to adenovirus and other viruses, in these situations, the whole throat is congested. And adenovirus is notorious to have more of exudates, but the base is not very angry red. In case of group A, it is quite, tonsils are big, congested, and over that the exudates are sitting.
Sham, your points are well taken, but how many gas pharyngotonsillars have you seen without a tender lymph node? That was the query. That was the dilemma. That was the dilemma. Need not be there. Need not be. Because all other criteria were, and about the tonsillar base, I would say they were angry but not red. It was, I mean, it's a subjective thing again. So
it's very, very difficult to be angry without being red.
See, you must remember, just like viral infections, majority of group A beta hemolytic streptococcal pharyngitis also resolves spontaneously without treatment in most children without sequelae.
Okay. In the interest of, let's not vote, but what would you do? Would you do a RADT or send throat swab for adenovirus or straight away give amoxicillin to this child?
Yes, for me?
Yeah, Sham, tell me.
Yes. See, for example, if you are thinking of viral, there's a cold.
In this particular child, you told us.
Yeah, just for the information, if there's a mild cold, there's a cough, it is fitting into viral, there's a family history, there are oral ulcers. In these situations, I will never do a throat swab. In that situation, even if you have a strep throat, in that situation, it could be a common cell. So I'll be very clear that first you have to be very clear, it is clinically what? If clinically you feel it is strep throat, then the throat swab will be useful. And if you feel it is going to be viral, in that situation, please don't do.
Sham, here the dilemma was he did not have any cold or features of a viral illness, but the rash and absence of tender node. So I sent a throat swab RADT, which I do in my office, and it was positive. I gave amoxicillin to this child. So I treated this as gas pharyngotonsillitis. Okay, let's move on to the next patient. Yeah. Not really. I mean, is there a way unless you do a culture? Dr. Bala, would you like to differentiate between alpha and beta hemolytic streptococcal sore throat, and would it make any? Would it have any impact on management?
If I do rapid tests, if it is positive, I wouldn't do blood counts, I wouldn't do NS1, I wouldn't do throat swab culture. Current recommendations suggest that if rapid test is positive, you treat. On the other hand, rapid test has got good. See, once it is positive, the recommendations are that you don't have to do cultures. But if it is negative and if you still strongly suspect bacterial pharyngotonsillitis, then you do a throat swab. Otherwise, you don't do throat swab at all. Duration of antibiotic. That's not going to change whether it is it's culture positive or RADT positive. It's 10 days amoxicillin. Yeah.
Rajesh, you wanted to make a point?
No, I was saying that after all our discussion, we seem to come to a point where we were 50-50 on whether this is viral or group A. There were a lot of points for both. And then we did a RADT. So does the RADT have that power to tip you in favor?
Absolutely.
So at that time, you're not calling it as a commensal.
No, no. See, there's no question of, RADT, the RADT, clinically, if it is fitting in, you must remember, 5% of school-going children can be carriers of streptococcus. They can have RADT positivity and culture test positivity. But if this clinical scenario, it is fitting in, the recommendations are that don't waste money on cultures. You straight away start giving antibiotic. What is the idea of giving antibiotic? There are 3 benefits. One,
I agree to the antibiotic. I was wondering about RADT.
Rajesh,
So my point is, I'm asking a question. We were 50-50 on viral versus group A. Now, if I get a RADT positive, can it be a situation where this is a viral throat infection with a RADT which would have been in a community setting?
It can be. You are right. It can be. RADT does not have 100% specificity and sensitivity. It is agreed upon. With the clinical background, you want to treat because one, you want to prevent rheumatic fever and glomerulonephritis. Second, within 24 hours of antibiotic therapy, the child becomes non-infectious. You can send the child to school. Third, if there are others in the community or in the house who are prone for such post-streptococcal complications, it will be prevented. These are all the benefits. But that doesn't mean any child with RADT positivity, you can swear it is infection.
So
it has
that is
also got false positives.
That is the point Sham was trying to make. Unless your pre-test probability don't.
Yes, Vijay, let me come in.
Yeah.
Vijay, I think I agree with Dr. Rajesh.
Yeah.
I think if you are not sure clinically it is viral or bacterial, then your RADT is not going to help you. I agree with Rajesh. If Rajesh wanted to mean this,
but
I think you have to be.
No.
For example, just a minute. Let me complete. Now, in this patient, you said the lymph nodes, jugulo-digastric lymph nodes are not there. In this patient, everything else is fitting into the center criteria. Doing this RADT and then bailing you out that this step is quite okay.
That is what happened, because this child did not have any other features of a viral illness. His age was fitting, his throat pain as presentation, his exudates, everything else was fitting. And it was not a frank gas or your standard typical gas.
You should not be doing RADT if the Centaur score is 2 or less.
Correct.
Absolutely.
If the clinically overall you feel it is viral, you don't do RADT.
If it is very high, I don't need the RADT.
Absolutely.
4 and 5, you can treat clinically or do RADT.
So 4, 5 you don't need. Okay, let's move on to the next case. 9-year-old boy from UK. He had traveled from UK about 15 days ago. Came with high fever for 4 days. Interfebrile, he was okay, used to be okay. Vomiting for first 2 days, then he stopped vomiting. Had loose motions for a day on the day of admission. He had severe calf pain. He was a little uncomfortable walking and standing. Was dizzy, preferred to sleep, but was conscious and received a dose of ceftriaxone amikacin as he was hospitalized to a nursing home and then transferred to our hospital. His counts done on 20th were 12,000 with neutrophilia, platelets slightly on the lower side. On 22nd, that is the day of presentation, his counts were 8,000, CRP of 100. Child had a little flushing, liver was 2 centimeter, non-tender, and this child had traveled to Igatpuri and had gone on a trail, and he had a bite mark. Why is this picture not seen here? Can you see the picture there? There is a picture here. There is a big a rash on the thigh, posterior thigh, which was like a target lesion, like a bull's eye with central
I can't
clearing.
see.
No, it's not seen here also, unfortunately. Why is it not seen? I don't know. Can you just escape and go to slideshow again? There's a beautiful rash which is seen. Not seen? Unfortunately, the picture is not seen. I don't know why. Anyway, there was a typical rash on the posterior thigh, which was slightly raised, central clearing, like a bull's eye, something that one sees in Lyme disease, if you have heard of Lyme disease. And this is what the child came with. He was a little drowsy, would prefer to sleep. And on admission, we got his counts done. CRP had risen to 226. His OT was 86, SGOT. SGPT was 51. Creatinine was 1.34. And this child, we thought, with this history of having traveled to Igatpuri, we put this child on doxycycline. What are your thoughts on this case, Dr. Bala? Unfortunately, I'm unable to show you. Let me see.
It's okay.
While you speak,
it's
I'll
okay. It's okay. See, two or three things are striking. One is that it's an acute febrile illness with an erythematous rash, which is localized to one place. And I don't know whether there is any hemodynamic instability. Vijay? No hemodynamic instability.
Stability, except he would prefer
no
to
shock.
sleep.
No shock. No shock. Okay, if there is no shock, then I'm not going to think of, see, the moment there is shock in a child with rash, I'm going to think of sinister conditions like toxic shock syndrome, right? Due to streptococcus or staphylococcus. This doesn't look likely. On a similar note, there is not much of thrombocytopenia. There is no hemo concentration. I'm not going to think of dengue. I'm going to think of the following possibilities. One is that scrub typhus rickettsial infection, which is notorious. That is one possibility. Second, I don't know whether it is some staphylococcal infection. Locally, that rash, I don't know whether there is any induration, cellulitis. Secondary to that, the child is developing staphylococcal bacteremia and shock. Third, even though there is a rash in this child in India, anybody who has fever for 4 days, diarrhea, fever, definitely I will think of enteric fever also. Other than this, I don't know. I don't have enough data here to say this is a particular condition. So leptospirosis during monsoon times, we always think of, and leptospirosis is going to respond to any damn antibiotic. I'm going to anyway give antibiotic to this child after taking culture. So I won't bother much about the diagnosis of leptospirosis. And as he said, Lyme disease, I have not seen a single case so far, Dr. Vijay, so far in my career. The other conditions which can cause rash like this, rarely, ecthyma, pseudomonas infection causing necrotizing fasciitis and things like that. I don't know what is the type of rash.
I'll tell you, the thought of Lyme came in mind because he had traveled from UK. But we treated his, it looked like a tick bite. And that's the reason with 4 days of fever, preferring to sleep, sick looking child with high CRP and marginally raised SGOT. We empirically put this child on doxycycline. His NS1 was negative. But this could, there are a lot of cases of dengue around. So day 4, the child became afebrile a day later after starting doxycycline. Well, it can happen in rickettsial fever. However, even other viral infection would become afebrile on day 4, many other viral. Only point against was his CRP was very high, 226. So we treated this child as rickettsial disease. We sent his scrub IgM after 7 days, which was negative. We sent molecular diagnosis, PCR for rickettsia, it was negative. This is the rash. This is the rash.
I don't know. I've not seen erythema marginatum.
So this is on the posterior thigh with central clearing. It looks like, typical target lesion, bullseye rash, which one gets in Lyme disease. And the child improved. We gave IV fluids, we gave doxycycline. About 36 hours, the child was afebrile. Finally, we discharged him. He flew to UK yesterday. Sham, your comments on this?
Since when he is in India?
Pardon? 15 days.
How long he was in India before this illness?
15 days.
Um,
He left yesterday. So total stay in India was 3 weeks.
I think Lyme disease see, it doesn't fit into Lyme disease presentation. They tend to have more of, I think, if I read the literature in the past, facial paralysis. They tend to have a lot of nerve pains and all that, and multi-system involvement. And this rash, I agree, target lesion, central clearing, and then surrounding erythema. But I'll say I'll put it as scrub typhus as number one. He has gone in a trail. And even if query Lyme disease was there, you're treated with doxycycline and be happy.
Yeah.
Dr. Vijay,
Yeah.
but,
Bala.
in Chennai, the incidence of rickettsial infections is so high. Any child, whether there is rash or eschar or not, we are not sure whether it is enteric. Fever is there for 7 days. Liver, spleen, some elevated enzymes, CRP, urine showing some abnormality. Ceftriaxone, of course, is a must.
And
We always add doxycycline.
doxycycline.
And in fact, we don't discontinue doxycycline even if the IgM is negative. Now we have started doing PCR for scrub typhus rickettsia, and we have picked up at least a few cases where IgM has been negative and PCR has been positive.
Bala and Sham, my dilemma was, first of all, is serology and molecular, everything came negative for scrub typhus. If you look at the duration of doxycycline, it is about 7 days for rickettsial disease, and it is 14 days for Lyme disease. So that was the issue. We erred on safer side. We discharged the child on doxycycline, ask him to continue doxycycline, and he has gone back to UK. Okay.
In fact, we have picked up scrub typhus in quite a few children who had eschars, whose IgM was negative. From the eschar, we have proven scrub typhus by PCR.
Okay, this is a 9-year-old boy.
Dr. Bala, in your experience, how sensitive is this IgM scrub typhus?
Scrub typhus, first 5 days, it won't be positive. And it has got the kits that are available, they say they have a specificity and sensitivity of around 75%. In fact, if you, again, like most other serological tests, if you want to prove, you must do IgG antibodies paired sera after 4 weeks or 2 weeks.
No, but Dr. Bala and Dr. Sham, I had a word with Winsley Rose, who see a lot of, rickettsial disease in Vellore. If the pre-test probability is high, they say Will Felix is also a good test to go by.
They are doing it in Vellore. I'm afraid if you look at textbooks, it's an outdated test.
Yeah, but
it's outdated. In fact, I remember reading
I agree.
Saying it is an outdated test.
Yeah. Okay,
I agree. I agree. We discussed with Winsley. He also says after 7 days, Will Felix is quite reliable.
Yeah, quite reliable. Yeah. Okay, let's look at this boy, 9-year-old. He presented with right side pain in the right side of the neck. This worsened over 48 hours with restriction of movements of the neck. Developed fever a day after he started coming of the neck pain. No, the parents noticed a swelling on the right side of the neck. And there's redness over the swelling because the father had applied the belladonna tape. On the neck. This is how it looked. The father and the boy were playing the previous day WWE, and he had put him on the bed, and that is when he sprained his neck. And this child, since he started developing fever, went to a pediatrician who had started this child in co-amoxicillin. This child developed a rash, something like this, which disappeared in 24 hours. Next day, the child continued to have fever and pain in the neck, was looking sick, was taken to the pediatrician again. She did some tests, marginally elevated, 12,480, CRP of 415, ESR of 40. I don't know for what reason she did, but IgE was done, which was 33. She got a neck USG done because there were multiple nodes palpable, and even not palpable. He had node on the right side, and the USG showed multiple cervical lymph node, which were hypoechoic, suggesting necrosis, early necrosis. She sent throat swab for culture, which showed GPC in pairs, group P, gram-positive cocci. Even the sputum she had asked for, that also grew gram-positive cocci in pair. So this child looked sick, though hemodynamically stable. We started this child on vancomycin, thinking that whether dealing with some, septicemic illness, toxic, he looked very toxic. So vancomycin, clindamycin started. With rash, we had to discontinue vancomycin, and he was changed to linezolid and ceftriaxone. We wanted to, because with linezolid, we thought if it is streptococcal, it's better to adhere to ceftriaxone. So at admission, the child was sick, tachycardic, had cervical lymph node. They were right-sided, multiple tender lymph node. Left side, there were a few lymph nodes by the time we examined the child. He had chapped lips, congenital congestion, no eye discharge, and liver was 3 centimeters and tender. This is how the child looked. What were we dealing with? Sham?
I think even if the age is little, 9 years, I think age.
9 years, 9 years.
9 years. But still, I think I'll consider this is in recent past.
Recent past, 2 weeks ago.
Okay.
He had his follow-up yesterday only.
Yes. I'll put it as Kawasaki disease, most likely.
With very high CRP.
I think necrotic nodes you are concerned. I think I will be uncommonly, you may see necrotic nodes in Kawasaki as well. So this fits into Kawasaki.
See, the point of, the dilemma was, first the presentation was neck pain and a node as a presentation of Kawasaki. We were baffled with necrotic nodes and the age of the child, and not that we saw, we did not see many Kawasaki's in the recent past, last couple of months or so. But
I think Vijay, I think the things have been complicated by maybe belladonna tape, because some children do develop irritant dermatitis to it. Was this throughout this rash was tender?
Rash wasn't tender.
So it could be irritant dermatitis, and it's usually pruritic also.
Maybe that could be the neck area, but he did have rash which disappeared on the trunk and the thigh. The rash disappeared, maculopapular rash.
So transient rash in Kawasaki is known.
Yeah. And the congenital congestion with perilimbal sparing and this red tongue, glossitis, and cracked lips. We thought of, ultimately we treated him like Kawasaki. We got an echo done and we showed coronary dilatation with, in fact, aneurysm in the RCA. The small aneurysm.
That is uncommon in bigger children, aneurysms. Mm-hmm.
Yeah. So Dr. Bala, this kind of pain and node as presentation of KD, fever appearing on second day. What are your comments on this?
First of all, we had published in PID journal our own experience with a child who had Kawasaki, who had abscess. The cervical adenitis gave rise to suppuration. We grew staphylococcus from the pus. The most important things that you must remember about Kawasaki is very difficult to diagnose Kawasaki above 5 years. One, because we don't think of it. Second, because the typical irritability, which is very frequent in infants, and the typical features don't occur in older children. Third important point you must remember, if you go to the literature, you find that nearly 30% of Kawasaki are associated with some infection. But we have seen pneumococcal pneumonia, you have seen streptococcal bacteremia, we have seen staphylococcal adenitis, and we have seen mycoplasma pneumonia in association with Kawasaki. So in presence of infection does not rule out Kawasaki. This child had staphylococcal infection that is well known to coexist. Of course, viral infections are known to coexist. The other important point you must remember, interesting point, is that you see the tongue. This is a typical strawberry tongue. When it comes to strawberry tongue, we must remember two types of strawberry tongue. One is a white strawberry tongue and the other is a red strawberry tongue. The white strawberry tongue, which occurs first in scarlet fever, later becomes red. So you must ask the parents, if they come to you with strawberry tongue, whether the strawberry was white earlier and red now. If that is the case, you may be dealing with scarlet fever rather than Kawasaki. That is one. Second, there are multiple causes for strawberry tongue other than Kawasaki. Interestingly, other than scarlet fever, I believe you can get this sort of strawberry tongue in a peculiar infection. I've not seen a case, but it is very well described in literature. Yersinia pseudotuberculosis. If a child has strawberry tongue and pain in the appendicular region, and you do an ultrasound, the ultrasoundologist says appendix is normal, but you have lymph nodes. I've seen a few cases, but I have not been able to grow the organism. I believe it is like brucellosis, very difficult to grow. Yersinia pseudotuberculosis, that's one. Other important condition in infants, where if you have a strawberry tongue and fever, please look at the anal region of infants. The reason is, the child without diarrhea, if there is erythema in the anus, like BCG erythema, that is nothing but Kawasaki. In fact, we have picked up cases of Kawasaki on day 2, 3 with this perianal erythema and BCG erythema in young infants. These are all protein presentations of Kawasaki. The other important point you must remember, if this had happened in 2022, I would have thought of misc rather than Kawasaki. Because the phenotype of diffuse rash, phenotype of abdominal pain, phenotype of strawberry tongue with coronary aneurysm can also occur in misc instead of Kawasaki. But in 2024, this is KD for sure.
Well, an interesting question to Sham. Sham, we know COVID is over, but we keep getting COVID. We had a few cases about a month or 2 months ago. And in post-COVID era, given the age, would you ask for COVID antibody in this patient? And how do you rule out misc in such?
I won't get it done. I think everyone is COVID positive, particularly this child. And I think I've written the obituary of misc.
Thank God, Kokruja. I was worried whether you're going to say I will do antibodies.
Okay. A very interesting dilemma, very interesting case. 22-month-old girl crying when passing urine for 6 days. Since 6 days, she was crying. She had fever of up to 100 for 3 days. And when she came, she had stopped having fever. She was afebrile for over, say, 36, 48 hours. Physical examination was normal. Counts normal. CRP 16, NS1 negative, RMAT negative. This is what the urine showed, 52 pus cells, nitrates positive, Ale positive, leukocyte estrase positive, bacteria plus, but it was not done on freshly voided sample, so I disregarded that. But nitrite and Ale were positive with 15 to 20 pus cells. And there was definite history of dysuria. How do you take this patient? Sham, would you ask for culture at this point in time when the child is afebrile, but the urine shows?
Yes, I think the symptoms and the routine examination is quite suggestive. I'll definitely go for urine culture.
Okay. Would you start this child on antibiotic or will you wait for the culture?
See, the presentation wise, it looks like cystitis. And a short course of antibiotics may be started, or I think there's no hurry if the patient is not so much of symptoms. I'll wait for the report.
Yeah.
Child has become afebrile now.
Child has become afebrile.
Okay, acha, for last 2 days afebrile.
Yeah.
So okay, I think
what
about I'll be concerned about the pain while
what
passing.
About the dysuria? That also settled. So that symptom of dysuria disappeared. Child was afebrile, but had definite fever and definite dysuria. Child is afebrile.
How the genitalias are?
Normal. I mean, there is no vulvitis and mother is not
no
obsessed
vulvovaginitis. Okay.
No vulvovaginitis.
Okay.
And so she comes back after I advised urine culture, did not start antibiotic, but the child was afebrile and looked like simple UTI if at all. And the mother came in 4 days later with this report. E. coli, colony count more than 10⁵, urine collected by a clean catch method. It was collected pretty well because we spend a lot of time in explaining the parents, and very many a times we ask one of our residents to collect the urine. Child is normal. Now what do I do?
Okay. I think in this situation, I think you can treat for about 3 days of antibiotics with a drug which is showing a lot of sensitivity. Most possibly it is cefaxime for 3 days, and that's quite okay.
So 3 days is enough cefaxime. Bala, would you give antibiotic and 3 days?
Before that, a few comments.
Yeah.
One, the fundamental fact pediatricians often forget is that below 3 years of age, UTI need not have symptoms referable to the urinary tract. So your dysuria, increased frequency, urgency, loin pain, they are all symptoms of UTI in children above 3 years.
But this mother was saying the child used to cry.
I'm coming to that. That's a fundamental point. This is one. Second, if you have features of urinary infection below 3 years of age, unless proven otherwise, that urinary infection is upper UTI for me rather than lower UTI. Cystitis is not a common diagnosis in an age group of 22 months. So even though there is no fever, I would consider this child as having a strong possibility of upper UTI rather than a diagnosis of cystitis like in an adolescent. Point number 2. Point number 3, in this child who's symptomatic, who has got significant pyuria, I would have considered giving antibiotic to this child with the urine routine report after giving a culture. And again, now we all know that the colony count has been moved down to 10 to the power of 4 today, even in clean cash from 10 to the power of 5. In fact, it is interesting to note that this 10 to the power of 5 is not a pediatric number at all. It is an adult women guideline. Unfortunately, since for want of anything else, we have been following 10 to the power of 5. Now we moved it down to 10 to the power of 4. In this child, definitely I will give an antibiotic, and I will not give an antibiotic as lower UTI. I will give an antibiotic only as upper UTI, oral antibiotic, and keep a watch on this child. Of course, as Shyam said, I will look at the genitals, look for vaginal synechia. I'll look for history of constipation or bowel bladder dysfunction, look at the spine, look at the anus, and find out about antenatal scans, then proceed further.
Dr. Bala, I have a few points. You say your point well taken. Younger child you treat as complicated UTI. Fever of only up to 100.
It doesn't matter at all.
Counts normal.
It doesn't.
Normal.
It counts.
CRP not
See,
high.
counts need not be abnormal in pyelonephritis. Fever need not always be high in pyelonephritis. I think that they're all myths. UTI below 3 years to me is upper UTI unless proven otherwise.
But here there are symptoms pertaining to lower urinary.
No, even if there are symptoms, you cannot differentiate between upper and lower UTI clinically. Just based on low-grade fever and minimal symptom. That is what literature says.
Are you saying a pyelonephritis in a 22-month-old child with fever not
No,
crossing
I am not
100?
saying this is pyelonephritis. I am saying I cannot distinguish between lower and upper UTI. Unless proven otherwise, I'll treat this as upper UTI
Okay,
only.
you will treat it as upper UTI. Okay,
That's all.
fine. So this child antibiotic we treated with cefaxime, but I did not use it for 14 days. And
that's acceptable. Vijay, again, like many other diseases, the duration of antibiotic therapy, even for pyelonephritis, is coming down to 7 days rather than 14 days.
And then
See, the other point, Vijay, the other point is the cystitis is known to self-resolve. But pyelonephritis, little unlikely. Little unlikely. I won't say it cannot. It cannot.
But remember, considering the consequences, you cannot afford to ignore.
So Shyam, from what I understand, Dr. Bala is saying, though these may not be suggestive of UTI, given the age and the consequences, he would treat this as upper UTI. I mean, complicated UTI. Okay, you would definitely follow this child with imaging or no?
Certainly. In fact, the recommendations say, in the United Kingdom, if this, in fact, our own nephrologist, I'll tell you what our nephrologist thoughts are very, very unconventional. In the United Kingdom, they say first UTI, if the antenatal ultrasound has been normal, there is no need to do any imaging monitor. That is what the UK guidelines say. On a similar note, our own nephrologist in our hospital, Dr. Sairam, he says, in a child like this, if the antenatal scan records are available and if they show there is no anomaly, clinically nothing is there, don't do an ultrasound during the acute phase. He says do it after 2 weeks. Otherwise, during the acute phase, many a time the radiologist will report mild dilatation, mild edema of the kidneys, suggesting pyelonephritis, and you will be unnecessarily doing reflux studies and DMSA, etc. This is his unconventional opinion, but that is what some urologists in UK and USA do today.
And I believe there is no rule of repeat urine routine.
Vijay, would a urine routine have helped at the onset of your antibiotic therapy when you did it after 4 days?
Would that really change your decision to treat or not?
Suppose the urine was bang normal at
Then
that
also,
time.
would you not treat, having grown E. coli on a clean catch sample? That was the whole point of discussion. So you repeat urine.
See, in this child, if the child comes back after 4 days with a urine culture like this, okay, if the specimen had been corrected properly, if your data is correct,
absolutely.
What I would do is to give antibiotic definitely. Whether, and again, the timing of USG, in India, I would perhaps consider doing an ultrasound straight away because you don't know the competence of the person who has done in the antenatal period or earlier itself. So I would definitely ask a pediatric ultrasoundologist to look for clue. In fact, this child might well be having a renal stone disease, maybe having a vesical calculus, which is causing cystitis and a UTI. So I wouldn't want to miss it. So I would do an ultrasound abdomen. Regarding the repeat urine routine, see, if at all these reports are correct, I wouldn't repeat anything. Straight away, give a course of antibiotic, do an ultrasound and monitor the child.
By the way, this was a true case, nothing fabricated, and the reports were genuine. And urine culture was from a clean catch. Okay, in the interest of time.
Vijay, I think,
Yeah,
Vijay, I'll recommend, because the pediatric nephrology chapter has brought out latest recommendation after 2011, now in 2024. I reviewed that paper. I was asked to review this paper by a practitioner to see what do you feel. And I gave a lot of comments on that. But here I'll put it like this. I think everyone should go through that. There's no time to discuss that paper in detail. But it's a very good paper and gives very enlightening information regarding the new ideas of UTI.
Sure. So 2024 guidelines. I will just read the content on the last slide. I mean, there are more slides, but we'll wind up here. Because UTI is something which is very often over and under diagnosed and not treated properly. Many of us don't spend adequate time in counseling and telling the parents how to collect urine. That is something that we need to invest our time in. This is a 8-month-old boy, high fever of 103, no other signs or symptoms, clinically active, playful, very high count. Most of the infants with high fever, with chills and very high count, most of them turn out to be UTI. But this child was absolutely normal and was afebrile the moment we admit the child. Next, the child went home. Similarly, this is a child who was treated for dengue, was hospitalized, and this child had 50 to 20 pus cells per high power. LE was positive, and even the nitrate was positive. We did not do anything, and the child improved. So UTI is something which keeps baffling. We need to be extremely careful not to over or under diagnose UTI. We need to really spend some time and explaining to the parents how to collect and what is the importance of treating urine tract infection in time. Well, with this, I would stop here. There are many cases, but for want of time, we'll stop. Dr. Sham Kukureja was with us from Denmark. And Sham, let me tell you, the quality of AV is so beautiful that we did not feel that you were away from us, thousands of kilometers away from us. It was so clear. And your comments were very crisp, very wonderful, and we had a lot of learning from you. And my friends here would agree with me that Sham was as clear as ever. And we really enjoyed, at least I learned a lot and I enjoyed this session. I thank Dr. Bala also, and I thank this wonderful audience for sitting through the day and being attentive and alert till the very end. And I also thank my virtual friends who have connected us virtually from other centers. And I maybe last 2 or 3 minutes, if there are any questions or comments from Lucknow, Delhi, Hyderabad, Chennai, Kolkata.
Hello.
Are there any comments or questions from any of the virtual centers?
Chairperson for the event, and I really appreciate for your patience and thank you for attending this event and making it a successful program. And in future also, we would definitely come up with such scientific programs to encourage the practices of the pediatricians. So now I would like to request Mr. R.C. Jha and Mr. Abhijit Singh.
Any other comment from any other center? If no, I once again take this opportunity to thank each one of you for being with us. And I thank the Alkem team and hand it over to them for a vote of thanks. Thank you.
So good evening, everyone. I stand here on behalf of Alkem here. And certainly this Sunday has been the knowledgeable Sunday rather than a relaxing Sunday. That is what the feedback. And very glad to share with you across the country, more than 1,200 pediatricians have attended this event. So on this behalf, I want to take a great opportunity to thank Dr. Vijay Yavle for his coordination of this event, Dr. Amdekar, Dr. Rajesh Chokani, Dr. Jagdish Chinnappa, Dr. Prakash Vaidya, Dr. Balasubramaniam, Dr. Upendra, and Dr. Sham. So this has been a wonderful, and also take this opportunity, a big round of applause to Team Alkem, especially the marketing team and the field force team, making this event very, very successful, not only in Mumbai, but across the place, wherever this event is there. So thank you so much once again. And certainly this event has come from the makers of Taximo, Switch, Clavum, and request all of you to continue your valuable patronage for our brands of Alkem, the #1 anti-infective company today. Thank you very much. Have a great week, Sunday once again. Thank you.